ear because of disease somewhere else. Because the middle ear and the external aortic canal are supplied by sensory supply by trigeminal nerve, posteriorly cervical plexus of nerves, and then glossopharyngeal nerve, and then vagus. So these are all the branches that supply the external aortic canal and middle ear. So any disease in the other parts of the throat that may cause irritation or infection, so the pain will be felt in the ear, though the ear is normal. So in that case, you have to search the other areas, like any patient is having any temporomandibular joint tenderness, any throat infection like tonsillitis or ulcers in the throat, or any sometimes CA, tongue, or dental impaction or dental caries. So all these patients, they come with pain in the ear, though there will not be any pathology in the ear. So you should be careful to look for all the other items. Sometimes we do diagnose the condition when the patient comes to us with a pain in the ear and nothing is there. And then we find out some of the pathology and then we refer to the concerned people. Next is ear discharge. So these are the type: watery discharge, or mucopurulent, or purulent, or sometimes blood stain discharge. So watery discharge you will get only in case of automycosis. So as I already told you, when you examine, you can see the fungal debris in the external aortic canal. Or it may be a mucopurulent discharge, that is mucus and purulent combined. You can see in the ASYM cases, congestion is there, and then after burst you can see some ear discharge is there in the ASYM. And then typical CSYM, mucopurulent, you can see the discharge pouring out from the external aortic canal. And the other type of CSYM, that is the atticoantral type, always associated with cholesteatoma. You can see white cholesteatoma debris in the external aortic canal, usually in the posterior superior aspect or the aortic region, and mostly it extends into the mastoid, causing sometimes intracranial or intratemporal complications. So when you see any ear discharge, so first of all you should see whether it is a safe type of ear discharge or is a automycosis. So if it is a mucopurulent discharge with a perforation, then it has to be dealt with surgery. That is reconstruction of the tympanic membrane. Meringoplasty has to be done after control of the infection. As I already told you, atticoantral type of infection always spreads to the mastoid bone. So you have to do wide exploration of the mastoid, clear the disease from the middle ear and mastoid, and reconstruct the tympanic membrane, and if necessary, the ossicles also. So bloodstream discharge, again you can see burst furuncle or carcinoma of the ear, very rare. And then ruptured drum, ear drum. So most of the times you will see slap injuries of the over the ear causing bloodstream discharge and then tinnitus. The patient comes to us. So in those cases, please don't prescribe any ear drops. Traumatic perforation of the tympanic membrane, ear drops is contraindicated. But usually what you do is when you come, you prescribe some antibiotic drops. Carry some infection from outside into the middle ear. So the thing you have to remember is any traumatic perforation, if you are encountering, if you see after injury any bloodstain discharge, please don't prescribe any drops. You put them on antibiotics and then wait for some time and then see for radiographic testing and other things so that you prevent the secondary infection and facilitate the healing of the ruptured tympanic membrane. Then cholesterol also, sometimes there will be a granulation formation and result in blood stain. Whenever the patient cleans the ear, you will see the blood along with the discharge. That's a blood stain discharge. So these are the conditions you should keep in mind. And ASYM you can treat with antibiotics and upper respiratory tract infection. Whenever there is ASYM with a perforation, it always needs reconstruction of the tympanic membrane after clearing the active infection. Surgery is the rule. So more so if it is associated with a cholesteatoma, because the patient is likely to go into intracranial complications also. Then next complaint is hearing loss. If he comes with, sir, I'm not able to hear. So you should ask the duration also when it started. Is it a long standing or short term? Or is it associated with pain? Or is it associated with any discharge? So there are mainly two types of deafness. One is conductive deafness. That is, something is obstructing for the sound to be conducted to the inner ear. Maybe the block may be in the external aortic canal or middle ear, or it may be in this inner ear. That is, sensory cells in the inner ear may be damaged, so thereby the patient will not be able to hear. Or sometimes it may be a mixed combination of both. So what are the why you see the conductive deafness? It will be recent onset only. So on examination, if there is impacted cerumen is there, naturally you will have some blocking sensation. Likewise, in ASYM, when there is collection of pus in the middle ear, CSYM, when there is perforation in the tympanic membrane, and one more condition, serous otitis media. Here, the tympanic membrane will be normal. History of upper respiratory tract infection will be there. Because of eustachian tube block and negative pressure developing in the middle ear, there will be a collection of fluid in the middle ear. So if you see autoscopic examination, the tympanic membrane will be hazy. It will not be natural luster of the tympanic membrane will be lost. And if you do hearing test, there will be conductive deafness. So for this, you have to remove the fluid that is collected in the middle ear. Tympanic membrane will be normal only. So meryngotomy, just incise the tympanic membrane and suck out all the thick mucoid secretion that is collected in the middle ear and put a gromate. Then the patient will have the normal hearing within a week or so. So these are some of the conditions which causes conductive deafness. So for some, we require surgical management. The other thing is sensorineural deafness. If it happens by birth, then the patient cannot acquire speech because he's not able to speak, not able to hear. So he will be a deaf and dumb child. So such children should be identified. And nowadays we are doing cochlear implant operations for such bilaterally deaf sensory neural deafness children. So the best age is we can do at the age of 2 years so that he can acquire the normal speech as a normal child. So the earliest, the best is the rule now, and they are doing a bilateral cochlear implantation at the same sitting also. Next, acquired sensorineural deafness occurs in eighth nerve tumor as a process of old age in degeneration of the nerve cells in the inner ear. And sometimes some drugs also cause deafness like streptomycin, kanamycin, and some diuretics. So you should be vigilant. And these drugs should not be used for a longer time. And when you are using, you should have a audiological evaluation whether there is any hearing effect is there or not. So for acquired hearing loss, the only acquired sensorineural hearing loss, the only solution is a hearing aid. Then otosclerosis is one more condition which may have usually in the beginning only is conductive deafness. Usually it runs in families. There will be associated tinnitus also. So this can be dealt with either by surgery, that is stepidotomy. You remove the fixed stapes and then put a piston. Or you can use a hearing aid also. Hearing aid also gives good result in otosclerosis. So one more important point I would like to bring to your kind notice is sudden sensory neural hearing loss. This is also one of the condition. The patient goes to bed. By the time normally, by the time he gets up, he finds he is no longer hearing in 1 year. So this is called sudden sensory neural hearing loss. It is a medical emergency. If you can do something within 72 hours, the patient chances of regaining his hearing is 50 to 100%. So never say any patient coming with sudden hearing loss, oh, you can wait for some time, then we look. So always, when a patient comes with a sudden hearing loss, always better to evaluate. And if it is sensory neural hearing, maybe some viral etiology, we don't know, by giving an intratympanic steroid injection once in 2 days. In 3 to 4 sittings, we have seen many patients recovering up to 50% to 100% results also. So don't neglect this case. Any patient comes with sudden hearing loss, please advise audiological evaluation and if possible, intratympanic injection also, so that he can regain his hearing loss. Then coming to vertigo and giddiness. So most of the people think whenever the patient comes to you, whenever vertigo is faced, you feel that is a neurological condition. First, you feel like sending him a neurologist rather than a ENT person. But on the contrary, the causes, if you take up the cause of vertigo, the common important cause for vertigo is labyrinthine vertigo, rather than neurological conditions. About 60% of cases are peripheral vertigo involving the vestibular. Only other things are neurological involving the brainstem and other things. So vestibular labyrinth, the most common conditions we encounter are BPPV, benign positional paroxysmal positional vertigo. Here in the patient feels giddy in some particular position of the head, whether lying down in bed or if it rolls to one side, you'll get severe giddiness. It lasts for a few seconds only. Again, the patient will be normal. And whenever he assumes that position, he will get the giddiness. That is called the benign paroxysmal positional vertigo, which is a curable condition by doing some maneuvers. So, any giddiness lasting for seconds only, and again the patient becomes normal. And whenever a patient is kept in that position, if he is getting that giddiness, that can be cured by a maneuver. Then vestibular neuritis, again, it is due to infection involving the vestibular ganglia. So it is a severe form of vertigo. There you get the giddiness as well as the vomiting also, and it will last for days to the weeks. Sometimes it may last for weeks also. You should give some steroids and antiviral agents. Then another important condition is Meniere's disease. Meniere's is characterized by giddiness, then tinnitus and hearing loss. Hearing loss also will be fluctuating. It increases and sometimes decreases like that, fluctuating hearing loss, giddiness, and sometimes there will be associated vomiting and nausea also. So in these conditions, you should advise the patient for audiological evaluation, and then in the diet, salt restriction is very, very important. Then even in CSOM also, when there is cholesteatoma, erosion of the bony labyrinth, exposes the membranous labyrinth and causes giddiness. So labyrinthine stimulation. Whenever a patient comes with severe giddiness, this classical rotating type of vertigo, it is an ENT cause. Whenever the patient says, I feel some unsteady feeling, some type of a syncopal thing or dull-headedness, it is not ENT, it is mostly other conditions. So any patient with severe type of vertigo, alarming type of vertigo, then it is mostly 99% ENT cause only. We have to evaluate these patients by ENT surgeon. Then facial weakness or Bell's palsy, most of the time we call it as. So usually on one side, the facial nerve emerges from the middle ear and then comes out through the stylomastoid foramen. So during its journey, due to infection or inflammation, the nerve gets swollen and then results in facial weakness. So on that side, the patient will not be able to close the eye, and there is a deviation of the mouth, the angle of the mouth towards other opposite side, and even swallowing or mastication also, the patient feels the food is going to one side. So for this also, If there is an associated viral infection, antivirals, and then steroids plays a major role. So this also the treatment should be started at earliest stage so that the patient can regain in 2 to 3 weeks normal function of the facial nerve. And physiotherapy also plays a role in these patients. Then coming to the throat. Time over, huh? What is it? Throat pain, mostly you can see inflammatory conditions like tonsillitis, nasopharyngitis, then ulcers in the throat, peritonsillar abscess. You can see swollen tonsil being pushed medially and then inflamed uvula also, and parapharyngeal and these things you can see by throat examination and can come to a reasonable conclusion and treat them accordingly. Then difficulty in swallowing. Patient says, I'm unable to swallow some of the solids. I can swallow the liquids, but swallow whenever I want to swallow some liquid, I feel some feeling of obstruction. So the common condition is PV syndrome. So any middle-aged woman with gross anemia, angular stomatitis, glossitis. So these are the candidates. So for them, you have to do an esophagoscopy, and then if you find a stricture at the upper end, dilatation will help, and patient will be able to normally swallow this thing. Other thing is carcinoma of esophagus. You have to do a biopsy and confirm, and then treat accordingly. Another condition, achalasia cardia. In this condition, the patient will be able to swallow solids, but he will feel some difficulty for liquids because of spasm of the cardiac spasm of the sphincter of the esophagus. Then coming to the hoarseness of voice. Usually in any upper respiratory tract infection, we get some hoarseness of voice, but usually it should last for 1 week to 10 days. If any patient having persistent the hoarseness of voice, please look for any lesion in the vocal cords. See, these are the vocal cords. You see bilaterally is the vocal nodules, and this is the polyp, and this white thing is carcinoma of the larynx, and their vocal cord paralysis. That is, one vocal cord is moving, other vocal cord is not moving. Thereby, phonatory gap will be there. So, normal voice will not be there. So, all these things have to be evaluated. So, any patient hearing harshness of more than 1 week or 10 days, they have to be evaluated. Then coming to nasal obstruction in the nose, common condition, deflected nasal septum or nasal polyps, sometimes growths, either a benign growth or a malignant growth. And other common cause is nasal allergy, where the most of the mucosa will become boggy and edematous, causing nasal obstruction. And accordingly, you have to, suppose deviated nasal septum is there, septoplasty, polyps are there, polypectomy. Now, polyps have been done by using a debrider, which is very effective in removing the polyps without much bleeding and other things. So, if there any growth is there, we have to do biopsy and confirm. Then sinusitis also. Nowadays, the results are very good using a debrider. We can open the sinuses and clear the disease from the sinusitis. The nasal allergy. So, the best part is you can prescribe a nasal fluticasone nasal sprays, cortisone nasal sprays along with antihistamines. They will give good results. If there are any recurring problem, always better to refer to an ENT surgeon. Then nasal discharge also, watery nasal discharge you will get in nasal allergy, sometimes in CSF rhinorrhea cases. And then mucoid and mucopollen discharge in sinusitis cases. Whenever there is a blood stain discharge, you have to suspect any malignancy or tumors in the nose. And headache, as usually sinusitis is also one of the causes for headache. And by doing relevant CNS, CTPNS, we have to treat the condition. So disturbance of smell, sometimes anosmia, sometimes hyposmia, because all these nasal conditions at the viral rhinitis, nasal polyps, allergy. So this has to be evaluated, and If you will be able to remove the obstruction, sometimes the patient will regain the smell also. Then coming to the foreign bodies, foreign body, nose, throat, and ear. Usually, foreign bodies in nose and nose and ear will be children. So you should be very, very careful in dealing with foreign bodies. I have seen cases foreign body ear, a small stone or a this slate pencil like that things kept in the chair, and you try with a foreign body hook and will be pushing it to the middle ear also. Sometimes we have to open post-auricular region to extract that foreign body from the middle ear. So it is not very easy because children will move. They will not keep without movement. So now always try syringing. Foreign body ear, first you try syringing. If you are able to remove it, okay. Otherwise, don't put any foreign body for forceps to remove them. You will be invariably injuring the tympanic membrane, causing more trouble. Similarly, also nose also, if you are able to see clearly, you can try. Otherwise, blindly, if you try to remove it, there will be bleeding, mess of things will be there. Other again, you have to. So in all those cases, under general anesthesia, better to try for children or children. Foreign body throat, if there is any fish bone or any this thing, we can try by video laryngoscopy and remove it. Or any chicken bone or coins, we have to give general anesthesia and remove it. So these are the things I would like to bring to your so that you will have some points for general practice. Thank you.
Very nice lecture, sir. Enriching insights. Now I invite Murli Krishna to present memento to the. In Tirupati. Its affiliation is Skin, Hair and Laser Center. Areas of interest is acne, aesthetics, energy-based devices, lasers, pigmentation disorders, psoriasis and vitiligo. Thank you, sir.
Good morning, everybody. it is basically a my experience kind of talk. It is not related to any specific topic. It is more of a widespread, different kind of diseases. It's going to be only my experience, all the photos, all of my patients only. My topic today is difficult to treat cases and their response to newer therapies and procedures. What do you mean difficult to treat? It may be the complexity of the disease, it may be resistance to standard treatments, or it may be the disease may be chronic or relapsing in nature. There might be patient related factors as well, because the patients sometimes they can't afford the medication, or they're very irregular in following up with the treatment. There may be side effects and tolerability and psychological and social factors as well. Last decade has seen remarkable advancements in dermatology, spanning therapeutics, technology, and personalized care approaches that significantly improve patient outcomes. These are the innovations. I just listed the innovations actually in this, like commonly used things nowadays are biologics, laser and light therapies, and their small molecular drugs like Apremilast is available now, regenerative medicines like PRP and GFC, and teledermatology and expanded access to care. The following slides show the evidence of response to the mentioned innovations in the treatment. It is not in a particular order. Alopecia areata, alopecia totalis. What is the alopecia areata management? Generally, we do the first line is intralesional steroids, topical steroids, and JAK inhibitors. Or second line is oral and topical minoxidil, and the third line is systemic corticosteroids, cyclosporin, and topical JAK inhibitors like tofacitinib. Is a case one. It's a male patient, aged about 22 years, presented with total loss of scalp hair for 5 years. He has used everything, no response. Started treatment and photographs taken every 4 to 6 hours. I gave oral tofacitinib along with topical minoxidil with oral minoxidil. This is the follow-up after 5 months. This is 6 months, 7 months, 8 months follow-up. This is after 9 months. Like very gratifying result where the patient never had hair for last 4 to 5 years, had a full, absolutely normal hair after 9 months. This is another case, a female patient presented with a total loss of scalp hair for 3 years, taken oral immunosuppressants and used topical minoxidil with no appreciable benefit, treated with oral tofacitinib 5 milligrams twice a day along with topical steroids and minoxidil 5%. This is the follow-up after 2 visits. This is after 4 visits. This is another case. This is also the baseline and complete regrowth. This is another case, just 7 years old kid presented with alopecia totalis of 2 years duration, treated with oral tofacitinib. It's an off-label in kids. Once a day with topical minoxidil 2%. The results are very gratifying, like absolutely almost 100% regrowth. Alopecia areata is a condition which tends to recur. Recurrence is common, but not a rule after discontinuation of oral tofacitinib. These are the guidelines. What we do, alopecia totalis is more manageable when more localized. Oral tofacitinib 5 milligrams twice a day, 10 days in a month as a maintenance dose. And like the side effects of oral tofacitinib, increased risk of thrombosis and cardiovascular events. We have to monitor LFT and RFT. My second condition, vitiligo vulgaris. Vitiligo vulgaris, these are the options we have now. The first line is topical steroids with calcineurin inhibitors like tacrolimus and pimecrolimus, and JAK inhibitors like tofacitinib. Widespread lesions, narrowband UVB plus topicals. Second line is targeted phototherapy, and the third line is surgical. Case 1, a case of vitiligo vulgaris with extensive acral involvement, treated with oral tofacitinib and narrowband UVB therapy. You see the response on the nose, on the lips, almost in the nose, there is complete pigmentation. You just see the hands. This kind of results were unimaginable few years ago. The results are very gratifying. This is another hand. It's almost like after 1 year of treatment. You see, even the food, the response is fantastic, but there is some pigment that still needs to be, I mean to say, produced, or those patches need to be covered. This is another case of extensive vitiligo, but this case I didn't do the topical, I mean to say, narrowband UV therapy, only treated with oral tofacitinib. See the response. This is after 9 months. On the foot, the response is not that great. This is a review article which says tofacitinib may be the most favorable systemic JAK inhibitor treatment option for patients with extensive vitiligo. This is another case, lichen planus pigmentosus. It's like very common due to hair color application. These are common protocols we follow for the management of lichen planus pigmentosus. Commonly, we use the topical mometasone with tacrolimus and oral tranexamic acid with oral colchicine, and regular sunscreen recommendation. The effect of Q-stitched Nd:YAG laser with pico power in lichen planus pigmentosus. The following slides show moderate to very good response of the disease with Q-stitched laser treatment. Results are consistent, reproducible, and repeatable. Whenever you do a procedure, especially in dermatology, especially with lasers, the result should be consistent, reproducible, and always repeatable. This is the dosage I followed, and this is the response after 6 sessions. See the pigmentation on the neck. There is almost complete clearance of the pigment. This is the other side after 6 sessions, done once in 6 weeks apart. This is another case. See the response. This is another case. See the response. It's a kid, actually, 15-year-old kid, extensive lichen planus pigmentosus. The response is very, very gratifying. This is a capillary macule. This is the dose I have used. This patient came from Bhimavaram, and then she was not getting married because of the capillary macule on her face. And after 6 sessions, there is almost like 70% clearance of the lesion. And recently she got married, and she was very happy with the result. Melasma. Melasma is one of the most difficult problems to treat in dermatology because, like most of the times, recurrence is the rule. This is the melasma management. The first line is the triple combination. Along with triple combination is hydroquinone, tretinoin, and fluticasone or fluocinolone. Sunscreen is mandatory. Second line is azelaic acid with glycolic acid pills and adapalene. Third line is laser. Laser is not the first line treatment for melasma. This is the dose I do. These are after 5 sessions. The response is reasonably okay, but she tried everything. The response was not there. At least she's happy with the reasonably good result. This is the other side. This is another case, acne. Acne is a very common condition we see day in and day out. The only advice to general practitioners, don't give monotherapy of clindamycin. Always combine clindamycin with either benzoyl peroxide or adapalene. This is the first line, mild acne, moderate acne, severe acne. These are the first line, second line drugs we use. This is the second line, and this is the third line. And this is the response we get, like with the condition. The response with treatment is amazing. Almost you get 100% results. This is like no procedures, only medical management only. See the kind of response after 4 to 5 months. After 4 to 5 months, this is after 3 months, this is after 3 months, this is after 3 to 4 months, this is after 3 to 4 months. And this is acne vulgaris with post-acne hyperpigmentation treated with Q-stitched Nd:YAG laser with pico power. This is the dose I use, and this is the response after 4 sessions. This is the response after 4 sessions. See, almost like there is 100% clearance. This side, see hyperpigmentation that has improved beautifully, almost like no hyperpigmentation. There is no marks at all, absolutely. See, after 5 sessions, not even a single acne is persisting. This is another side after 5 sessions. So this is the comparison between MNRF versus fractional CO2 in acne scars. This is the scarring type. We generally use MNRF in mild to moderate scars, and in the fractional CO2, moderate to severe scars. The only disadvantage with fractional CO2 is risk of post-inflammatory hyperpigmentation. But with MNRF, the risk of post-inflammatory hyperpigmentation is very less. Depth is like with the MNRF, we can go really deep, but with the fractional CO2, the depth is like 1 to 1.5 mm. This is post-acne scarring treated with MNRF. These are the advantages of MNRF. The advantage of MNRF, the risk of post-inflammatory hyperpigmentation is very less. The delivered RF energy is specifically focused at the tip of the microneedles, leading to very less injury to the epidermis. Thus, there is far less downtime and pain for the patient as compared to conventional fractional CO2 laser. This is the response after 3 sessions. This is the response after 3 sessions. Another patient, response after 4 sessions. After 4 sessions, this is another patient. Actually, he had like, you can see the response on the cheeks, the scar. The response is fantastic. See another case, the response is very, very good. The quality of the improvement is like very, very good. Post-acne scarring treated with fractional CO2 laser. This is the mechanism of fractional CO2 laser. This is after 2 sessions. After 2 sessions, almost 100% improvement is there with the scars. This is another case after 6 sessions. This is another case after 6 sessions. Striae distensae is one of the most difficult problems to treat in dermatology. What do you do generally? Second line is topical tretinoin, non-ablative fractional photothermolysis and ablative fractional photothermolysis, microneedling as well as RF microneedling we do. Third line is glycolic acid along with PDL and IPL or PRP with MNRF. This is a case of 18-year-old girl, obese. I treated her with MNRF. The response after 5 sessions is reasonably good. See the improvement in the scar around the periumbilical area. The quality of the skin has improved a lot. It's a case of nodulocystic acne with hirsutism. Whenever this patient comes to me for consultation, she always tries to cover her face because she was not willing to show her face outside because of the acne, because of the scars, and because of the hirsutism as well. She was treated over a period of like almost 9 to 12 months. I treated her with a fractional CO2 for scarring and diode laser for hirsutism along with medical management. See the response. Response is gratifying. Dermatology is definitely a transformative medicine. It transforms the life of the people actually. Androgenetic alopecia, otherwise called male pattern hair loss. What is the first line in the androgenetic alopecia? Topical minoxidil, finasteride, and oral minoxidil. Second line is dutasteride. And third line is the hair transplant. We do the PRP, GFC, exosomes, those kind of stuff as well. These are the results. Male pattern hair loss treated with oral minoxidil, with topical minoxidil and finasteride. This is the response. See the response? The response is like really good. This is like no procedures, absolutely. Only the medical management. See the response? See the response? See the response? This is MPHL treated with GFC and topical minoxidil and finasteride. See the response after around 4 to 6 months. This is also after 4 to 6 months. This is after around 6 months. So this is the androgenetic alopecia management of female pattern hair loss. The first line is the topical minoxidil and oral minoxidil, spironolactone, anti-androgen, cyproterone acetate, and even finasteride in perimenopausal and postmenopausal women. What is the second line? Hair transplant, low-level light therapy, platelet-rich plasma, microneedling, and a fractional CO2 laser. These are the results. This patient has undergone hair transplantation outside, but she was not very happy with the results. But she came to me and I did GFC 6 sessions, and the response is very good. Another case, you see this like absolutely maybe 5 years, 6 years back, these kind of results were difficult to get. Now it's like probably like almost every patient gets these kind of results. What are the tips for using oral minoxidil? The trends have shifted. Previously, we used to use a lot of topical minoxidil. Now we kind of use a lot of oral minoxidil. What are the tips? The most important thing is start low and go slow. That is very important because oral minoxidil causes postural hypotension. That is the most common side effect, postural hypotension. Fluid retention, dizziness, changes in blood pressure, and weight gain. These are the common side effects. You have to watch for weight gain, especially in females. It works well in combination with other treatments, regular checkups, BP and heart rate. Be patient with the results. Takes 3 to 4 months to become visible, and consistency is the key. Avoid in patients with uncontrolled hypertension, heart disease, or history of fluid retention. This is the concluding my talk. Advances in dermatology are essential for improving the patient outcomes, providing relief from chronic symptoms, enhancing quality of life, and reducing overall healthcare burden. These innovations not only target the symptoms of the skin disease, but also address the underlying causes and promote more integrated approach to health and wellness. And I thank the organizers for giving me the opportunity to present my experience in treating difficult to treat cases in dermatology. Thank you.
Hello. Dr. Madhav Reddy is a popular dermatologist. You have given enriched insights of dermatology problems. Thank you very much on behalf of Rajampet branch and on behalf of me.
I invite Murali to give memento to the chairperson. I am really happy and enlightened to introduce my classmate Kirti. We did PG together. Dr. Kirti did his schooling in Science School, Korukonda, MBBS at SVMC Medical College, Tirupati, and he is gold medalist in anatomy and SPM. He did MD General Medicine at Sri Venkateswara SVMC Medical College, Tirupati, and DM and DNB in NIMS, Hyderabad. He worked as consultant neurologist at Medicity Hospital, Hyderabad, Bolneni Hospital, Nellore, and Narayanadri Hospital, Tirupati. He conducted clinical trials as principal investigator in stroke, pediatric migraine, and neuropathic low backache studies.
And finally, after achieving all this experience, he started his own Kirti Neuro and Emergency Hospital at Tirupati, and he is presently working as consultant neurologist. And stage is set for you, Kirti. Please.
Good morning, everyone. At the outset, I thank the organizers of IMEA conference Rajampet branch, especially Dr. Sunil and Dr. Sarmaya Garu, and I thank Dr. Srihari for his kind words. We'll straight away go into the topic. Today, I will be talking about fits, feints, and funny turns. Though the terms are a bit vague, but for the outreach, like this is a op terminology. That's why I felt this is the ideal topic. Why I have chosen this topic is in day-to-day clinical practice, especially in the peripheries, when we directly come in contact with the patient primarily. So it's a very common presentation, and if we don't identify these conditions, we may tend to misdiagnose, and it's often confusing, and the symptoms are overlapping between, like, say, for example, a seizure or a syncope, or sometimes a functional event. So today I will be concentrating more on these three, and especially correct diagnosis is very important to avoid unnecessary investigations and also to not to miss any emergencies. Next slide, please. So today I will be focusing on these big three. That is the fits, is the seizures, and faints, predominantly the syncope, and functional events. And also we can club other events like hypoglycemia, ATA also in those category. But predominantly I will be focusing on functional events. By the term I mean the funny turns. Next slide, please. So a seizure is defined as a sudden surge of uncontrolled electrical activity in the brain that can cause temporary changes in personal behavior, movements, feelings, or the level of consciousness. The patient need not always lose consciousness. They may still be conscious and still have a seizure. And of course, faint is the syncope, that is the transient loss of consciousness, mainly due to cerebral hypoperfusion. And the funny turns, there's a very vague term. As I told you, we will be concentrating more on the functional events. Sometimes the dizziness, what many of the patients that confuse that as a vertigo. So that also is included on this term. And sometimes some of the patients, they can present with blackouts, palpitations, or focal neurological symptoms also like TAA, or any some of the patients with hypoglycemia also can present with such type of symptoms. Next slide, please. So we need to have an accurate diagnosis before treating the patient, and that is more important because we should try to avoid either under investigation or over investigations, and we should not miss any life-threatening conditions like any cardiac disease or epilepsy. And to prevent misdiagnosis of psychiatric causes, any functional event sometimes we normally see in clinical practice, they will be labeled as epileptic patients and they will be given anti-epileptics for a very long period. And finally, we should give assurance to the patient and treat them with appropriate medications or counseling. Next slide, please. So in evaluating the patient's clinical history is the single most important factor. So we have to take a detailed history about the event. So how was the patient just before the onset of the event? Was he getting up from his bed? Was he standing for a prolonged period? Or was he doing sometimes like if a patient takes head bath with hot water, they may have this type of episodes. There's an entity called as hot water epilepsy. So you take hot water head bath and patient falls in the bathroom, and they will not be any eyewitness to see whether the patient really had tonic-clonic movements or what has happened. So these are the things which we should keep in mind. And during the event, how was the person during the event? Whether just there was a loss of consciousness, or whether there are any tonicular movements, whether there is onset was on the one side or it's bilateral, and all those things are important. And also, once the event is finished, how was the person? That is called as a post-ictal phenomenon. Was there any or the patient was fully conscious, or was he drowsy, or was he confused? So these are things which are very important in coming to a reasonable clinical conclusion. And associated symptoms like aura, palpitations, blackouts, or sweating, these are also give us a clue as to what the condition the patient is suffering from. And also, we need to consider any triggering factors also. That's what I was telling about just before the event. How was the patient? What was he doing? So what was his posture? What was the activity? Was he on any medication? Like some of the medications like prazosin can cause postural hypotension, and we should not label those persons as having epilepsy and treat them with the anti-epileptic drugs. And one of the most important factors is the eyewitness. We should always ask for the eyewitness how the patient was during the event. Sometimes we may not get that, but preferably we should take the account from the eyewitness. Nowadays, we can ask the patient's relatives to video record the event, and we can see it, and then we can come to a conclusion as to what the condition is. And of course, past history of any medical history or family history are important. Next slide, please. And after the history and a brief clinical examination, and in the vitals, especially the pulse and orthostatic blood pressure recording also is very important. And cardiovascular assessment, especially any irregular heart rate, heart beating, and any murmurs like aortic stenosis can present with a syncope. So we should not miss that and label the patient as having a seizure. And of course, for the general examination, whether the patient is dehydrated, whether he's anemic, and those things we should check. Next slide, please. Now, coming to the seizures, what are the key features of seizure manifestation? The seizures are typically sudden onset and stereotype. Like if a person has a seizure, most of the time the same stereotype events will be occurring. Of course, in some of the rare conditions like epileptic syndromes, especially pediatric epileptic syndromes, the persons may have multiple seizure types, but in majority of the patients, it is stereotypic. Like say, for example, if the patient has a right focal with secondary generalized seizure, he will be getting the similar type of seizures. So that stereotype is very important. And whether the patient had a loss of consciousness, whether there was any tonic movements or atonic seizure, or tonic-clonic movements were there, or any behavioral changes during the episodes. That happens typically in a complex partial seizure. And after the event, how was his condition? What called as a post-ictal confusion or post-ictal drowsiness that can last for a few minutes to sometimes a few hours also. Then was there any associated tongue bite or urinary incontinence? And what are the triggering factors like sleep deprivation, alcohol abuse, or hypoglycemia, or any missing of anti-epileptic drugs? These are the things which we should consider when we are dealing a patient with a seizure. Next slide, please. Now, recently in 2025 April, ILAE, that is the International League Against Epilepsy, has come out with a newer classification of seizures. Previously, we used to label seizures as focal, simple partial, complex partial, generalized like that. But a recent classification has been changed, and here these are the main four categories: focal, unknown, generalized, and unclassified. And among these things, again, they may have either seizures can be there with preserved consciousness or with loss of consciousness. So I'm not going into details. This is the latest classification of seizures according to ILAE. Next slide, please. So once you make a diagnosis of a seizure, the person having a seizure, then we should see whether it is fitting into any syndromes, whether it is like idiopathic generalized epilepsy or it's absence epilepsy or myoclonic epilepsies, and there are various categories. That syndromic classification is important. Once we do that, then comes the treatment aspect. If the patient is able to be seizure free with drugs, well and good. Otherwise, we may have to plan for epileptic surgeries also. Nowadays, even early surgeries, we can reduce the brain damage and keep the patient seizure free. Next slide, please. Now, the common causes, I think, epilepsies and the secondary causes like trauma, ischemic events, or infective causes, or metabolic causes like hypoglycemia, hypocalcemia, and in children, febrile seizures. These are very common. So we are not going to into the details of those things. Next slide, please. Now, coming to the syncope. So the syncope should be differentiated primarily from what we were previously calling as a complex partial seizure. Like the patient will not have in a seizure, a complex partial seizure, he will not have tonic-clonic movements. They will lose consciousness. That's it. They may have automatisms. They may not have automatisms. That we may not be the attendants may not be able to identify them. So we need to differentiate seizure from syncope. So that's very important. So there are certain clinical features which help us in differentiating these two, especially seizures. Syncopes are situational, like the person standing for a prolonged period in a schoolgirl standing for half an hour to 1 hour in hot sun during prayer time. Suddenly she falls. So this typically happens in syncope, and any severe pain can trigger a syncope, or dehydration sometimes can trigger. And these syncopes, they usually have the warning signs. They will have the lightheadedness, the blurring of vision, sweating, palpitations, and once these are there, we should suspect a syncopal attack. And most important aspect is the loss of consciousness in a syncope is very brief. It is usually less than a minute, but very typically less than 30 seconds. If a person has a loss of consciousness more than a minute, first rule out a seizure, then come to secondly think about a syncope. But if it is less than half a minute, syncope should be seriously considered in differential diagnosis. And very rapidly they recover. They will not have that post-ictal confusion, other things. Once that event is finished, so they will be fully conscious without any post-ictal symptoms. And sometimes, rarely, they can have tonic-clonic movements, what we call them as a convulsive syncope. Rarely that can happen. So not all convulsions are not seizures. Sometimes they can be convulsive syncope also. Next slide, please. Now, common causes, most commonly is neurocardiogenic. And of course, arrhythmias and any structural cardiac diseases can cause syncope, like aortic stenosis and orthostatic hypotension, especially drug-induced. Antihypertensives, especially alpha blockers, are known to produce orthostatic hypotension, especially in elderly. We should always consider that. We should keep in mind that these things can cause syncope, and don't label those persons as having seizures. And of course, carotid sinus hypersensitivity. Next slide, please. And coming to the functional events, these are non-epileptic seizures, what we were calling previously. So it's a broader term. Functional events, they are variable and inconsistent, and at each event will be different from the previous episode, either in duration or in the semiology. So they are often prolonged and fluctuating, and usually they have associated stress. Especially this happens in young people, young girls especially, and they are asynchronous movements, and they may retain awareness. They may not be opening their eyes, but they will be listening and remembering whatever the bystanders are saying, or what they are doing. So they will be aware of those things. So we should be very careful in eliciting history. That's important. And apart from functional events, the hypoglycemic events are vestibular events. That is acute giddiness, and TAS can be classified under these funny terms. Next slide, please. And common causes are, as we were mentioning, anxiety, panic attacks, hyperventilation, and vestibular migraine or vestibular disorders, TAS. And in children, breath holding spells also need to be considered. These are the closest to differential diagnosis in seizures in epilepsy, in pediatric practice. Next slide, please. Now, coming to the practical differentiation between these three, whether the person coming to us with a query in like transient loss of consciousness, whether the patient is suffering from a seizure or a syncope, or is it a non-epileptic functional event. To differentiate those three events, these are the things which we should keep in mind. First and foremost thing is the onset, whether that is sudden onset or not. Like I said, syncope seizure is very sudden. Syncope sometimes can then they have programmed symptoms like dizziness and blackouts, and then they will lose consciousness. And functional are usually they're prolonged. Onset is not sudden, but it is variable. Sometimes it can be sudden also. It is variable. And duration, typically seizure lasts for more than a minute, and syncope lasts for less than a minute. And as I said, functional events, sometimes they last for 15-20 minutes, half an hour also. And recovery, syncopes, their rapid recovery is there. And in functional events, it is variable. In seizures, they will have some, for a few minutes, they will be confused, or sometimes they will be drowsy. And after that, they become normal. But in elderly persons, the recovery may be prolonged, sometimes for a few hours also. Tongue bite is very common in seizures, but it's not common in syncope or functional events. And tonic-clonic movements can be seen in syncope also, but that is rare. But it can happen. Next slide, please. Now, after we come to a reasonable conclusion from history and clinical examination, we'll go into the investigations, the basic investigations of blood investigations, which includes blood glucose, electrolytes, including serum calcium, and blood counts should be done. And if you are suspecting a seizure, go for a neuroimaging and EEG, which are helpful in making a diagnosis of what is the cause for the seizure, if it is a seizure, and whether we can label them as having fitting into any epileptic symptoms also. And of course, ECG for arrhythmias and in cardiac diseases. And if you don't find a cause, then Holter monitoring also is advised to know. Sometimes any transient events, transient AF or any transient events, any ventricular arrhythmias can be picked up by Holter. Once we rule out all organic conditions, then we can consider going for a psychiatric assessment. But before going into the psychiatric assessment, we should rule out all organic causes. Next slide, please. Now, coming to the management aspect, and first, once we identify it as a seizure, and what is the cause for the seizure? So once we identify the cause, treat the cause. Like many of the times, the persons, they may have a neurocysticercosis or tuberculosis. So once we treat the cause, the patient need not go for a long-term anti-epileptics. But once the cause is not found, if the patient has epilepsy, then we may have to treat for a prolonged period, for minimum of 2 to 3 years. And in benign cases, once the person doesn't have a seizure, if it is functional causes, so reassurance plays a very major role in preventing those recurrent attacks. And then psychological assessment and counseling, they give the patients a better outcome. Next slide, please. Now, once we witness a first seizure in a primary care, first thing, if the person has a single episode, that's the first episode, first always look for secondary causes. Once we find the secondary causes, treat that, and that's sufficient. And we not go for a long-term anti-epileptic drugs. Anti-epileptics for a brief period like 2 to 4 weeks is sufficient. And advise them regarding the safety issues, like avoiding driving, swimming, or going to the high places. And if you cannot find a cause, refer the person to a neurologist. Next slide, please. For the syncope, first identify the triggering events, what event has precipitated the syncope, and avoid that. And basic workup can be done. And urgent referral is required in a syncope once the syncope is exertional, or the ECG is abnormal, or whether there is a family history of sudden deaths. In such cases, don't neglect syncope as a simple vasovagal attacks. Though majority of the cases are vasovagal attacks, but if these things are there, it's better to immediately refer to the cardiologist. Next slide, please. And of course, functional causes, first always rule out organic causes, then reassure the patient, give psychological support, and always avoid unnecessary anti-epileptics. In day-to-day practice, we see many persons with pseudo seizures, what we are previously used to call these as functional events or pseudo seizures, they were put on antiepileptics and they were using for a few months to years together. It is unnecessary. And the events are very frequent, and if it is disabling, it's better to refer to the specialist. Next slide, please. Next slide, please. And for any first unprovoked seizure, once we don't find any provoking factors, it's better to refer to a neurologist. And also atypical syncopes can be seizures. So don't label person as having syncope. Sometimes we may be missing a seizure. So in such cases, we should refer the patient. And if you're suspecting epilepsy or any TIA or stroke or any unexplained episodes, then we can evaluate and come to a diagnosis. Next slide, please. And these are the typical case, but most of the time in clinical practice, we don't see such cases. As I was telling, a 15-year-old girl collapses in school, upstanding for a half an hour to 1 hour with brief jerks, sometimes associated with brief jerks, and with a quick recovery. So likely syncope. There's a convulsive type of syncope. Next slide. And is a 35-year-old man with sudden fall with tonic-clonic movements, with post-ictal drowsiness, suggests it's a typical generalized tonic-clonic seizure. Next slide, please. And a 24-year-old lady with a stress-related shaking of the all limbs and body pelvic thrusting, with eyes closed, lasting for about 20 minutes. And she recalls what the bystanders were saying. That's a typical functional event. But to label the person as having a functional event, it's always better to rule out the organic cause. Next slide, please. So summary. So as I told, history and exams are very key. Examination of the patient is very key. Broad differentials to be considered. And use investigations wisely. Don't under or over investigate. And once the organic causes are ruled out, psychological support is a must. Next slide, please. So the same thing. So the take-home message is any transient paroxysmal events, keep in mind either it could be a seizure or a syncope, because a cardiac event also need to be considered, because these are the emergencies. So simple vasovagal attacks, we can reassure the patient and avoid treatment, but always keep in mind that not all seizures they present with tonic-clonic movements. So there are various types of sensory phenomena or autonomic phenomena which come for a very brief period. So we should be very careful in evaluating a person having paroxysmal symptoms lasting for a few seconds to a minute or two. So we should be careful in evaluating such patients. Thank you for your patient listening.
Any questions?
Actually, the three cases which you presented, Kirti, actually we have encountered similar things in our practice. What is the basic thing we can do at our small places?
Yeah,
First aid.
Yeah,
If you can enlighten, that is very
yeah,
good.
it all depends again on the diagnosis. First, once person presents with a single first attack, we should always look out for the secondary causes. Most commonly, electrolyte disturbances are there. Any hypocalcemia or hypoglycemia or hyponatremia, these things can present with seizures. So once those are covered, once they are treated, the patient doesn't get another episode, so that's done. So if you don't find any local those causes, simple causes, then we have to refer to if it is a seizure, if you're suspecting a seizure, refer to a neurologist. If you're suspecting, say, syncope, then a cardiologist can evaluate.
Thank you, sir. Sunil sir, to give small moment to
at the
Dr.
outset, I
Sri
thank Kirti for his triple F presentation. Fits.
Now topic is basics of imaging in coronary intervention. Chairperson Dr. Srinath sir. ICU cardiac thoracic OT. Sir, excellence award for Venkatramana Heart and Veterinary Hospital, best hospital in Tirupati from YSR Arogyasri in 2023 and 24. Sir had healed so many cardiac cases, thousands of hearts for more than 2 decades. Unparalleled clinical excellence and extensive experience. Now, sir will give a small topic regarding basics of imaging in coronary intervention.
I thank all the organizers for inviting me for this lecture. This is a relatively a specialized topic for usually useful for more of cardiologists. My aim of presenting this topic is to aware of these investigation modalities, which is useful for the interventional cardiology and so that we can educate the patients. There are 4 modalities of the intravascular imaging is available. Intravascular ultrasound, optical coherence tomogram, angioscopy, and infrared spectroscopy. Out of this, OCT, optical coherence tomogram, and infrared spectroscopy gives almost a visual histology of the plaque. So the plaque that accumulate in the intima causes the obstruction of the coronary arteries. And before going for any procedure, we have to know the composition of the plaque so that we can get a better result from the intervention. So if take the, what is the first step is going for example, patient is having a coronary artery disease. We want to know the extent of the disease and anatomy of the vessel and identification of the disease, and further intervention will be based on the coronary angiography. After knowing there is a block or a coronary atherosclerosis and causing obstruction of the coronary arteries, to know our results wants to be a best results and future restenosis, future TLR, target vessel revascularization should be less if we use intravascular imaging and do the coronary intervention. So, but the coronary angiography lacks some of the problems with coronary angiogram. It's a poor resolution. It's an angle dependency. For example, eccentric block is there. If you visualize from front of the block, then you will see the vessel normal. So you have to tangential for 90 degrees, you have to visualize. So always you have to take a 2 angles in coronary angiogram to know the obstruction. So in that case, sometimes we may miss the block. So vessel overlap, foreshortening, inter and intra-observer variability and the coronary angiogram is a common. So this is a simple luminogram. Coronary angiogram is a luminogram. So we need what vessel we want to visualize the vessel wall and the plaque characteristics. We have to go for an intravascular imaging. So what the intravascular imaging gives to us? One is plaque distribution and the extent, vessel remodeling, plaque composition, severity of the stenosis, reference vessel size, stent expansion apposition, and post-PCI complications if anything occurs. So virtually you are going into the vessel and seeing into the vessel, peeping into the vessels through intravascular imaging. So the imaging modalities helps in informing the lesion preparation. For example, plaque is having heavy calcium. You cannot yield it with simple ballooning. Sometimes it may read IVL balloon, or sometimes atherectomy devices are necessary. Sometimes cutting balloon is necessary. Sometimes we have to go for an OPNC balloon. Sometimes we have to use all together to get a good results. Otherwise, you cannot yield and stent expansion will not be good. So they will land up in restenosis again. So selecting the appropriate size of the stent is also important. Selecting optimal stent length is important. So if you land up a stent in the plaque area, there is high chance of edge restenosis, dissection, complications. You will land up in complications. So we have to land the stent in the normal area to normal area. At least, if not possible, diffusely diseased vessel, we have to land up the stent in a plaque where is less than 30% of the vessel area. So, and also we have to see the plaque should not have a more lipid. If you land a stent in the lipid area, it causes dissection and throws the lipid plaque in the distal coronary circulation, causes slow flow, and we will land up in the problems in the cath lab. So clarifying and identifying the acute complication in post-PCI, edge dissection, stent malposition, tissue protrusions we can identify, clarify the mechanisms of late stent failure like stent thrombosis, neointimal hyperplasia, stent underexpansion, and neoatherosclerosis. I have already told you what are the 4 types of intravascular imaging. Out of this, commonly used in the cath lab is intravascular IVUS and intravascular ultrasound and optical coherence tomogram. How the systems work? In case of IVUS, there will be 2 types of transducer available, mechanical and phased array transducer. Electrical energy goes to the transducer tip where the piezoelectric crystals will be there. They produce the ultrasound wave. Ultrasound wave goes and hit the wall and come back to the transducer, again converted into the electrical energy, and which is again transformed into the image on the screen. Similarly, in case of OCT, the energy used is the light, and light goes and hits the vessel wall, come back to transducer, converted back to the electrical energy, and again it come back to the computer systems, and it will be imaged on the screen. So the OCT having 2 types, frequency domain and time domain. Nowadays, time domain is obsolete, frequency domain is used. Frequency domain is a swiping laser source, no mechanical moving parts, capture the entire line at one time, 10 times faster than the time domain. So I'll go through the briefly. There is a source T is a transducer which emits the ultrasound or light, and if it falls 90 degrees perpendicular to this on the surface, it will be reflected back totally to the transducer and get the good image. Some of the light or ultrasound fall tangentially, reflected away from the transducer tangentially. And another thing, this out of the important is angle of this is called angle of the incidence. Angle of the incidence is 90 degrees. Most of them go back to the transducer. We can get the image. For example, the angle is 30 degrees. It will be reflected away from the transducer. Another thing, the smoothness of the surface. If surface is smooth, most of the energy will be reflected back to the transducer. If the surface is rough, then scattering will occur. Only a portion of them go back to the transducer. And we have the 3 layers in the vessel wall: intima, media, and adventitia. Each layer will have a different acoustic impedance and refractory index. Depending on that, the source of energy may penetrate into the deeper layers, gives the next layer image also we will get. So another 2 more important points we have to know is shadowing. For example, the tissue cannot allow that energy to penetrate deeper into the tissues, then we get a shadowing. In case of calcium, ultrasound is totally blocked by the calcium. We'll get a shadowing beyond the calcium. And in case of OCT, light can travel through the calcium, so we can well delineate the calcium, and we know the depth of the calcium also. And attenuation is absorption by the tissue. Lipid will absorb both the ultrasound and the light, so it causes less bright shadow, and penetration will be poor in the lipid for the light and ultrasound. It causes attenuation of the tissues, and attenuation can happen by the absorption of by the tissue or scattering. So how to get the depth of the image. For example, the time traveled by the energy source, light or ultrasound, will give the thickness of the vessel wall and the depth of the calcium or depth of the plaque. This is how image is created. We can get a time and depth. 3 layers will get a different times. We can imagine the 3 layers. So we know the thickness of the each layer. So if you see the IVUS and the difference between the OCT, IVUS is wavelength of 35 to 80 and OCT is 1.3. So the wavelength is smaller than RBC. So we have to clear the RBC with contrast and the saline. In case of OCT, resolution is very high for the OCT. It's 10 microns sections will be taken. In case of IVUS, it is 100. And depth penetration is more for the IVUS, and depth penetration is less for the OCT. But overall, OCT is useful in detection of fibrous cap, lipid, calcium, thrombus, and plaque vulnerability, stent evaluation, late follow-up. It fares better than the IVUS, but IVUS gives the amount of plaque burden. But nowadays, IVUS is also improved. Nowadays, the IVUS coming is as a high frequency IVUS, almost rivaling with the OCT. So IVUS images are analogous to the histological section. They are oriented from the ostium of the coronary artery. There is no absolute anterior, posterior, or left versus right orientation. Side branches and perivascular markings are used for orient the image, and the image is described as if viewing from the face of a clock. That we have to characterize from 2 o'clock, 3 o'clock, 6 o'clock, 9 o'clock, like that. We have to speak about the IVUS defects. And the echogenicity, in case of IVUS, we compare with the adventitia. Shadowing, complete reflection of the light or ultrasound rays cause shadowing. Attenuation, reduction of the intensity of the light wave through the absorption and scattering. And multiple reflection occurs in ultrasound when there is a reflective surface happen. And OCT also, backscatter is more, it is more bright. Attenuation is less intense shadowing. Shadowing causes complete obstruction. Composition may be homogeneous, heterogeneous. For example, calcium gives heterogeneous appearance. And case of lipid or fibrous, it is homogeneous appearance. Texture is coarse or fine. Edges sharp or diffuse. And calcium give a sharp edge. Lipid give diffuse edge. So in both OCT image, next is IVUS image, both gives same picture. Intima and adventitia will be bright. In between a lucent line is a media. In OCT also will get a media as a less bright structure, and in case of IVUS, we get a lucent structure. So this is the plaque. You see, usually the atherosclerotic plaque accumulates in the intima. Whatever the below the lucent and inner side of the lucent line is intima, that is, if a thick, it's a plaque. There's a thick plaque is there. Out is adventitia. Similarly, in OCT, finding sometimes fibrous plaque, circumferential plaque, finding a extra elastic lamina is difficult. So in this case, the total bright structure is a fibrous plaque, and less is a diffuse, and we can't delineate the borders in case of a fibrous plaque. So these are all the different types of images. This is a fibrous plaque. If you see the calcium, second pointer is there. Second picture is calcium, and because of the calcium, complete shadowing is there, and it's a soft plaque in the intima. Attenuated plaque, again, attenuated plaque is there. I'll go to the next picture. Attenuated plaque is a lipid. And again, echolucent plaques, that indicates a necrotic core or is a lipid in the deep inside the plaque. It's a mixed plaque with some amount of calcium, fibrous, and as well as lipid. And the plaque rupture, you can see, I'll go to the previous picture. You can see there is a rupture below in 6 o'clock position in last picture one. And you go to the picture, that's a plaque rupture and accumulation of the blood. And another thing is a thrombus there. So IVUS need eye training. We have to do multiple IVUSs to get oriented to the image. But OCT is user friendly and even beginners can understand. So the calcium, again, if you see the calcium, it's a superficial calcium, almost blocking the entire ultrasound waves. Nothing is seen beyond the calcium. And here you see next picture is a deep calcium. The plaque before the calcium is seen and behind the calcium is not seen. This is a spotty calcium. Here and there it's a calcium is there. And that's a nodular calcium. Nodular calciums are very difficult to treat. Even some atherectomy, sometimes we cannot break the nodular calcium. In that case, sometimes IVL will be better. So these are the different characteristics of the lipid plaque and fibrotic plaque and calcified plaque. And this gives fibrous, the OCT pictures of the fibrous and calcium you see well delineated structure in the last fibrocalcific plaque. And vulnerable plaques, again, is a thin cap fibroadenoma. The bright structure is fibrous cap, and below that is the lipid. So a thin cap fibroadenoma are more prone from the ACS, like acute coronary syndrome. They can anytime break and throw the lipid into the lumen and causes acute MI. These are the different, this one. For example, we cannot imagine the EL and adventitium is external elastic lamina adventitia is well seen. Then it's a lumen abnormality, red thrombus or a white thrombus. White thrombus can, light can penetrate through the white thrombus. Red thrombus, light cannot penetrate. So red thrombus gives more slow flow and is more dangerous than the white thrombus. So if it is not visualized, it is in the wall. Structure is in the wall. High attenuation is lipid, low attenuation calcium, and calcium is well seen. Then morphology, how the morphology will guide us in lesion preparation. It's more of lipid. We'll go for a direct stenting because if you break the lipid may cause slow flow or no reflow. So we go for a direct stenting. Fibrotic, just a compliant balloon is enough to open the vessel. And if it's a moderate calcium, non-compliant balloon, cutting balloon, scoring balloon, these are all necessary. If a heavy calcium, we have to go for an atherectomy. So this is MLD max is the criteria. MLD is pre-PCI, morphology of the plaque, length of the lesion, diameter of the vessel. We have to ascertain, then go for the choose the stent size, length, and diameter. Post PCI, if any dissection is there, if it is a medial dissection, again put another stent covering the dissection. Apposition of the stent is very, very important. If the apposition is not good, they will land up in restenosis. Expansion is adequate, should be adequate. So these are the criteria of the calcium criteria, and depending on that, we will go the thing. These are the left main lesion. You see left main and lot of long segment disease, and the patient had a triple vessel disease. This is left main to LAD. We had imagine we had a very good results with IVUS guided one, and I'll show the pre one is 6.35 in left main. We got almost 10, and LAD pre is 4.1. We got almost 7 square mm. So anyway, the criteria is minimum should be 6, 7, 10. 6 for the LCX, 7 for the LAD, 10 for the left main. We have to achieve square area. So we got a good result here. This is, I will play some of the IVUS clips. You see, there is a lot of plaque here. Lot of plaque. This was from art. Then for RC, you see, there is a lucent line is there. You see, there is a lucent line above that mark. And whatever inside is there, here there is some calcium is there, but it's not very thick calcium causing, just spotty calcium is there in the 12 o'clock position. Yeah. And this is an IVS from the LAD. This patient was actually triple vessel disease, diffuse disease, not willing for CABG. So we with the IVS and IVL, we planned for the procedure. This was an RCA, but RCA was most of a lipid block with some particle. This is an IVS catheter. Outer side is sheath and inside the IVS transducer. After that, dilated the vessel. Previous IVS pictures also belongs to this patient. But it's almost diffusely diseased vessel. After dilating and putting the stent, we see another lesion below. But we got another lesion, but we left it because flow is good, and we have. This was this IVS catheter. IVS transducer move in the sheath. Now we have did the IVS, and finally there is a thick circumferential calcium here. We did IVL, but it's not yielded even after IVL. And we have went for OPNC balloon, and we went for a very high times. And finally, we got a reasonable result. So we got a reasonable result for this. But the patient is having a diffuse disease in distal and distal LAD. LCX also diffusely disease. But a patient is ideal for the CABG, but not willing for the CABG. Thank you. Because I couldn't cover everything in the same slide. Same.
Hello. Thank you, Dr. Venkatramana Garu, for your detailed and brief description of coronary imaging. Very nicely described. Any questions, please, audience can be asked. There are questions. There are no questions.
Now I will invite Dr. Vijay Kumar sir to give memento to the chairperson, Dr. Srinath sir. I request Dr. Srinath to facilitate our There is a council meeting in number 2 hall. Any council is there? Here, they can go there. Next session, I invite Dr. G. Lata. She is going to give presentation on PRP in reproductive medicine. Now I request Dr. Kameshwaramma to chair this occasion and moderate.
I want to introduce Dr. G. Lata, infertility specialist from Tirupati. She did her undergraduation and post-graduation from SV Medical College, Tirupati. Worked as assistant professor of obstetrics and gynecology department in SV Medical College, Tirupati for 6 years, and did her MCH from Sri Ramchandra Medical College, Chennai from 2013 to 16, and got gold medalist in both MD and MCH. Underwent training for andrology at Miami University, Miami, USA. I got FMAS and DMAS from World Laparoscopy Hospital, Gurgaon. Presently consultant at Sri Ankura Fertility Center, Tirupati. Please continue, madam.
Thank you for kind introduction, ma'am. Good afternoon, everyone. So today I'm here to present on PRP in reproductive medicine, which is one of the emerging topic in almost all branches. So before going to the actual topic, I would just like to say a few words about the components of blood. So components of blood include 55% of plasma, which is the watery content, then 44% of RBCs, which transport oxygen, 1% of WBCs and platelets. WBCs mainly to combat infection and platelets mainly for coagulation. So these platelets have got alpha granules in it, which help in the release of growth factors, which are quite important in PRP. So PRP is nothing but platelet-rich plasma. It's an autologous blood product rich in growth factors, and it contains almost 3 to 5-fold greater levels of platelets than plasma. So the normal platelet count is 1.5 to 4 lakhs, and this PRP contains almost 3 to 5 times more than 1.5 to 4 lakhs. So the composition of PRP is mainly growth factors, like all the other, like platelet-derived vascular, insulin-like transforming growth factor and epidermal growth factor. These growth factors promote cell proliferation, angiogenesis, and tissue regeneration. So what are the different types of PRP? One is leukocyte-poor PRP and leukocyte-rich. The one that is used in reproductive medicine is the leukocyte-poor one, because these leukocytes may cause inflammation, and this inflammation may prevent the implantation. So always the poor type is used in reproductive, dermatology, and almost all branches except in ortho and sports medicine, where the leukocyte-rich PRP is used, because the leukocytes will cause inflammation, and this inflammation is advantageous in orthopedics for tissue regeneration and wound healing. So what are the uses in reproductive medicine? Mainly it's divided into 4 categories. One is for the endometrial rejuvenation. The second one is ovarian rejuvenation. Third is in ovarian torsion, which is still in experimental stage. And fourth being male infertility, partly in the experimental stage. So the other uses of PRP being in dentistry, orthopedic surgery, hair restoration, skin rejuvenation, and sports medicine. So how do we prepare this PRP is, Usually around 8 to 50 ml of autologous venous blood from the peripheral vein is collected in an anticoagulant tube like ACDA, and this has to undergo centrifugation twice. So the first centrifugation, usually this blood contains 3 layers as I said before. That is the plasma layer, buffy coat with platelets and WBC in between, and the lower RBCs. So then this undergoes centrifugation, and once centrifugation is done, we get 2 layers. That is, the topmost layer is the plasma, and the bottom layer is the buffy coat, and here the RBCs are being removed. Then again second centrifugation at around 2500 revolutions per minute for around 10 minutes. The first one is 2500 revolutions per minute for 20 minutes, and after the centrifugation, after the second one we get 2 layers. The top one is the platelet poor plasma and bottom is the platelet rich plasma, and this bottom one around 0.5 to 4 ml of PRP is used for different purposes. So first coming to the endometrial PRP. So where is this endometrial PRP used? The main indications being Asherman syndrome, thin endometrium with unknown cause, recurrent implantation failure, and chronic endometritis. So what is the mechanism of action is, usually the presence of growth factors have got different actions. These growth factors will promote regeneration, they are angiogenic and mitogenic, and will increase the endometrial thickness. And the second one is for recurrent implantation failure. How it helps is, it improves the receptivity, and for chronic endometritis, it acts as antimicrobial and anti-inflammatory. So preparation is similar as I said prior. Two times centrifugation has to be done, and finally the platelet rich plasma has to be collected and introduced into the uterine cavity. So it is done. The procedure can be in 2 types. One is direct intrauterine transfer, and the second one is hysteroscopic method of PRP. So how do we do this is, you just using an IUI catheter, take around 0.5 ml of prepared PRP, and then it is done in the proliferative phase, usually between day 8 to day 10 of cycle, and can be repeated every 48 to 72 hours, 3 times maximum. So this improves endometrial thickness, vascularity, and receptivity. So this is the hysteroscopic PRP. So what is done in this is, after anesthesia, pass the hysteroscope into the uterine cavity, and via the operative sheath, pass the oocyte retrieval needle. So oocyte retrieval needle is the one on the other side which has got a beveled edge and striations. So this beveled edge, while passing, it has to, while introducing into the subendometrial layer, it has to face the cavity, mainly to know the depth of insertion. So once we pass the retrieval needle inside the uterine cavity, 0.5 ml of PRP is injected into each wall of the uterus, anterior, posterior, and 2 lateral walls, subendometrially, so that the beveled edge faces towards the cavity, and it can be passed until the striations. So these are all the points how we need to pass the oocyte retrieval needle. So once we pass this, so in the next cycle itself, we can go ahead either with IUI or even with the embryo transfer. So maximum around, like even this can be done for 1 to 3 times. So the indications, the first indication being Asherman syndrome. As everyone knows, Asherman syndrome is nothing but because of repeated DNCs or infections, sometimes intrauterine adhesions occur, and the basal layer of the endometrium, usually there will not be any regeneration of endometrium. So the endometrium will be thin in such cases. So what we need to do in these cases is do a hysteroscopy, then remove the adhesions. After remove the adhesions, the PRP has to be done using a hysteroscope, that is introducing 0.5 ml into all the 4 walls. After that, a Foley's catheter is introduced for almost 7 days to prevent recurrence of intrauterine adhesions, or we can give estrogen therapy for 28 days, 4 mg. So this is how these are the adhesions. Those have to be removed, and then we need to pass the PRP. We need to instill the PRP. So this is one of the study case report where the patient got pregnancy after PRP. Then in thin endometrium with unknown cause, so this can be done with IUI catheter. Just introduce with IUI catheter the prepared one, that's 0.5 ml PRP into the uterine cavity. This can be done between day 10 to day 13 of cycle and can be repeated 1 to 3 times. And if there's no improvement, every 2 to 3 days, PRP can be given up to a maximum of 3 times. Once the endometrial thickness is around 7 millimeters, we can go ahead with IUI or embryo transfer. So the third indication is in recurrent implantation failure. So recurrent implantation failure is a condition where in spite failure to achieve implantation or pregnancy, in spite of going ahead with embryo transfer with 4 good embryos with a minimum of 3 fresh or frozen cycles. So in such cases, usually 30% cases of recurrent implantation failure is associated with chronic endometritis. So in this case, we can go for intrauterine infusion of PRP. So usually given 48 hours prior to embryo transfer. So this is one of the study regarding the recurrent implantation failure. Several studies have come out with recurrent implantation failure and PRP. So it has got a good role in recurrent implantation failure. And finally, the endometrial rejuvenation is in chronic endometritis, where there is inflammation. So these growth factors in PRP, they reduce the inflammation, they act as immunomodulators, and also increase the expression of matrix metalloproteins, which help in wound healing and regeneration of endometrium. So the second one being ovarian rejuvenation, that is called as ovarian PRP. So this is usually done in many menopausal or perimenopausal patients less than 50 years, infertile women less or more than 35 years with low egg count and low AMH, and women with primary ovarian insufficiency or premature ovarian failure, that is patients who are less than 40 years and with FSH levels more than 25, done twice, 4 weeks apart. And also they have amenorrhea or oligomenorrhea for more than or equal to 4 months. So such patients are labeled as patients with primary ovarian insufficiency. So in these cases, we can go ahead with PRP. So the picture over there is the one with low antral follicle count, where the number of follicles are less than 5. So these are the follicles, the dark cystic areas or the follicles. When they are less than 5, we call it as decreased reserve, and in such cases, they'll have use with PRP. So this is the mechanism of action of PRP on ovary. They improve the folliculogenesis and increase the number of follicles, and also angiogenesis is improved. Along with that, the anti-Mullerian hormone, which is an indirect measure of ovarian reserve, and also it says how a stimulation will be, is also increased along with the antral follicle count. So how do we do this intra-ovarian PRP is by two methods, that is vaginal route as well as laparoscopic route. So this is the transvaginal guided PRP into ovary. It is similar to oocyte retrieval, where a probe is passed into the vagina, a needle is passed via it into the ovary, and then around almost 1 to 2 ml of PRP is injected into each ovary. This is done usually in the between day 23 to day 26 of cycle, or in the follicular phase, or sometimes along with oocyte retrieval. So once we do this PRP, we can wait for 3 months and check the antral follicle count and go ahead with the treatments. The next one is the laparoscopic assisted ovarian PRP, where a laparoscope is done, laparoscope is introduced, and then the ovary is held, and into the ovary a retrieval needle is passed, or a needle which is used in laparoscope, and around 1 to 2 ml is injected into each ovary. Usually one puncture is best, but sometimes we may have to go for 2 to 3 punctures also. The same way it has to be done in the luteal phase, or sometimes in the follicular phase also it can be done. So this is how it is done, and it is injected subcortically or intramedullary. So in both the areas, PRP can be introduced, and this can be done even 2 to 3 times. So how do we do in ovarian torsion? This is still in the experimental stage. So it mainly reduces the ovarian damage, that is ischemia is reduced, and free radical damage is reduced by introducing PRP into the around the ovary. So how it is done is it can be given in the intra-op period or post-op period. Intra-op, immediately after ovarian detorsion, we can introduce the PRP around the ovary in the POD, around the ovary and the tubes. And second method is after detorsion, if the blood flows are good, directly it can be introduced into the ovary as well. And in the post-op period, if we are not given in the intra-op period, in the post-op period, after 3 to 7 days, we can just check the blood flows, and if the blood flows or if there's partial flow of blood in the ovary, then we can go for the PRP by transvaginal route. So this is transvaginal guided PRP into ovary in the post-op period. So how do we do in male infertility? This is still in the partly in the experimental stage. One is incubation of semen and testicular tissue which contains spermatogonial stem cells with PRP. Second one is cryopreservation of semen with PRP. Third being in azoospermia, we can go ahead with PRP, as well as torsion testis. So this is the first one where the semen or the testicular tissue with the spermatogonial stem cells is incubated with PRP. And then what we see is these spermatogonial stem cells, they differentiate to sperms easily. So that is one still in the experimental stage. The second one is the sperm cryopreservation with PRP. So usually in IVF, we just freeze the semen on 5th or 6th day, because if the male partner can't give semen on the day of egg pickup, we use this cryopreserved semen. And sometimes in chemo, like patients on chemo radiation, prior to chemo radiotherapy, we freeze the sperm so that the semen parameters will not be altered. And again, those who are undergoing orchidectomy or some trauma, if they have prone for trauma, even such cases we can freeze the sperm. So once we cryopreserve the sperm, what happens is the motility reduces by 50%, and also there may be some problem with the sperm DFI, that is DNA fragmentation index, usually has to be less than 30%, but if it's increased to more than 30%, fertilization failures are quite common. So in such cases, if we add PRP prior, what happens is the motility is regained and also the DFI will not be increased. And the third one is in non-obstructive azoospermia, that is those who are prone, that is those who have testicular failure. In such cases, what we need to do is we need to inject PRP prior before going for testicular sperm aspiration in IVF or ICSI. We need to inject PRP around 1 to 2 ml into the testis, and then after 3 months again we can do a TISA, that is testicular aspiration, to get the sperm from that. And also, as in ovarian torsion, even in testicular torsion also PRP can be given. So this is the procedure where we are injecting the PRP into the testis around 1 to 2 ml in each testis and wait for 3 months so that we can see the improvement in the sperm count, motility and morphology. So these are few of the studies where the introduction of PRP into the testis is done with 21 gauge needle under anesthesia. So these are a few studies. So what are the contraindications? So right now we can use it in endometrium, ovary, as well as in male infertility. What are the contraindications to PRP? Or one is coagulation disorders, active infections, chronic diseases like diabetes mellitus and autoimmune disorders, pregnancy or breastfeeding, cancer, those who are on anticoagulant use, PRP sometimes when we they may be bleeding also, allergic to components used in PRP, and severe anemia, because usually we need good healthy amount of blood for PRP. So what are the advantages? It's like autologous, from the patient blood is extracted, safe, simple, minimally invasive, it's repeatable 1 to 3 times it can be done, and it may enhance response in resistant cases. And the side effects being very minimal, there may be local pain, swelling around the injection site, erythema and irritation. What are the limitations of PRP right now is limited studies, lack of standardization. So the centrifugation speed, timing vary in different studies. So each one uses differently. There's variable preparation techniques and also the volume of PRP that is used and which period, which time the PRP has to be used is all variable. And cost certainly definitely more cost and uncertain long-term outcomes. We don't know about the long-term outcomes. So finally, I conclude, PRP is a promising regenerative tool in infertility. It's beneficial in thin endometrium, recurrent implantation failure, poor ovarian responders, as well as male infertility. And it's still few cases, it's experimental and it's used only in well-selected cases. Thank you for the patient hearing.
Any questions? Thank you.
Someone is-
Dr. Lata.
No,
How long it is being done and what is the cost?
so usually like if we take like endometrial PRP with hysteroscope, it will be around 30,000, sir, including the hysteroscopic charges. But PRP preparation charges will be less than 5,000.
Hello. Hello. Madam, can you hear me?
Yes, sir.
Hello.
Yes, sir. I'm
Yeah.
able to.
I'm Dr. Saifullah. I'm a surgeon. With respect to torsion testes, you mentioned the PRP. I'm as well a bariatric and a cosmetic surgeon. I've been using PRP for quite a long time. I just wanted to know how does it really, I mean, by the time the torsion testes patient comes to us, it's already a dead necrosed tissue. In my lifetime, I have only one case, which has been usually we see in a documented theory that, you detort the testes if it is a partial torsion. So in my lifetime, I have done only one case, detorted the partial torsion testes. So does it really affect, does it really help PRP into torsion testes? This is a simple question.
That's why it's still in the experimental stage, sir. I have not used for torsion ovary, but as per studies, it has got role to reduce the ischemia once we inject around the.
Yeah, that's what it's already by the time patient comes to us. The golden time is 6 hours. Usually, the patient comes by the time it is diagnosed, come from the periphery or from the whatever. By the time patient comes, is already 24 hours. Passed away.
And
That's
the
the only
thing,
question. Yeah,
the
thank you.
thing is, we can just prepare it within an hour period, and we need to inject within 30 minutes. So by the time we prepare the patient for surgery, maybe we can extract the blood. By the time the surgery is over, we can prepare it and then we can inject it around the ovary or whatever it is, the testis.
My concern is not the time, ma'am. My concern is already a dead tissue where you can inject PRP. That's my question. Torsion testis is already a dead tissue.
Yeah.
By the time it's already ischemic black, jet black. So does it really, in that cases, does it help? Or only the partial torsion which has been detorted? The vascularity is maintained in a partial torsion, then you can inject.
Yeah, partial torsion only will have help.
That's what my question, ma'am.
Partial only because it has got vascularity.
And thank you, Lata, for your excellent description of the PRP. Because we are all in IVF centers, we are all using PRP routinely. Doctor, she said all the things for torsion of ovary. She didn't mention about torsion of testis. It's not testis.
I told it's there even in torsion testis.
Okay, but it is even in torsion of ovary also. When the vascularity completely gone, this PRP is not at all working because we tried in many this one. If there is partial vascularity sufficient, about at least 50% of vascularity of the ovary must be there, then only this PRP will work. And even this PRP also, we are giving routinely before embryo transfer for refractory cases, especially for recurrent implantation failure cases. We are giving PRP, intrauterine and hysteroscopic PRP and everything. But even then also, the result is not that much improving with all the this one also result is not that much encouraging. This is all adding masala to the embryo, and of course we have to get success after giving the embryo. We have to get success and we have to get
we have to send the woman with the child. So we use all masalas. That's why PRP is definitely helpful. Definitely helpful PRP. But encouraging result means we have to do lot of trials and follow-up studies are there, and we have to do lot of trials. When the complete torsion is there, when there is no blood supply, there is no question of regaining that one with PRP.
Correct.
But at least 50% vascularity must be there.
True, very true, ma'am.
Yeah.
Thank you.
Thank you. Thank you.
Thank you, ma'am.
Madam, one simple question. Nowadays, the fancy term is embryo glue. Is that PRP also used in embryo glue, or is it different substance?
No, embryo glue is separate, sir, that we use before embryo
What is the
transfer.
content in embryo glue? That's implant.
It has got like inflammatory and the non-inflammatory as well as immunomodulators in that.
Oh, okay.
Thank you, Dr. Lata. Any questions? Any more questions? Thank you for your valuable and extensive speech on PRP. I think it is more useful to the gynecologists. Thank you.
Okay. Let me felicitate first Dr. Kameshwari. He is CTV surgeon from Narayanadri Hospital, and he is going to give presentation on advance in aortic surgery techniques, risks and outcome. I request Dr. Jagan Mohan to chair this occasion.
I welcome Dr. Trilok, a renowned CT surgeon from Narayanadri Hospital. His talk is on advances in aortic surgery, techniques, risks, and outcomes. It's a pleasure for me to introduce him. He completed his MBBS from Siddhartha Medical College, Vijayawada. He did his DNB from Apollo Hospital, Chennai. He worked as a junior consultant for 1 year at Apollo Hospital, Chennai. He worked as junior consultant from 2019 to 20 from Kim's Hospital. He worked as consultant at Great Eastern Medical School, Medical College, Srikakulam for 1 year. He worked as consultant for 3 years at Medical Hospital, Nellore. Now presently, he is working as consultant cardiothoracic and vascular surgeon from 2023. Thank you.
Coming to the normal aorta is divided into various parts, like with the aortic root, which constitutes the annulus and coronary arteries, the ascending aorta with then arch with the neck vessels, and the descending thoracic aorta and the abdominal aorta, which bifurcates into the iliac arteries. So aortic aneurysm is defined as an abnormal bulge in the wall of the of an artery. So aneurysms are the most are 10th leading cause of death in worldwide, with around 15,000 deaths yearly. So atherosclerotic plaque formation rupture causes the increased risk of aneurysms in adults. In this presentation, I would like to elaborate more about causes, signs, symptoms, diagnosis, treatment, and prevention of aortic aneurysms. Coming to the definition, usually the size of the normal aorta is around 2.2 to 2.5 centimeters. If it's dilated more than 2.5 to 2.5 centimeters till 2.9, it's called preaneurysmal dilatation. Sorry. Aneurysm is aneurysm is a permanent focal dilatation of aorta, which is more than 1.5, 1.5 times the normal diameter of an artery. So coming to the aortic aneurysms, there are two main parts. That's the thoracic aortic aneurysm and abdominal aortic aneurysm. Abdominal aortic aneurysm or thoracoabdominal aneurysm is present in 85% of the patients will be infrarenal. In the location will be infrarenal, below the origin of the renal arteries. There is 10% cases who develop pararenal or juxtarenal location, and suprarenal is like 5% of cases. So infrarenal is the most common abdominal aortic aneurysm, which can be juxtarenal, no normal aorta below the renal arteries, aortoiliac, which involves the iliac arteries also, and usually it is usually the most common causes are non-inflammatory, atherosclerotic, and few cases which come from mycotic aneurysms. So this is a pictorial depiction of thoracic aortic aneurysms, which may develop. That is a first picture is the root aneurysm with ascending aorta. Second picture is the arch aneurysm, isolated arch aneurysm, and third part is a descending thoracic aorta aneurysm. So coming to the epidemiology, thoracic aneurysms are around six cases per 1 lakh year, 1 lakh patients. Abdominal aortic aneurysm is quite common in old age patients more than 65 years, and prevalence among men is quite more, almost double the in females. Coming to the etiology, the cystic medial degeneration is the most common cause, where smooth muscle dropout and elastic fiber degeneration occurs. In few genetic conditions like Marfan syndrome and Laritz-Moid syndrome, where the aortic aneurysm develops pretty in young condition, usually due to the mutation in one gene for fibrillin 1, which causes the aorta to dilate. And other cause is a bicuspid aortic valve, where they develop aortic dilatation post to the dilatation, post to the stenosis. And some few infective causes, rare causes are syphilis, where the spirochetes infect the aortic muscle layers and cause aortic dilatation. And few conditions like tachycardia, aorta arteritis, and which is quite common in young females. And other causes are like rare causes are aortic dissection and trauma. Coming to the risk factors, most common risk factors are smoking, age related more than 65 years, hypertension, hyperlipidemia, and gender. Males have double the prevalence compared to the females. Pathophysiology, there is usually develops due to the decrease in elastin level and increased metalloproteases, which causes medial thinning and intimal thickening and increased frequency of aneurysm. So dilatation and the proportion of the dilatation is physiologically by the law of Laplace, where the wall tension is proportional to the pressure times and the radius of the arterial conduit. So whenever the arterial conduit size is high, there is more chance of the tension proportional due to the pressure. So aortic aneurysms are quite common compared to the small medium-sized arteries like axillary or carotid arteries. So coming to the etiology, so because of the various reasons, tension is increased in and pressure is overload, and the increased radius will lead to increases the risk of rupture of aortic aneurysms. Signs and symptoms. So for thoracic abdominal aortic aneurysms, usually the cases are asymptomatic or vague symptoms like pain in the jaw, neck, and chest. So there could be some cough or dyspnea because of the dilatation pressing on the trachea, or pain during swallowing. Coming to the abdominal aortic aneurysms, the most common symptom is a pain abdomen or a swelling in the abdomen, which is a pulsatile swelling. The pain is usually radiating to the lower back, where patient has some features like vomiting, nausea, and constipation, and lightheadedness. Coming to the diagnosis, the first basic diagnosis investigation is chest X-ray, where there will be abnormal aortic silhouette, mediastinal mass effect, enlargement of aortic knob with tracheal dilatation, and change in the aortic contour. So here you can see an X-ray of ascending arch and thoracic descending aortic aneurysm, and this is a case of arch aneurysm. Aortography. Aortography is a conventional and gold standard investigation which has now been replaced by CT and MRI. Coming to the CT scan, usually contrast enhanced CT scan is performed to observe the morphology, pattern, distribution of thrombus or calcification, and visualization of the, if any, dissection flap or intimal flap. In the first picture, you can see a CT aortogram which shows descending thoracic aneurysm. This is another CT which shows ascending aortic aneurysm. So contrast CT can be used for reconstructing the aorta, also entire aorta, where this is the same case where the ascending aorta aneurysm is there, extending up to the arch, which doesn't involve the arch vessels. Next investigation is MRI, best for assessing true size, lumen, and vessel wall, and excellent for observing the vessel quality, and and you can be used for unstable patient, for less renal toxicity, but very not suitable for unstable patients. CT angiogram. CT angiography is commonly done for imaging thoracic aorta, which can be done for reconstructing the axial images to 3D with accurate diameter of the vessels. This is the MRI angiogram of a case where there is a saccular aneurysm in the arch. So echo is also a common and most commonly used investigation, where it shows dilatation of the aorta. May show severe atherosclerosis with enlarged aorta with eccentric wall thickening and echogenic thrombus if present. Good for unstable patients. This is another echo where there is an aortic aneurysm which can be seen quite large with the component of aortic regurgitation. Coming to the diagnosis of investigations for abdominal aortic aneurysm, usually the mass aneurysm can be felt through abdominal examination, palpation, where there is a pulsatile swelling around the umbilicus area. Ultrasound is the most commonly used, and rest of the investigations are quite similar for both thoracic and abdominal aortic aneurysm, which includes CECT. Coming to the differential diagnosis of thoracic aneurysms, so it can be misdiagnosed as an abdominal aneurysm or pulmonary embolism, MI, aortic dissection, or congestive heart failure or aortic regurgitation. For abdominal aortic aneurysm, usually it is misdiagnosed as a renal colic, appendicitis, or diverticulosis or inflammatory bowel syndrome. Coming to the management of thoracic aneurysms,
So first coming to the ascending aortic aneurysm, this is a flow chart which is taken from 2023 Indian Journal of Cardiothoracic and Vascular Surgeons, where the management changes with the size of the ascending aorta. So if the size is more than 5 centimeters, then surgery is prophylactically recommended. If there are so if the risk of mortality is less than risk of surgery after a mortality is less than 1%, then usually the patient electively goes for a surgery. If the ascending aorta's diameter is around between 4 to 5 centimeters, and the patient has features like Marfan syndrome or quite young with family history of aortic aneurysms, usually if there are complaints, then you will go for a surgery. If there is a high risk for surgery, high risk for death from surgery, or if the patient doesn't have any complaints, then we could wait for the surgery and usually follow up with 6 months CT angiograms. If the surgery is like if the diameter of aorta is between 4 to 4.9, if there is if medical management is recommended, if there are the risk more than 1% of risk for surgery or risk of death. So these are the surgeries which can be done for ascending aortic aneurysms. So in the first image, this is called the Bental procedure, where the if the aortic aneurysm is associated with components like bicuspid aortic valve or aortic stenosis or aortic regurgitation, usually we replace the aortic valve along with the ascending aorta, and the coronary arteries are reimplanted. This is called the Bental's procedure. The second procedure is a valve sparing, where we need not use a mechanical or bioprosthetic valve for replacing the aorta, replacing the valve. Here the valve is quite component. So valve is spared, and only the ascending aorta is replaced with surgery, and the coronary arteries are reimplanted. This is called the David's procedure. So coming to the aortic arch aneurysms, isolated aortic arch aneurysms less than 4 centimeters in size usually require 12-month yearly CT or MRI for any enlargement of size. If there is isolated arch aneurysm with more than 4 centimeters, usually it is followed up without any symptoms. Usually will followed up every 6 months. Surgical treatment is often required if in all symptomatic patients who have aneurysm size more than 5.5 centimeters, or if the size of the aortic aneurysm is increasing more than 0.5 centimeters every year. Usually the thoracic arch aneurysms, usually the proximal arch is involved. So usually the surgical procedure is called partial arch replacement, where the arch is replaced partially with the rest of the native aorta left intact. If the entire arch is involved, usually this is called done for a complete arch replacement. This is the case of this is a picture where showing its complete arch is involved with dilatation. So complete arch is replaced with 3 directions to the neck vessels. Coming to the descending thoracic aneurysms, TVAR, thoracic endovascular aortic repair, is the most common compared to the surgery. So TVAR is indicated if the size is more than 5.5 centimeters. If it's not possible, then surgery is indicated if the size of the aneurysm is more than 6 centimeters. So in few cases like Marfan syndrome, so TVARs are avoided because there is a chance of leakage and leakage from the grafts. So this is the case. This is the picture depicting the descending thoracic aneurysm. This is the surgical where the entire descending thoracic aorta is replaced within a graft. This is the pictorial image of TVAR, where the aortic aneurysm is replaced with a endovascular graft. Coming to the management of abdominal aortic aneurysm, usually usually the management depends on whether the aortic aneurysm is ruptured or unruptured. Ruptured is usually taken as an emergency surgery. Unruptured cases, we have to check for risk factors. Risk factors are age, physical activity, diameter, and gender with cardiovascular disease. Usually, the abdominal aortic aneurysms are managed by endovascular repairs (EVAR), where the graft is passed from the one of the femoral arteries and usually covers the entire abdominal aorta infrarenally. So, are there any methods for prevention for aortic aneurysm? Usually, it's risk factor modification like cessation of smoking, lifestyle modifications, hypertension, avoiding hypertension, and hyperlipidemia. Coming to the prognosis, prognosis is quite good with early detection, prompt treatment, and early surgical treatment. So complications of why the surgery or treatment is required for aortic aneurysm is so they might develop complications in future if not treated. So may develop blood clots, aortic dissection, circulatory shock, and mortality. So this coming to our experience, we have a single center with last 15 months. We did 6 Bentals procedure where all the procedures were involved. Either the complete aortic valve was involved. So among the 6 patients, 3 were male, 3 were female. The age distribution was between 34 to 58 years. Coming to the ejection fraction, two had normal LV function, 3 had moderate LV dysfunction, and 1 has severe LV dysfunction. The valve pathology, for all these patients, 4 out of these 4 had severe aortic stenosis, 2 had aortic regurgitation. So among them, the valve morphology was there. Among them, three had a bicuspid aortic valve, 1 had unicuspid aortic valve, and 3 had two tricuspid aortic valves. For all the 6 patients, prosthetic valves were used. 4 had mechanical valves, and 1 had bioprosthetic valve. And the mortality was 0. So I am showing a few. అయిపోయింది. అయిపోయింది. So I will show few videos and pictures which we had done. This is an aortic aneurysm who had a bicuspid aortic valve. So you can see the size of the abdominal aorta was around, thoracic aorta was around 8 centimeters. It's like ballooning more than the size of the heart. This is the same case after we replaced the aortic aneurysm with the prosthetic valve. So this is another case where the patient had aortic regurgitation with huge dilatation, focal dilatation in the thoracic aorta. The size of the aorta was around 7 centimeters. 8. So this is another case where the aortic aneurysm ascending aorta was normal, but there was dilatation around the root. No, sorry. So this is a case of aortic regurgitation where the leaflets were very much flail and there is no coaptation of leaflets. This is one case where we replaced the aorta with the Dacron graft, and this you can see in the middle part is the mechanical valve. This is another case where we replaced the aorta. This is another case where it was the unicuspid aortic valve with the complete calcification and complete the aorta was transected and replaced. And this was the picture after chest opening the chest of the same patient. Same patient. And the same patient was replaced with a bioprosthetic valve and the graft, Dacron graft. Thank you.
I thank Dr. Trilok for his wonderful talk. It's the most difficult subject, and your videos are very good. So once again, thank you.
Thank you.
For all the way coming from Tirupati.
Thank you.
Any questions from the floor? Okay, if questions are not there.
Thank you. Thank you.
Let me felicitate Dr. Jagan Mohan first.
So one question, sorry. How long?
I request Dr. Jagan Mohan to felicitate Dr. Trilok. Now we will go to the next session. I invite Dr. Sur Sen Raj, renowned surgical oncologist, onto the dais. He will speak on laparoscopic hysterectomy, post LSES stepwise approach.
'89 to '92. What that's
important steps in the laparoscopic system. So what are the issues? Access is one issue. Access to the abdomen is very, very important. More than half of the complications do happen when at this stage, access. These the other difficulties of laparoscopic hysterectomy, for that matter, any surgery, will be additions. Additions will be bowel additions or omental additions in general. And when it comes to a hysterectomy, it is usually the bladder that is a main difficulty for the surgeon. And sometimes anatomy may be different. Anatomy may be different. Sometimes we may see a patient with a unicornuate uterus with a different anatomical orientation, something like that. So that we should also be careful about that. So why this man is talking about complications, you may think. This is very important. During our laparoscopic surgery, for that matter, any surgery, particularly for pelvic surgery, these are the very important things we should always keep in mind. Number one is ureteric injury. Number two, bladder injury. Then bowel and vascular injury. This bowel and vascular injury happens usually due to during the access point itself, when we get a primary port. So always be aware of these complications while doing surgery. Otherwise, what we say, the eyes cannot see what the mind does not know. So what are the equipments that are best suited for these things? Good optics are important. A minimum is a HD. HD camera should be a must. If 4K is available, okay. And good telescope and monitor also, or medical grade monitor, are important. Now, when it comes to the 2D versus 3D, I would always prefer 3D. I have invested in 3D scope, and I am very happy about for the past 4.5 years, I am doing in 3D scope only. Why 3D means 3D gives a binocular vision, a two-eyed vision. So depth perception will be better. So the importance of having two-eyed vision is very important in general, and particularly so in surgery also. So I would always recommend, if anybody would like to invest, better to go for 3D scope. Then the other equipment, vessel sealer, ligature, harmonic, bipolar, and other monopolar, these are the routine instruments. Minimum instruments are bipolar, and good bipolar and monopolar are the minimum requirements. Vessel sealer is there, good. If it is not there also, it can be managed. Harmonic is also same thing. The other thing is power morcellation. Morcellation we can either do by powered morcellation with a motorized morcellation, or we can do with scissors.
So earlier times I was doing with powered morcellation many times. For the past couple of years, I'm not using a powered morcellation. I'm always using a scissors. Using a scissors at the vagina. Under vision, I cut the specimen and remove up to even 1 kg uterus also. So uterine manipulator, usage of uterine manipulator helps in preventing the uterine injury, ureteric injury. And myoma screw is useful when we are to retract a big uterus. So I already told you about Y3D. I'll go for some of the videos mainly. So access ports, primary port, the number one choice will be an open port where you incise the skin, subcutaneous tissue and the linea alba under a direct vision, and you see the peritoneum. You catch hold of the peritoneum with two artery forceps, then you cut the peritoneum, then only introduce the port. This is the primary preferable this one. So the other one is VC port. VC port nowadays I have shifted from open to VC port. VC port is a trocar which will allow you to see the layers as we pass in. I will show you in a minute. So various needle technique, various needle is also good, provided you give the pneumoperitoneum and then you can insert blindly also, or followed by various needle, you can even introduce a VC port also. Blind insertion without pneumoperitoneum, introducing a short trocar is not to be recommended, though some surgeons are following it. Videos. Yeah. So the stepwise approach I would recommend. First thing after introducing a trocar is a general survey. The first thing we have to see is whether did we injure anything. So rule out an injury as soon as you enter the abdomen. It may be a vascular injury or it may be bowel injury. It has to be the first step in the operation. And the general survey to see for any adhesions and all. That is another thing. Video. Okay, double. Thank you. So this is the VC port technique I was discussing. There is no pneumoperitoneum. I am just introducing with the camera in the port itself directly. You can see that is a rectus sheath. The white one is a rectus sheath. Now it is a peritoneum now. That is a peritoneum now. Now I am already inside the abdomen. Now I withdraw this thing. Now I can see through the camera now. So what you see here is what I do is a 3D scope. So the clarity will be less here because it is converted into 2D. So that is a general survey. Liver I am checking. So additions release. Momental additions or bowel additions are there. We have to release. The other thing is congenital sigmoid colon additions to the left adnexa will be there very often. At least to the IP ligament, very often will be there. And in almost 75% of the cases where I have to remove the ovary, I have to release the adhesions. Many people sometimes do not think that why we should release all the sigmoid colon. We can directly go to that. It will prevent proper vision into the uterosacral ligament, other things. So always better to release the adhesions. This is what the momental adhesions. This is ligature, but this is not a must. Ligature is not a must. We can either do it with bipolar scissors or even a cold scissors with occasional diathermy usage also we can do. But since sometimes to increase the speed of the surgery, sometimes we will take this thing because we don't know what is there in below in the pelvis. We have to first see the remove the adhesions and see what is there in the pelvis. So always be careful in seeing and doing. Even the tip of the instrument also has to be visualized, and thermal injury we have to prevent always. So these are not a very dense adhesions, but these have to be released very carefully and avoid injury to the bowel. And while removing these adhesions, always stay close to the parietal wall. If we stay a little below, what happens? The curtain of fat will be hanging from above, and it will ooze some fat over the camera, and we will be having trouble in having proper visualization. There is some colon here. You can see that. So some additions over the ovarian and fallopian tube also is there. This is being released. This is another case. This is another case. You can see the sigmoid colon being densely adherent to the left adnexa and parietal wall in the left iliac fossa. Unless I remove that, I will not be able to do a proper ligation of the infundibulopelvic ligament safely, because we have to take care of not injuring the ureter while doing this ligation or sealing of the infundibulopelvic ligament. So please bear with us. It is not as clear as we see in our monitor, and since I have found 3D, we are unable to present anywhere because the 3D projectors and all are not available. So we have to project only in 2D. So this is, you see, you can always see, once you divide some loose areolar tissue there, the left adnexa will be very clear. So this is of the left fallopian tube and ovary, and there is some moss-like thing all is there. So we have to safely release all the adhesions and stay close to the ovary and fallopian tube rather than to the sigmoid. So leave small amount of fat should be on this side only, towards the bowel only. Don't leave any fat on the uterus, because fat belongs to the bowel. That is the rule. Either fat belongs to the bowel or fat belongs to the bladder, not to the uterus. So fat is there. That means you have to stay even more close to the uterus or the adnexa. So this is where it is even adherent to the even lower down also. Here I'm using a bipolar for retracting, and on the right side there is a monopolar hook. A simple basic instrument, so we can do all these things.
Hello.
Can fast forward.
Check.
Fast forward. No problem.
Check.
So this is for the other step is fundal structures. Always fundal structures, everybody knows, round ligament, infundibulopelvic ligament or ovarian ligament. But one important step here is many surgeons may not be doing that. Always create a window in the posterior leaf of the broad ligament below the ovarian vessels. So that window creation is a very important thing. You can see in this video. So round ligament I am catching hold, and I am dividing with a bipolar shearer. This is a bipolar instrument, is a good instrument. Earlier I was not using it for fear of increased thermal this thing, but slowly I have learned to. Many surgeons are nowadays using this bipolar shearer.
Hello.
It is a little more cost effective than the other vessel sealer like ligature and all, and harmonic. Harmonic and ligature are pretty costlier, and sometimes they go for even 2-3 cases also, and recurrent expenditure is very heavy, and we cannot increase the cost of surgery. So you have seen that I have created a window in the posterior leaf of the broad ligament, and now I am tackling the ovarian ligament. So always, while doing this step also, take care to leave some amount of ligament over the uterus and divide little away from that. Otherwise, what happens, the general tendency is it is going to be removed, the specimen is going to be removed. Why should I stay little, leave it? We will stay close to the uterus. If we stay close to the uterus, what happens now? After some time, it will retract and bleeds. So it will spoil the whole field. So the other step is open up the broad ligament. So opening up anterior and separating anterior and posterior leaf of the broad ligament is very, very important, and it decreases the ureteric injury risk also. So identify the proper plane between the bladder, cervix and vagina, and stay just anterior to the uterine vessels. I will show you that why just staying anterior to the close to the vessels is important. And post LSCS, very often we are seeing patients with post LSCS. So bladder will be densely adherent, sometimes even up to the fundus also. We have to tackle all those cases. So the technique of post LSCS is again going lower down and finding a virgin plane and coming up rather than from above downwards. I will show you again.
Hello. Check.
So this is the bladder dissection. This I think proper. A simple case only. anterior leaf of broad ligament is continued downwards, and I am doing the dissection between the bladder and the cervix. So a combination of bipolar and monopolar. My preferred instrument for this dissection is always a monopolar hook, because it's a versatile instrument and always a sharp dissection. I will never push the bladder down with a mop or gauze piece. Even during open surgery also I don't do that. There is not much difference between open surgery and laparoscopic surgery. So the same way you have to do laparoscopic surgery also. Same principles and all. Only thing is the instruments will change and pneumoperitoneum will be there. So it is in a way easier retraction. This is a bladder I am separating. You can see sometimes there will be little additions even in a normal case also. We have to find the proper plane and do the dissection. Usually the bloodless field will be there. Very rarely we may see some blood there, but otherwise usually it is a bloodless field dissection. You can see the loose areolar tissue being divided. The tissue can be sometimes pushed with the L hook itself, or sometimes I will keep on dividing. This particular vessel I am dividing now is very important. This is near the vesico-uterine this thing vessel. Unless you do this thing, the bladder will not fall little below. Why bladder should fall below? Because to safeguard again the ureter. So I will have a long length of uterine vessel to divide if I do that one. This is on the other side also I am doing the bladder. This is on the right side. Till now I was doing on the left side. This side also I am doing it here. So bladder, if it goes down, then you can see the uterine also. Already you are seeing the uterine vessel here. That's the uterine vessel here. You can see that. So this is again another case post LSCS, I think. I am finding the plane between the bladder and this thing. I am trying to find out what I am finding below is the uterine vessels. These are the uterine vessels below my hook. So I am trying to stay just anterior to the uterine vessels. So if we are afraid of uterine vessels and stay away from the uterine vessels, you will not find the proper plane. Always stay close to the uterine vessels. At the same time, be careful that this my hook may be little hot. So you should be always mindful of that. So you should give enough time for the heat to dissipate and then touch it. So even when I touch the uterine vessels, I will last in for a very short time. Heat transfer will not be there. So the uterine vessels I found out, and then lateral window technique, this is called. This is the lateral window below, and then I have come from above. So a combination from below upwards I come. This is the window. You can see that. You can see the window. This is a clear window. So once I see the window, then I come up. The reason for this is cesarean additions will be at a particular level. Below that level, there will not be any additions. So you have to find that plane first below, then come up. So the least risky approach is this thing. So you can see that I am coming from below upwards, not from above downwards. Above downwards, you can stay close to the uterus and do that, but there is always the risk of injuring the bladder. This is the safest way. Go below and laterally find a window, virgin plane, then come up. So this is a continuation of the bladder. Bladder dissection is the main important step in doing the surgery. Now my manipulator is there, vaginal manipulator. Colpotomizer is there. That ridge-like thing is the colpotomizer. Redness. This is the ridge-like thing. So there is a cup-like thing there in the vagina that is pushing the cervix upwards and safeguarding the ureterus on the lateral side. At the same time, I know where I am dissecting. So there are surgeons who do not use a manipulator. They will keep doing like that. Of course, it is a personal choice, but I prefer this is a good thing. So bladder dissection is the ultimate test of this thing as far as the laparoscopic hysterectomy is concerned. Always stay safe and be close to the uterine and vagina, cervix and vagina. So some vessels are still there on the left side. I am dividing that one. And then you can see the uterines clear. Below that, yeah, that is a bit uterines. So the next step is division of uterosacral ligaments. Uterosacral ligaments, always I divide. The reason is, by the time we divide the uterosacrals, the ureter and the posterior leaf of broad ligament will be lateralized. they just go a little lower down, and again I am again safe. I am always safer on the ureter. So that safety is of predominant importance. If you don't injure the ureter and bladder, you are a good surgeon. That means. So the other thing is division of uterine vessels. Either I can use a sealer or a bipolar or harmonic, but my preference is a vessel sealer. I always use a ligasure. For uterine vessels, I will never take a chance. I will always use a ligasure. And then the next step is everybody knows cardinal ligament division. I will show you a few steps here. So this is the posterior leaf of the broad ligament. I am going onto the uterosacral ligament. I am using a bipolar shearer here. This is a versatile instrument, but even a monopolar hook also I can manage. I indeed prefer many times a monopolar hook rather than this bipolar. Sometimes there will be some oozing, and then I can use a bipolar. So you can see the vessels. I am just staying close posteriorly to the vessels. What we see anterior to the little blue color is the uterine vessels only. So now posterior marking I am making on the this thing. Uterosacral ligament thickness is there. You divide the uterosacral ligament, the movement of the uterus also will be better. Now I am taking care of the right uterosacral ligament.
Check.
So again here I am using a bipolar shearer. Bipolar shearer is a very good instrument, but we should be very careful. It is a little thermal spread will be there, and there is no outer coverage. Outer covering is there for ligature, but for not for this thing. So you should be very mindful of not touching any bowel or other sensitive important things. Now I am using a hook. You see, it is always a combination of instruments. Never one instrument is never superior to the others. Always a combination. We can use a combination of instruments. So I am just marking on the posterior this thing also. So the other thing is a colpotomy, and then once colpotomy is done, extraction of the specimen, and sometimes very often the cases we do, uterus is not a normal size, it will be bigger one, it will not be coming out of the vagina. We need some morcellation. So this is the colpotomy step. Many surgeons use the hook only. There are some people who use a harmonic also for this thing, but it's a wastage of resources to use for colpotomy. It's always a hook is a better thing. I'm on the left side now. So most of the times it will not be oozing. If there is any oozing, I can use a bipolar. You can see this is a posterior left uterosacral ligament. Some ooze is there, it can be managed. So that is a colpotomizer. What you see white one is a colpotomizer that I kept from below. So this is on the right side. So we do not lose much blood in a laparoscopic hysterectomy unless sometimes some vessel gets slipped. Very often the blood loss will be from the uterine side, specimen side, not from the uterine or this thing. So that is our colpotomy. Video this next is vault closure. I am trying to rush off as early as possible. I know time is very important here in a conference. This is about intracorporeal closure. This you can see that I use a vicryl. 1 number 1 vicryl I use. I prefer interrupted stitches, and the lateral stitches I only put 3 stitches, a figure of 4 or a mattress, horizontal mattress stitches, and the central one will be the one. The other lateral ones I include always the uterosacral ligament. Always include the uterosacral ligament so that the patient will not have any prolapse. So this suturing also, if you can see, of course, this is a little 1.5x speed. Still, suturing is always better in a 3D laparoscope. 3D gives us the depth, so there is no imagination left. Otherwise, we have to imagine the depth and keep doing the surgery. So suturing is very good and easier and 3D scope. Unfortunately, I cannot reproduce what I see on my 3D monitor here, because it is being converted into 2D, and then here we are again projector also there will be some loss. See, there is a little ooze there while taking the suture, but it will be controlled while after suturing itself. The next suture video on the Yeah. So this is, I think, check cystoscopy. I don't do it routinely. Though this is the right ureteric opening. This is the left ureteric opening. You can see that this is the left ureteric opening. So sometimes a difficult laparoscopic hysterectomy, big broad ligament fibroid, something is there. Always better to make it sure that there is nothing, there is no injury to the ureter. That is one of the method I will do. If there is 2 more minutes, I will take few more slides, sir. No, sir. Thank you. So I would like to talk about the ureteric injury because there is no surgeon probably who has not injured a ureter during his lifetime. Pelvic surgeon, I mean. So always be careful, and learning curve, it may happen during our early stages, but we should keep learning from our mistakes as well as from others. So in laparoscopic, as concerned with laparoscopic surgery compared to the open surgery, we are always using a energy source for vessel ligation, like a sealing and all. So they always produce heat, whatever the company fellow says, either harmonic or ligature, anybody, my temperature is very controlled, sir. Whatever it is there, still there will be some temperature. You will recognize when you use a laparoscopic instrument during open surgery when your fingers are there. So sometimes we do that when we can see it is just so hot. Sometimes we use a bipolar, then we touch the tissue. It is so hot, even 10 seconds later also. So that is why sometimes we use a more bipolar and all, use an irrigation, normal saline irrigation, that will reduce. Otherwise, what we do, we rotate the uterus. I want to do the left uterine, I have done. Then I go to the right uterine, and then the sister is asked to shift this thing, and that hot uterine stump will be touching the bladder on that side. So that can injure the bladder. So this may seem, some people may say this fellow is too panicky and all. This is not panicky. It can happen. It can happen. One day or other it can happen. The other thing is when we use a hook is better actually. Spatula is there. Spatula is a little wider. A spatula will be little, it will take little longer time to reduce the heat. So spatula is there, then you are done it, and then you want to push the bladder and see. Once you push the bladder and you keep in touch for even 2-3 seconds, that heat will transfer. If you just do like this, it's okay. It should be in milliseconds. If you are touching with a bladder, this thing, it should be in milliseconds. Otherwise, that heat transfer will be there. So the sites of ureteric injury, the most places at risk are, one is at infundibulopelvic ligament. Infundibulopelvic ligament, that is one place where ureter can get injured. The other thing is, as it crosses the uterine vessels, everybody knows water under the bridge. So uterine vessels are above, ureter is below. But here, even if we want a little push, the ureter will not go. The reason is, there is a vessel, specifically a small vessel is always there, that comes from the uterine artery to the ureter. So that will be hanging like this, ureter. Even if you push ureter, it will not go. See, during radical hysterectomy, we will see that clearly. So in open surgery, we will not see that. But you should be aware of that. There is some connection between the uterine artery and the ureter. So there is a limitation for it to be pushed. So that is why we take all the care of avoiding an injury by dividing the posterior leaf of broad ligament, uterosacral ligament, so that it falls little away from the site of injury. So the other is at vesico-ureteric junction. As at vesico-ureteric junction, again, it is at risk because we think we are dissecting the bladder, and then we think we are on the uterine vessels or stump. In that stump, there will be ureter. So always be mindful of that. These are the 3 places that ureter can get injured. And ureteric injury, if you do not recognize in time, it will lead to ureterico-vaginal fistula and requires sometimes surgery. Sometimes a stenting may be good enough. So always avoid ureteric injury. Again, about injury, avoiding injury. Avoiding injury is the most important thing. That's why I have included a few steps in, though it is not a part of this thing. So how to avoid injury? A broad ligament fibroid is there, a cervical fibroid is there, or if you want to operate on an endometriosis patient, it is always a good thing to stent the ureter. Take the help of your urologist available, stent the ureters, and then keep doing the surgery. So you will be seeing the ureter better and you can avoid. So then about the endometriosis, deep endometriosis, do not do a laparoscopic hysterectomy. My recommendation would be, please try to avoid a laparoscopic hysterectomy, even if we are doing 100 cases per year also, laparoscopic hysterectomy. deep endometriosis is different. So that deep endometriosis laparoscopic hysterectomy has to be done by a fellow who daily operates on a endometriosis. That should be reserved for a super specialist who takes care of endometriosis exclusively. So that is why deep endometriosis is there. I will not say. I will convert the patient. Then already I talked about lateralizing the ureterus. I already talked about that. Beware of the heat injury. I already discussed. Then irrigate after energy device use. Yeah, that's a good thing. So bladder injury, how to avoid? So always use the sharp dissection. Visualize the bladder always. If you are doubtful, inflate the bladder, and at the end of surgery, again inflate the bladder if it is required. I don't do it routinely, but if there is any suspicion that I stayed close to the bladder and I have even some minute suspicion that I would have injured mucosa, I would do that. I will just inflate the bladder and see. There is nothing wrong in seeing that. Check cystoscopy. So I would conclude my talk. I could not include many of the difficult cases here because this conversion of 3D to 2D to again this MP4 format is taking time, and my assistants helped me a lot, my staff, but still I could not make it. And in view of time also, I restricted my videos. So I would like to conclude, always have good optics. Laparoscopic surgery, always have good optics. Optics is number one. 3D is the best, I say, but even if it is 2D, it should be HD. Then appropriate instruments. Appropriate instruments mean bipolar, good bipolar is a must, basic. Above that, ligature and harmonic, okay. Even if they are not there, you can do that. Then be mindful of the risk. Always be mindful of the risk. Starting from the port, first port itself, you should be very careful. First port injuries are sometimes very, very dangerous. There are injuries that happen to people have put the port into the aorta, mesentery, and many things have happened. So never underestimate laparoscopic hysterectomy. And the other thing is ureteric injury. Always be mindful of ureteric injury. Keep seeing the ureters now and then if you are doubtful. Do a window and then stay close to the uterus. And then the final word is always never hesitate to convert to open surgery at appropriate time. Many times what happens is the difficulty is there. The camera surgeon is also another equally competent surgeon. Then that surgeon will be saying, no, sir, you can do this. I think you can do this, they will say. But you should know. And it is always difficult to convert to laparotomy before producing a complication. If you produce a bowel injury, dense adhesions, then converting, then it is a nuisance. Then also you will be losing time as well as you are putting the patient under parenteral nutrition for longer time, hospital stay prolonged, unnecessary tension and all. You don't have a good sleep. So when it is a case for open, if you get a doubt, don't spend more than 5 minutes in deciding it, and even give the benefit of doubt into conversion. Always explain the patient to before surgery itself, there is always a possibility to convert. So I conclude my topic here, and I once again thank all the audience here for patient listening, and senior faculty, and Dr. Vijay Kumar Garu. Thank you, sir. Thank you once again. If there are a few questions, I will always take it here,
Yes.
or even during lunchtime
Dr.
also. I will take.
Surasen Raju excellently explained about many practical points. I think many gynecologists are there and surgeons are there. They can have easy question.
Hello.
Sir.
I think I should compliment you on your expression, and especially on one thing that's most important is in endometriosis.
Yes, sir.
If you are not doing it daily, you shouldn't be attempting it. It should be only for the people who do it all the time.
Yes, sir.
Because I used to go and help the people who are doing the endometriosis, and those ones I have seen them. Therefore, you always have to have a surgeon of caliber.
Yes, sir.
Also next to him, so that if you have to resect the rectum, you resect the rectum at the same time.
Yes, sir. Thank you, sir. Thank you. From senior person like you having a comment, I appreciate.
Practical doubts from the gynecologist? Because almost every time you are doing hysterectomy, na?
I always say to my gynec surgeons, it is difficult to operate endometriosis rather than pelvic malignancy. CA cervix is not a difficult surgery. CA endometrium is not a difficult surgery. Ovarian cancer may be difficult, but equally difficult is endometriosis. Only thing is you have to see a good endometriotic surgeon, surgeon who operates on endometriosis to appreciate that you should not be doing that. If you see a good surgeon who is operating endometriosis, then you will not operate. If you don't see them, oh, okay, this is what we do anukuntam. That is wrong. You should see a good surgeon who operates endometriosis, then you know that you should not be doing it. That's why I do not do a endometriosis patient, deep endometriosis, I won't do it. Minimal endometriosis, I can manage, stent it, and I do it. Deep endometriosis, I will not do. That is the thing. Thank you, sir.
Dr. Sain, sir, it was a wonderful, it's a routine topic, but the presentation was quite meticulous. And he stressed more on the complications part. That's for a surgeon, for anybody, even for the small surgeons who are upcoming surgeons, even for the gynecologist. I think it's a must to know the complications. Thank you, sir. Thank you once again.
Small moment for chairperson.
Okay. Manur sir.
Sir. One topic is. This session is, I invite Dr. S. Praveen Kumar Reddy, interventional cardiologist, is going to give presentation on hyperlipidemia and atherosclerotic cardiovascular disease. Now I request Dr.
Kumar Reddy.
Yes, Praveen Kumar Reddy garu. Did MBBS from Venkateshwara Medical College 2001 batch. Finished MD in 2013 from Narayana Medical College. 2019 finished the DM cardiology from SWIMS. He works as a tutor in the pulmonary medicine in Anantapur Medical College. Assistant Professor of Department of Cardiology SWIMS in 2020. 2022 consultant interventional cardiologist in Bhimavaram Hospital, Bhimavaram, and now presently working in DVR and SK Hospital. The present topic is hyperlipidemia and the atherosclerotic cardiovascular risk assessment. Please carry on the topic.
Thank you. Thank you for inviting me to this conference. Today's my topic is hyperlipidemia and atherosclerotic cardiovascular disease. So these are the common components of a lipid profile we see regularly in our clinics. That includes total cholesterol, HDL cholesterol, LDL cholesterol, triglycerides, apolipoprotein B and lipoprotein A. And the non-HDLC cholesterol, which is calculated by subtracting this HDL cholesterol from total cholesterol. This non-HDL cholesterol is very important, and we'll discuss about in next slides. This is a slide showing the metabolism of these lipoproteins. These lipoproteins are the carrier molecular structures that carries this triglycerides and lipids from to the tissues. So, following the food intake, this intestines produces chylomicron lipoproteins. They carry triglycerides and cholesterol, and they deliver these triglycerides in peripheral tissues. And what is left out is chylomicron remnant that contains more cholesterol and less triglycerides, and this is taken up by this liver. During fasting, the liver delivers this VLDL that packed the lipoproteins with triglycerides and LDL and cholesterols, and they release this VLDL in the peripheral tissues. That means in the adipose tissue and muscular tissue, they release triglycerides by activity of lipoprotein lipase and converted into intermediate density lipoproteins. Further release of triglycerides, it converted into low density lipoproteins, which is taken up by the liver, or it can deliver the cholesterol to the peripheral tissues. We notice that the atherogenic cholesterol is not only represented by this LDL, but it also included remnant cholesterol. So both the LDL and remnant cholesterol together is a non-HDL cholesterol. So we talk about non-HDL cholesterol. What is more specific is this apolipoprotein B. As we talk, this lipoproteins, they have structure where the inner core is made of cholesterol and triglycerides, and outer shell is made up of phospholipids, so that these lipoproteins are more soluble in the blood. But this outer phospholipid shell is more stabilized by these apolipoproteins. So one of it is apolipoprotein B. It is present in every molecule of non-HDL cholesterol. So as we discussed, HDL always removes the cholesterol from the peripheral tissues. So HDL associated cholesterol is considered good cholesterol, whereas LDL cholesterol and remnant cholesterol and lipoprotein A related cholesterols, they cross the intima and get deposited in the coronary vessels and forms atherosclerotic plaques. As we discussed, the high levels of this LDL and remnant cholesterols, they cross the endothelium and deposited in the intima of the coronary vessels, inside inflammation, form foam cells and atherosclerotic plaques. This side, India is in CVD epidemic, where there is a large number of Indians having coronary artery disease, and there is also in our India 10 years earlier than Western population onset of coronary artery disease, and there is a more amount of mortality. These are the graphs showing the prevalence of this lipid abnormalities in our country. In Andhra Pradesh, triglycerides of more than 150 milligrams are seen in at least 25% of people, where LDL cholesterol more than 130 is seen in 15 to 20% of people. One commonly ignored component is the lipoprotein A, which is found in 1 in 5 of the people, which is always genetically determined and independent of these other risk factors. That means the patient, even the patient has not having any risk factors, that means no diabetes, hypertension, or smoking, still the patient is very high risk for developing the coronary artery disease. What is special of this lipoprotein is it is like a LDL protein associated having the apolipoprotein. It also is having a apolipoprotein A, which has plasminogen-like activity. That is plasminogen-like activity. It not only causes atherosclerotic plaque, but also causes clots in the coronary vessels. Another commonly ignored is the familial hypercholesterolemia, which is found in 1 in 300 people. So, in familial hypercholesterolemia is due to mutations in the LDL receptors or apolipoprotein B or PCSK9 proteins. It causes reduced LDL functional receptors and causing elevated LDL cholesterol and causing atherosclerosis and coronary artery disease at a very early age. You can see coronary artery disease, these are two types, homozygous familial hypercholesterolemia, heterozygous. In homozygous, these patients develop coronary artery disease before the age of 20 years. Whereas heterozygous forms patients, they develop coronary artery disease very prematurely, before the age of 55 in male and 60 years in female. This is a Dutch lipid clinical clinic network diagnostic criteria is the screening tool to diagnose the familial hypercholesterolemia. A score of more than 6 is considered a probable familial hypercholesterolemia. When we suspect familial hypercholesterolemia if the LDL levels are more than 190 and a family history of premature vascular disease. That means in any siblings or parents who develop a coronary artery disease less than 55 years in males and less than 60 years in females. And on physical examination, presence of tendinous xanthomas or arcus cornealis before the age of 45 years, we suspect familial hypercholesterolemia. So we came to know the importance of this identifying these patients. Next slides. So diagnosis of hyperlipidemias. By this, we came to know that total cholesterol is a very poor predictor of atherosclerotic vascular disease, and even LDL cholesterol also gives the atherogenic cholesterol. It is bind to the LDL only. So the best predictor is always the non-HDL cholesterol, which always gives the LDL cholesterol in addition to this remnant cholesterol. Another important marker is apolipoprotein because it is apolipoprotein protein B is present in every lipoprotein of this non-HDL cholesterol. So it is also a better marker of total atherogenic particles in the body. So this I will discuss what we get in the lipid profile components. This I want to show the slide because though triglycerides does not incite inflammation atherogenic plaques, but still we considered triglycerides more than 150 milligrams per deciliter as a marker for coronary atherosclerotic disease, because as we food intake, remnant cholesterol and triglycerides, they rise parallelly. So we take triglycerides indirect marker. Any triglycerides of more than 150 milligrams per deciliter is indirectly suggests the remnant cholesterol is elevated. So what to consider? What sample to consider? Non-fasting or fasting sample. So it's not current guidelines recommend using also non-fasting sample, because non-fasting sample there is little changes in the total cholesterol or LDL levels, HDL levels. So only triglycerides changes by 20 to 30 milligrams. So non-fasting sample is considered, not compulsory fasting sample, unless the patient triglycerides levels are more than 400. We consider fasting sample. Next is a lipid lowering therapy. The Cardiology Society of India and Lipid Association of India, they provide guidelines for the dyslipidemia management. So the management is based on the lipid goals, depending on the risk for atherosclerotic coronary vascular disease, development of atherosclerotic vascular disease. So in low risk patient, that means the patient has no risk factors, keep the LDL levels below 100. If the patient has any single risk factors, diabetes, hypertension, or tobacco, or any family history of atherosclerotic cardiovascular disease, keep LDL less than 100. If the patient has two risk factors, diabetes with hypertension, hypertension with diabetes, and the patient with heterogeneous familial hypercholesterolemia. That is heterogeneous familial hypercholesterolemia, we consider as a double risk factor. That is why it is always should not be ignored. We keep these LDL levels in these patients to less than 70. Very high risk patients means those who have established atherosclerotic cardiovascular disease, or those with diabetes of more than 20 years, or diabetes with organ damage. That means diabetes with retinopathy and neuropathy, nephropathy. These patients consider very high risk. We need to keep the LDL levels less than 55. And those with extremely high risk patients means recurrent coronary events or any coronary event followed by any cerebral event. So we consider these patients extremely high risk patients, and we keep the LDL levels less than 40. So we talk more about the LDLC and the ApoB levels. So what the corresponding non-LDLC and ApoB levels are? LDLC levels of 100 milligrams corresponds to 130 of non-LDLC and apolipoprotein of 100. And this one. Then how to manage dyslipidemia in acute coronary syndrome patients? First, you do a non-fasting or fasting lipid profile and start a high-dose statin therapy with ezetimibe. We repeat lipid profile after 4 weeks. If that goal of LDLC is less than 55, that means there is a lipid goal in acute coronary patients. So LDLC is not achieved, then you add bempedoic acid. Then repeat lipids again at 8 weeks. If it is not achieved, add PCSK9 or inclisiran and repeat a lipid at 12 weeks. So if the lipid able to achieve that levels, then we need to repeat at 6 to 12 months, depending on patient compliance. So these are commonly available statins. So one is atorvastatin, rosuvastatin. What is high intensity is 40 to 80 milligrams, and moderate intensity is 10 to 20, and low intensity is 5 to 8 for atorvastatin, and rosuvastatin 20 to 40 milligrams for high intensity, moderate intensity is 5 to 10. So these are the intensity of the lipid lowering treatment and average LDL-C reduction. For moderate intensity statins, that is atorvastatin of 10 to 20 mg, they have 30% reduction in LDL-C. With high intensity statin, means atorvastatin of 40 to 80, we have 50% reduction in the LDL-C. That is the main target to achieve in acute coronary syndromes. Always acute coronary syndromes start with high intensity statins. Next is high intensity statin with the ezetimibe, the reduction of 65%. If you add bempedoic acid on above it, there is additional 15% reduction in the LDL-C. Next is PCSK9 inhibitors, 16% reduction in the LDL-C, then or inclisiran also 60% reduction in the LDL-C, and PCSK9 inhibitor with high intensity statin 75%, and PCSK9 inhibitor plus high intensity statins with ezetimibe of 85%. So these combinations are most commonly used in familial hypercholesterolemia patients where the LDL levels are very high. So this is the chart showing the mechanism of action of these antilipidemic drugs. So the bempedoic acid and statins, they inhibit the production of cholesterol in the liver. So the liver produces more LDL receptors and recycle to the surface, so that LDL clearance will be high. So ezetimibe has similar action, but it increases absorption of cholesterol from the intestine, lesser cholesterol availability in the liver. So what happens is the liver produces more LDL receptors and more LDL clearance from the plasma. Next, what is this PCSK9 inhibitors and inclisiran? So PCSK9 is a protein that bind to this LDL, internalized LDL receptors and inhibit recycling to the surface. So by using this PCSK9 inhibitors, the inclisiran, they inhibit this PCSK9 protein. So more availability of the LDL recycled to the surface and more LDL reduction will be there. So we came to know the statins. The effect is very high, side effects are very less. So statins reduce 50% of LDL cholesterol, they reduce coronary events by 50%, they reduce mortality by 20%, but the side effects are only very minimal. So 1:1,000 muscle symptoms, only muscle pains, so 1:1 lakh the people may have rhabdomyolysis. But still the patient, many outside the patient aren't able to get this high intensity statins, thinking of these muscle symptoms only. We need to fight this against this. So the lower is always the better for LDL-C. Even as low as 30 milligrams per deciliter is better. There is no lower limit for LDL-C, and that will help stopping to the patient. Always strike early and strike strong for LDL-C, because starting high intensity statins at early stages will stabilize the plaque, reduce the inflammation, and reduce the formation of thrombus and also recurrences. So always strike early and strike strong. But unfortunately, only 10% of the patients only receive according to these guidelines, according to the strike early, strike strong. Most of the patients, even 70 to 70%, more than 90% of the patients, they're not able to achieve that target of less than 55 milligrams. So they are more prone for the recurrences. Next, triglycerides and remnant cholesterol treatment. Triglycerides means more of a calories time. So always eat less, exercise more. High intensity statins, fenofibrates, and icosapentae. Next is lipoprotein A. There are no targets available yet. That means this is really genetically determined. The levels cannot change with any of drugs. That means there is no role of statins, ezetimibe, or fibrates in reducing these lipoprotein levels. Only PCSK9 inhibitors only reduce the lipoprotein levels by less than 25%. So what to do if lipoprotein, what to do next? That means aggressively control these risk factors, means treat hypertension, diabetes, and keep LDL levels as low as possible. That means using high intensity statins, ezetimibe, bempedoic acid, and PCSK9 inhibitors. So finally, a healthy lifestyle is very important. LDL-C should be our primary target. And throughout the range of LDL-C, lower is always better with no lower threshold. Also, earlier reduction of the LDL-C is better. Apoprotein B is a better measure of the exposure to pro-atherogenic lipoproteins, and non-HDL-C is the accurate predictor of CV risk, and there are no known adverse effects of very low LDL-C levels. Thank you.
Uh, nice topic. Covered extensively about the management of the hyperlipidemia. And the I think you have covered all the PCSK inhibitors also. So when the high intensity statin therapy is not working, then we can add PCSK inhibitors and inclisiran, the small RNA inhibitors of the LDL reuptake. So very rarely we see the patients who is not under control with the statins, probably with the genetical familial hypercholesterolemia, hypertriglyceridemia, or the conditions sometimes difficult to treat. In that case, hypercholesterolemia, we can add a PCSK9 inhibitors, which is available in the market now. Thank you for the extensive coverage. Thanks.
Any questions from the floor?
Any question?
Small memento for Chairperson Venkatramana. Felicitation of Dr. Praveen Kumar sir by Dr. Venkatramana. Next topic, Dr. Keshav Reddy sir. Kindly come on to the stage, sir. Regarding topic.
Dr. Chandrasekhar Reddy also accompanying.
Niranjan Reddy sir will give small introduction about sir.
Good afternoon, everyone. It's indeed a honor to have Keshav Reddy sir deliver a lecture today. A very known personality in the field of bariatric surgery. At present, he is the director of London Obesity Center and consultant GI invasive surgery at Continental Hyderabad. He's trained from SV Medical College, Tirupati, and later on MMC. And after that, he spent a lot of years in Mayo Clinic also. His past affiliations are with the London Clinic. He's headed the director of bariatric surgery, Homerton University Hospital, London, senior lecturer and consultant surgeon in Royal College Hospital and Homerton University Hospital, appointed professor and head of surgical department in Deccan Hospital, Hyderabad in the year 1994. He is the first person to establish the surgical department in the Medicity Hospital in the year 1997, started laparoscopic surgery in 1990, developed advanced laparoscopic surgery in the Royal College Hospital, London, started the laparoscopic bariatric surgery in Royal College, London in 1998, which is the first in UK. He has a number of publications and abstract on bariatric surgery, which most of the bariatric surgeons would have read about. He is also the examiner for MBBS in UK, apart from bariatrics fellowships, etc. Done a lot of work and notes on natural orifice surgeries from 2005 to 2008 in Germany. This is Sir's a bit small biodata. He has much more. Without much time, I'll give it up to Sir. Thank you, sir.
Thank you very much. Can you hear me? I'm not sure whether you can hear. Yep. Okay. Right. This is a topic just before your lunch. May not be the right one, but still I will manage to speak to you. As I already spoke to me, what my background is. But my motto is surgical service, integrity, empathy care, and surgical transfer. That's why I come back to India, and I'm in Continental Hospital. I'll speak about generally initially. I don't make any surgeries here because that's mixed audience we have. First of all, we don't know what is obesity, and we call everybody obese. Weight is not obese. And everybody who knows about the metabolic syndrome, they have 5 components. 3 of them are, one is waist circumference. Second is the triglycerides. Then you have the HDL, and you have the BP, blood pressure, and sugar. These are the ones. There's nowhere the weight has come in, because BMI is one of the easiest way to measure for insurance companies in 1800s, late 1800s. That's how it comes. Anyway, coming to that actual one, what we should measure is the waist circumference here, above the iliac crest. That's where you need to measure. And then the waist to height, that's the most important. And whether it should be 0.5 and below half is okay. 0.6 and above is more. And same thing, waist to hip is another one. And that's 0.85 for women, 0.9 for men. And these you have to take into consideration. Of course, now the body fat composition we can easily measure, and therefore that's what we have to look at. A simple tape is enough. That's all you need, and better than anything else. And this is what measure. If you look at here, the waist circumference and the height, 0.6 and above, even if you look like me, skinny, still if you have a belly is big, then you will become what? Metabolically very active, and therefore you have a high risk, very high risk, not just risk. And some of them being children, this is one of the tests they have done. Children have been wrongly categorized as obese when they're not. And therefore, this is another thing. Of course, waist to hip ratio, we already talked about it. And therefore, we need to target all our medications, education, surgeries, everything, all towards that goal, how to resolve their problems, metabolic problems. And that's what it is. This is the simple mission in body. We generally routinely do this so that we know what they have. I've just put this to show, if you look at that, the BMI is 37.8, but see the waist to hip ratio, 1.13. And also you have the visceral fat is 24. That's very high. Whether it should be under 10. And that's why waist circumference is the most important, not anything else. Of course, if you look at this was study actually in India, ICMR and NIN has done in 2020, 22. 48% of the urban population is obese, and almost similar amount in the rural population in Andhra Pradesh are also obese. Of course, half the population of the world becomes obese by 2050, and we also 1/3 of the population. That means 400 million become obese by that time. Right, let's come to what can cause the obesity. Root cause, we need to know how to treat it, otherwise we do not know. I'll talk a little bit because this is very important. increased calories is not just a simple calories. It should be high glycemic index foods, the processed foods. Second is frequently picking on the food, keep on eating. And that you should have at least 3 to 6 hours gap between any food, whether snack or food. That is most important. Gut health is important. You have to improve the gut health. If you don't, you become obese and diabetic, both. That's why we call it diabetes and obesity. Depression, sleeplessness, you have pesticides, pollution, and whatnot. And of course, don't forget about the alcohol. And the children, if they have the antibiotics, that's why do not give antibiotics to the children. Very, very rarely you have to give them. Most of the infections are viral, but that's where the genes, that's the lost. We know that everything is inflammation because the insulin resistance goes up, and therefore insulin resistance is caused by various things, and inflammation comes. See, everything to do with the gut microbiome, and that's where the starts inflammation. And that inflammation causes insulin resistance to diabetes, cancers, everything. Therefore, cut down the sugar. Sugar is a poison. And anything, rice, pasta, bread, potato, chapatis, all are sugars. You should have complex sugars, and that's what you should be eating. The second is what we eat is the dairy products. All dairy products cause inflammation of the body. Therefore, you will get diabetes, even with that. Of course, meat and meat products are inflammatory. They cause also diabetes. Alcohol, of course. This was very 1998 or 97, they have done in the study, national statistics in England. The risk is very high. If you look at them, multitude of complications happen, obesity-induced complications. So many. Don't forget about the cancers which they produce, ovaries, endometrium, esophagus, stomach, name anything, breast cancer, all are to do with the obesity. Of course, MASH, the liver, or before we used to call it non-alcoholic steatohepatitis or non-alcoholic liver disease, fatty disease. And many people become urinary incontinent. Can we lose weight without any effort? Very, very few people can lose and maintain it. Many people lose almost my weight or more, but they put on that weight within 1 year. Therefore, how does the surgery help? The middleman, of course, me and my colleague, he was the president at the time, and we honored this man, little man in the middle. But he is the one who changed the perspective of the whole of metabolic surgery in the world, and it's about Buckwald. Even at 88, he was operating. He's 94 now. Therefore, he showed diabetes disappears after surgery. You have hypertension, hyperlipidemia, obstructive sleep apnea, everything disappears. But more for metabolic surgeries, which are the malabsorptive procedures. And of course, stroke risk is less by 64%. You have also a Swedish study, and there the death rate reduced by 31.6% because of the cardiovascular risk is reduced. Of course, Long and Ted and this from Minnesota, Iowa, they did also a study, and they looked at almost 7,000 patients, 8,000 patients, 40% decrease in the death rate. Therefore, we know now it is making that. And this gentleman who is there sitting next to me, he is the inventor of biliary pancreatic diversion, very malabsorptive process called BPD. From that, we changed to BPD with diurnal switch. And that changed the whole perspective of the metabolic surgery. Therefore, insulin is considerably reduced with the surgery. Ghrelin, which is produced in the stomach, produces appetite-causing hormone, and that appetite-causing hormone goes down, and also your insulin resistance goes down. Incretin effects goes up. Therefore, now the drugs are created for this, GLP-1, GIP, and the PYY, not yet. That's also coming. Therefore, all the metabolic problems are improved apart from this. Mortality with the surgery is very, very low, very safe surgery, better than even gallbladder surgery. That is what it is. Overall, it decreased the incidence of cancers in ovary and endometrium, and that's what it does. You can look at some of the ones I just flash it just to know. This man lost 98 kilos. 98 kilos. You can see him. His abdomen, you would have looked at him like a big pot. And this woman also lost, and she became very thin. See this man. He also, 5 years before he had the surgery, and he lost enormous weight. You can't recognize the ladies, the one at the top and the bottom. She looks like a model now. Not for that reason we are doing the surgery, but still. And this lady is in a wheelchair. See how she becomes. She's again another model. Not that we can promise that, but can happen. This man is a banker. He lost about 70 kilos actually. Similar. Looking at the back here, shape of the bum and the legs and the back all changes. And this lady wrote me a letter, email, I just put it. She lost 45 kilos more, but then maintained at that level. One of our nurses, this one also. I won't put too much. This lady lost a lot of weight. She lost how many? 14 stones. 14 stones is 80 kilos plus. 92 kilos. She becomes half her size, this lady. Right. I'll give you a scenario of some of the conditions, what happens. Why I kept saying the waist is important. That changes everything. BMI 60, but I don't bother with the BMI. You see the 163 centimeters after surgery, it came to 124 within 6 months. And of course, she had depression, osteoarthritis, hypertension, various things. She's off the sticks. She's no longer walking with sticks. And she's also off all the medications. That's the important thing. This lady, she had a mobility problem and OSA and sleep apnea, and both all gone completely. 4 years after, her waist size came down to by 36 centimeters. Another one, she has a mobility and leg problem, knee problem. All issues gone. 145 centimeters, 118. It's very much. And the skin becomes smooth and red. And her leg used to be like a lipedema and lymphedema. And both can be completely changed with the surgery. Diabetes mellitus, hypertension, mobility problems, everything. These are all multitude of problems. They all get better with time. But you have to select them well. And of course, you have to optimize them and then do this. See, she become now a nutritionist. All diabetes, hypertension, all gone, all medication stopped. That's the beauty of the surgery, is long lasting. And hypertension, I don't prescribe to everybody. The patients should be willing to have the surgery and follow our guidelines. Otherwise, I do not do the surgery. Right. Okay. There are many other issues there. You can see them. Spinal fusion and could not walk, and all become 1 year later, reduced all medications, and also her husband also had the surgery. Like that family issue. All the family members come and have the surgery generally, 4 or 6, like that. And this interesting woman, her husband used to call her ugly and fat. What did he do? She lost weight. She threw the husband out. That's it. The next lady, she also got a gastric bypass. Sorry, he got a job and she actually, and a boyfriend. Therefore, their perspective changes, jobs change. So many people have changed. And also pre-transplant, I do the surgeries to make them lose weight so that they are fit for surgeries. This is renal transplant patient before. She had lost weight. And who gave the transplant? Her own sister gave the transplant, live donor. And she also lost weight so that she's also eligible for surgery. fertility and chemotherapy. Some of the people who had the chemotherapy, they want to be fertile. And for them, I do the surgery. This lady become pregnant 3 months post-op. 3 months. She never thought she will become. She did. Of course, people change job. They become travel reps or police. They become a bus driver, become police, or Stansted Airport. They become also the managers. Some of the air stewards or air personnel, they also have to have surgery because they have to fit into the space. If they don't, they can't work. Therefore, they had the surgery and go back to work again. I don't know seat belts people wear and seat belts they don't need anymore. Extended belts. Clothes become cheaper because they can buy it anywhere. This is like that food also becomes so cheap. Within a year, they get their money back by not spending on the food. Recently, one of the patients I used to look after, this is where we say empathy is important to the patient. Because of empathy, she became a nurse now because she wrote it very recently, only about 4 days ago. Okay, let's come to the multitude of surgeries. We have gastric band, sleeve gastrectomy, you have the gastric bypass, mini gastric bypass, and Roux-en-Y bypass, SADI single anastomosis, diurnal switch itself. The last two, very few in the world do, and some of us are there, about 15 or 16 of us. That's how the normal anatomy is like that. We know everybody. What we do, put a ring at the top of the stomach, and that's a band. We stopped doing it because of the complications are so much. All of them are removed within 10 years after implantation. Sleeve gastrectomy, basically simple. A big stomach is made into a narrow tube, and that's what it is. That's a sleeve. It restricts the amount of the food one can take, and also it can change the hormonal status, exactly like bypass. This one bypass is a Roux-en-Y bypass, makes stomach into small pouch, and then you attach the small intestine, bile joints here. But in the next one, why don't you put a loop? And that's a mini gastric bypass. It has its own problems. One need to know whether they help or not. Next comes, this is the single anastomosis diurnal. These are proper metabolic surgeries. Weight loss is excellent. These are people for 60 BMI to 150 BMI we are speaking about. You do sleeve first. They may lose about, one of the patients, 380 kilos. 380 kilos, she lost about 180 kilos with sleeve, and then another 100 kilos with the SADI operation, diurnal switch operation. She come to 100, from 380 kilos to 100 kilos. And mobile, everything. This is the actual diurnal switch. Right. How long they stay in the hospital? 1 to 2 nights. They start exercising within 7 days and can go back to work within a week. Of course, follow-up is important initially. After that, you don't need. You need a blood test every 6 to 12 months. And of course, they have to have injection B12, various things, vitamins. Pre-organ transplant, before heart transplant, you have the liver transplant, the kidney transplant we spoke about. The guidelines are there. They're all on the website anyway. You can always look. Waist size also is important. Of course, I've done 8,000 plus bariatric surgeries, trained so many. Revisional surgery, sometimes, especially for people like us, we get most of them complicated one for revisional surgery when they put on weight or if they have complications with the surgery before. Of course, we have to change the lifestyle. Otherwise, it's a waste of time to do this. Now the game changers are come. These are the injections. Weekly injections now we have. 1 receptor, 2 receptors. Now monthly injection is coming. It's called MET 09171. That will be available by end of next year. Ozempic, Mounjaro, people know about this. But they have always complications. But don't forget about them. They have risk. it should be given very supervised, not everybody. And I wrote an article, and Swati Sharma published in Deccan Chronicle only about a month ago. Right. Surgery is very efficient, but you have to tailor the operations according to the person's needs, not anything else. Of course, you explain to the patient. I spend about 45 minutes talking to the patient and explaining, because that's the most important one. Of course, diabetes and all will be, and other comorbidities will be resolved after surgery. That's where I am. Any questions if you have, you can ask, or any time later. And I'm at the Continental, therefore you can, or ring me my personal number. I can talk to anybody or about anybody. Thank you. I think it just
Thank you, sir, for the
30
wonderful
minutes.
on time, sir. Thank you so much. Thank you, sir, for your insight of obesity and the treatment options that are there. Any questions, please?
If nobody asks the questions, only two things. Either you know it all, or the person who spoke is an idiot. Which one it is?
All or none.
Sir, it is a Dr. Gurumurthy Memorial Oration, sir. It is a prestigious from IMA AP State. So, సార్కి ఈ మెడల్ని ప్రజెంట్ చేస్తున్నాను.
Little patients, big lesions, fascinating cases from the ICU. Chairperson Dr. Murli Mohan, sir. Sir, kindly come and give a small introduction about sir.
Sir, Mike. A very good afternoon to all. I am very happy to introduce Dr. M. Kiran Kumar, neonatologist. Kiran Kumar will speak on little patients, big lessons, fascinating cases from NICU. Dr. Kiran Kumar have done his MBBS from PES Institute of Medical Sciences, Koppam, and he had done his DNB Pediatrics from Kanchi Kamakoti Child Trust Hospital, Chennai. And he had done his DM Neonatology from Lady Harding Medical College, New Delhi, India. Without much delay, I hand over the floor to Dr.
this muscle biopsy and exome sequencing are the diagnostic. Coming to management, the average expectancy will be 29 months, and till the baby survives, we will proceed with respiratory support and physiotherapy. And here, the genetic counseling is important. Why? Because it's X-linked recessive, so we should counsel the mother before the next pregnancy, and we can detect the carrier state of the mother also before proceeding to the next pregnancy. So the learning point in this case is false positive result. Why? Because this baby had poor Apgar, we initially thought of hypoxic ischemic encephalopathy, but later this baby diagnosed to have central nuclear myopathy. And always reevaluate the primary diagnosis. If any baby with persistent extubation failure, hypotonia, and preserved sensorium, always thought of peripheral cause of hypotonia. And muscle biopsy and genetic tests are essential to conclude the diagnosis. So coming to second case, this is a baby with Down's phenotype with birth weight of 2.7 kgs. This baby presented with jaundice and hepatomegaly. You can observe there is a vesicopapular rash, and on evaluation we found to have a hyperleukocytosis. That is a WBC count of 1.3 lakhs, which is very unusual in newborn babies. So peripheral smear shows surprisingly 43% blasts with more of erythroblastosis and megamyelocytosis. And flow cytometry showed positivity for CD61 and CD41, which is in favor of megalokaryocytic leukemia. It is a transient condition in Down syndrome. Why? Because this is it is secondary to GATA mutation. This GATA mutation will be leads to this megakaryocyte proliferation in Down's babies especially. So this is TLDS, that is a transient leukemia of Down syndrome. Usually these babies regress spontaneously, but some percentage, 20 to 30%, will land up in AML after 4 years of life. So these babies will be closely followed up with repeated CBC. When the baby requires, that is when the baby is landing in critical phase, we should start on low dose cytarabine. This baby managed with low dose cytarabine, that is 0.5 to 0.75 mg per kg subcutaneous route. You can observe there is a gradual decline in WBC count. We reach a normal count of 14,000 on day 10 of life, and rash also subsided. We followed up this baby till 2 years of age. This baby was doing absolutely fine without this Down phenotype. This baby was doing absolutely fine. No other any significant systemic involvement till now. So learning point: always screen any Downs baby. Always screen for hematological issues, especially for TLDS. If the baby presented with rash, hepatomegaly, and leukocytosis, think of TAM. And flow cytometry and GATA are the diagnostic these things. And cytarabine is always life-saving. This cytarabine, it won't prevent into transformation into AML. It is a critical situation where the critical situation will happen. This cytarabine is going to help, like prevention of life-threatening symptoms. Coming to clinical case 3, this baby born at 32 weeks of gestation with birth weight of 2 kgs as a non-immune hydrops, presented with severe respiratory distress at birth, and baby required intubation at birth in view of respiratory failure, and baby was continued on ventilator support. On examination, we found to have decreased air entry as well as ascites. When you see the X-ray, there is a bilateral pleural effusion more on left side with mediastinal shift. We have placed intercostal drainage in view of respiratory failure. We drained 120 ml of serosanguinous fluid initially. At the time of presentation, baby had features of shock also. Once the shock part improved, we started on feeds. After starting feeds, this serosanguinous fluid changed to yellow color. This is the color. Can you guess what is the diagnosis? Yeah, this is chylothorax. What happens in chylothorax? If you introduce the feeds, this serosanguinous fluid change to milky white color. So why it happens? Why in this case there was no obvious diagnosis for this baby. There is a functional integrity changes which is happening in the lymphatic duct changes lead to chylothorax in this baby. So what is the diagnostic criteria? When you suspect this type of fluid, you should send for triglycerides also. It is always high. So as per criteria, if it is any triglyceride level more than 110, we will consider it as chylothorax. And it is lymphocyte rich, that is more than 80%. So for this baby, the triglyceride levels were 328 and lymphocytes were 90%, and cell count was 12,000 per DL. So this baby was there with us for initial 30 days. Initially, we treated with TPN, and secondly, feeding management wise, we started on MCT rich fluid. That is medium chain triglyceride feed we introduced. With that, baby improved and chylothorax got resolved and successfully discharged the baby on day 30 of life without any other comorbidities. This is a stepwise approach how to proceed with chylothorax. This was already mentioned. Initially, we tried with MCT rich feed. If it is not subsiding, we can try multiple drugs like sirolimus, octreotide, and all. If this thing also not working and the drainage is more than 10 ml per kg per day, we can proceed with surgical intervention like thoracic duct ligation and surgery. So then coming to fourth case, this is the 34 weeks with birth weight of 1.74 kgs. You can observe there is a eviscerated bowel loops without any atresia and ischemic changes. This baby was stable at birth with good perfusion, no evidence of any shock. And we covered this bowel with the cling wrap. There is a plastic wrap which is available in commercially market. So we have covered this to prevent the insensible water loss, and NG tube inserted to decompress the bowel loops. And we accessed the peripheral line in the labor room, it seems, and fluid resuscitation was done and transferred to NICU. So what we did in NICU? So we have placed a silo. Actually, there are commercially available silos also available. This is a preformed polyurethane silo. So we initially applied Euro bag, as at the time there was no silo in our center. So we initially tied with the Euro bag. Later we shifted to preformed silo. So what we did, we did daily tightening under sterile precautions, and there will be gradual reduction in bowel into abdominal cavity. And throughout this procedure, we should maintain the perfusion and well as abdominal compartment syndrome prevention. Why? Because the abdominal cavity is very much narrow. We can't do primary reduction in this baby. So initially, we should place the silo. Once the bowel reduction is happening, then only we can proceed with primary repair. NG output monitoring and electrolyte imbalance, urine output, and we should start babies with total parenteral nutrition, because nutrition is a prior concern in these babies. And septic screening, if required, we should treat with antibiotics. So if you observe, we have completely knotted the silo from above. As the day progresses, there is a reducing in nature, and we have almost reached the final stages of reduction in the last picture. So this is the subsequent pictures where the baby underwent primary repair. Post primary repair, baby also improved well without any complications, and baby we could able to establish feeds after almost 4 weeks of birth. That means almost 1 month. Baby was on TPN. Then we reintroduced the feed, and baby successfully got discharged. So what is this? This is a case of gastrocrisis. The incidence is 2 to 5 per 10,000 live births. So the factors for gastrocrisis were young age, that is who give birth to babies who are less than 20 years, and smoking, alcohol consumption, and low BMI. So how can we diagnose antenatally? The ideal period is between 18 to 20 weeks. If there is a free floating bowel loops in the cavity, we can suspect the gastrocrisis, and also we can send for serum alpha fetoproteins that will be high. So learning points here is the congenital defect with paraumbilical abdominal wall opening with extrusion of bowel contents. The management wise, there should be a prevention of infection as well as ischemia, and requires early protective measures and also stage reduction. So coming to summary of all 4 cases, coming to first case, the central nuclear myopathy. If any baby with persistent extubation failure with hypotonia, always consider neuromuscular cause. And if any baby with Down syndrome, always investigate for hematological issues, especially for TAM. If required, cytarabine therapy is must. The third one, chylothorax. If any large effusions, which is presenting at birth, and the consistency and the fluid color is changing with the feed, always suspect chylothorax. And coming to gastrocrisis, the last one, silo with the stage reduction is the essential therapy before going to primary closure. So take home messages from NSU point: use critical thinking in rare presentation, and diagnostic precision improves outcome. And there should be a multidisciplinary approach always will be helpful. And there will be proper documentation and follow-up are the key. So every little life deserves best care, as we started NSU in National Hospital recently. Now we are completely operational with level 3 NSU services, with also transportation services also. So please utilize the services. Thank you. Any questions?
Thank you, Dr. Kiran Kumar, for enlightening us on various problems of neonates in NICU. The floor is open for questions. If no questions, we'll close the session.
Thank
Sir, Dr. Murli Mohan sir, a small memento given by Dr. M.V. Sudhakar sir, D&B Orthopedics Medicover Hospital, Nellore. Sir will give a small topic about role of bone, joint and muscle health for smart aging. Chairperson Dr. Vengal Reddy sir. Sir will give small introduction about sir. Introduction. Sir will give introduction about you. Okay. Small CV. Okay. మీరు laptop set చేయండి.
సార్ వీడియోస్ అని లేవు కదా వీడియో ఏం లేదు పిక్చర్స్ మాత్రం.
I'm very honored to introduce Dr. M.V. Sudhakar. He's an orthopedic surgeon. Has got more than 22 years of experience in orthopedics. And he's expert in arthroscopy, arthroplasty, and polytrauma, as well as pediatric orthopedics. He did his MBBS from SV Medical College and DNB from Delhi. And he worked as assistant professor and associate professor in various medical colleges. And he presented so many papers, especially regarding ACL surgery, regarding modern graft options. Right now, he is working in Medicover Hospital, Visakhapatnam. Sir, please proceed.
Thank you very much. Good afternoon. Thank you, IMA. So though I am from Nelluru, but I have been working in Kerala for the last 27 years. I just recently moved to Nelluru, maybe 1.5 months back. So it is fortunate that I am here again in the state conference. 2 months back, I was a speaker in IMA state headquarters for Kerala state branch. The talk was how to age smart. So I thought of taking a leaf from there, and we will discuss the role of arthroscopy in joint preservation and philosophy of smart aging. తెలుగులో ఒక మాట చెప్పాలనుకుంటున్నాను. ఏంటంటే పాత రోజుల్లో 55 సంవత్సరాలకే తాతయ్య అంటే పీపుల్ యూస్ టు యాక్సెప్ట్.
Now even at age 70, if someone calls you Tataya, ఎబ్బెట్టిగా అనిపిస్తుంది. So, so the thing is, even I am Tataya at home. So it looks awkward for me, someone calling me Tataya. So it is true with many of the members here and in the society also. No one wants, at a especially age 55, 60, people have some amount of self-consciousness. Am I stable? Am I mobile? So the modern orthopedics and especially healthcare has offered many things to make us mobile and stable. So one thing which is rampantly being practiced is arthroplasty for osteoarthritis. But there's nothing substitute for the God-given knee. How to keep a natural knee and still be able and stable. So I'll be taking you briefly into the, sorry. So it is, I always dedicate all my things, whatever today I am, is because of my parents, my teachers, especially Professor Varghese Chako, who has instilled the basics of orthopedics, and Dr. Vidyasagar Garu, who was actually stimulated me to pursue orthopedics, and my patients, without whom I couldn't have been standing here today. And my friends, we always encouraged and bared my stupidity, and my students who always put a challenge to you, being me working in medical college and being the teacher for the postgraduates for the last 15 to 20 years. So it is always a challenge because you don't know what sort of questions your student pose. Arthroscopy, we all know, like laparoscopy, is a minimally invasive surgical technique. It allows surgeon to directly visualize, diagnose, and treat problems inside a joint. I was very carefully watching one of my teacher in 2002 who used to put a scope for a diagnostic arthroscopy, it is called. And we used to post the case and diagnostic arthroscopy one day and then another day for therapeutic arthroscopy. And the days are gone. In the last 2 decades, there is nothing like a diagnostic arthroscopy. Still, there is a hope like a laparotomy, diagnostic laparotomy. There is a diagnostic arthroscopy still holds good. But however, don't think that MRI is going to replace everything. Our clinical experience will be definitely supported by diagnostic arthroscopy. But sometimes MRIs will mislead you. And especially in the given today, even 1.5 Tesla, 3 Tesla, MRI is not going to directly tell what exactly the joint pathology is. Routine issues, okay, ACL tear, PCL tear, meniscal tears, that's the thing. But however, when it comes to the cartilage injury, MRIs are poor. The sensitivity only 50 to 60%. That means the failure rates are almost 50 to 95% failure to diagnose the accurate diagnosis. So how to manage them? So we know definitely minimally invasive surgery arthroscopy is, and it definitely improves early recovery. I will share a small anecdote here. My uncle, that means my wife's babai, at age 72, he comes to me with a knee pain and X-ray shows osteoarthritis fully. But this man walks 6 kilometers daily and dances also. So the burden is now he don't want TKR. So how to manage him? See, we have seen bald heads, but how many of you have seen bald tibial condyle, femoral condyle? I don't know. I could not able to show the video here. If I can, I will show. So totally there is no cartilage. And after 2018, September 7th, I operated on him. Now it is 2025, 7 years. Still, he walks for 4 to 6 kilometers with his natural knee, God-given knee, without TKR. And he still dances, sings and everything. And he drives his car. That's what is smart aging. That's what I wanted to stress here. Maybe the talk today may not have relevance, but soon, in the next 4 to 5 years or 10 years, this talk will have value because why the longevity of 77 years to the woman and 71 years to the men. So our TKRs at age 50, 55 are going to solve our problems. We need to challenge this. So we all know that ACL, PCL reconstruction will stabilize the knee, preventing early onset of osteoarthritis. During my postgrad days, we used to cut the knee from the lower one-third of the quadriceps to the tibial tuberosity and open the knee and do ACL reconstruction. God knows we have stabilized the knee either because of the ACL reconstruction or because of the stiffness. I always doubt because people used to have a stiff knee, so they used to walk. So we thought it is because of ACL reconstruction. Actually, I learned that it is because of the stiff knee. So from there, we moved in the last 2 decades where we are offering minimal invasive surgeries. Patient go off in the next day. In the West, especially, they are sending the patient on the same day following ACL reconstruction. But the problem is, until unless we have a good home care program, it's very risky and life-threatening also. I have seen a patient who went for thromboembolism and died. So daycare procedures for ACL reconstruction, PCL reconstruction or bicruciates is still not a routine thing in India and especially in tier 2, tier 3 cities, maybe in especially tier 1 cities like Mumbai and Delhi. Yes. So meniscus repair. See, still why I pursued arthroscopy is I have seen one young girl of 9 years going for a meniscectomy by my boss at age 7. So that day really I didn't cry, but it haunted me a lot. Is it necessary to cut a meniscus? How whether I can save the meniscus? So I used to repair maximum number of meniscus in Trivandrum because I learned that the 4 things which are important for the knee are one is ligaments, definitely, that is to stabilize the knee. The second one is menisci. The third one is cartilage. The fourth one is our alignment. Some people you have varus knee, some people you have valgus knee. Until unless you address all these 4 planned way, just managing one problem may not be able to stabilize your cart. One leg, we can't lie on a one leg cart, right? In the same way, we need to address. Maybe 20 years back, we didn't have that much knowledge and we didn't have that philosophy and we didn't have that much understanding. And down the line in 2025, now we are thinking about how to save the natural knee by preserving, by stabilizing by ligament reconstruction and taking care of the meniscal repairs and cartilage injuries and also realigning to protect this whatever you have done intra-articularly. So my whole job today will be to stress the importance of role of arthroscopy in joint preservation. Because I have seen many times in IMA talks, means general talks, I thought it's important that our own colleagues know the importance of these particular advancements in healthcare so that we will be able to offer better services to our beloved patients. So chondral cartilage lesions, diagnosis still very difficult. Even the modern 1.5 Tesla MRI miss 50 to 90% of the grade 1 to grade 2 lesions and grade 3, grade 4 lesions missed by 40%. Patient history, high degree of suspicion, and reading MRI by self if you have the experience and expertise and discussing with radiologists. See, we shouldn't be hesitating to talk to our radiologists or pathologists or microbiologists, for that matter, even biochemists, when you have a doubt. Many times our ego is the biggest hurdle in understanding the problem and putting up a team effort for the better outcomes of the patients. So, and a diagnostic arthroscopy will definitely help us because you are directly visualizing the problem and there's no confusion there. So MRI still can't give the same information as a diagnostic arthroscopy. See, this patient is just recently treated in Medicover only. This gentleman of 34 years, male, you see on the, can have this pointer, please. Is there a pointer? Okay, no issue. See, there is a screw there. 10 years back, this gentleman, when he was around 24 years, he underwent a arthroscopic fixation of his medial femoral condyle. Probably, he don't have any document. However, retrospectively, from postmortem, I can understand it could have been a OCD, osteochondral desiccants, a fragment. So it was fixed and the guy was moving okay. He used to have recurrent now and then little pain and swelling, and he is basically chair bound, so he was not that much symptomatic until 4 months back when he took up a job as a manager in a hotel in addition to his regular job. So that's where this guy started having more symptoms and he presented to me, and X-ray, this is X-ray finding. That X-ray shows nothing there, And there is a MRI also. MRI shows in the same area there is a subchondral lesion, subchondral cyst, and cartilage is normal. That's what the MRI report I will show you. See here, this MRI report doesn't talk anything about the cartilage. But one point they have mentioned here is small marginal osteophytes are seen. This is a point which helped me out to suspect there is something fishy there, because a bone like a grass in the middle of the sea indicates an island. Like that, a bone in the middle of the femoral condyle should stimulate you why there should be a bone in the cartilage. So that means the cartilage has gone. So I explained to the patient, this osteophyte there, don't look, it's not a healthy sign. Probably you don't have any cartilage there. So to convince is very difficult, because he's 34 years and MRI also shows okay. And with the given scenario of Arogyasri and everything, where you have to, your MRI is the one that will take as the evidence. Okay. So how to convince this guy? So somehow I convinced this guy and did a arthroscopy, and see on the right side, there is no cartilage at all. Almost 2 centimeter of grade 4 cartilage injury. And this knee, and another surprising thing is he has got a kissing lesion also. That means this is medial femoral condyle and medial tibial condyle cartilage also gone. That means this knee can survive maximum at maybe another 1.5 years. So he is, by the time he becomes 35, his knee becomes 55 to 60. So how to handle such scenarios? Until unless we are really empowered and have that information and everything, we can save few more knees and make them healthy and happy. That's how we can help them they will age smartly rather than with the grief. So X-ray, MRI cheated us, and the arthroscopy is the one which helped us. That's where arthroscopy has got an edge in diagnosing joint pathologies in a better way than routine this thing. If you have the clinical suspicion and read your X-rays and images carefully and counsel the patient, take time, and we our own, I think our professional system will definitely help each one of us. If I don't know, if someone says something which is not a normal thing, maybe I shouldn't be commented. We shouldn't be doing that. I think in this, I want to send a message that better we don't comment on our colleagues. Maybe we can discuss. So అతనికి ఏం తెలుసు, అలాంటి ఏమి ఉండదులే, దిస్ ఈజ్ అంటే మామూలు ప్యాషన్ అయిపోయిందిలే, ఇలాంటి పదాలు వాడేసి we shouldn't be killing our own colleague and also killing the patient. At the end of the day, the patient is the loser, and professional jousting, medical jousting is the biggest hurdle. So I think we should take care of it. And this is the tibial condyle lesion. Tibial condyle also grade 4 lesion. So until unless we address his medial femoral condyle, medial tibial condyle, this knee is 20 years older than its contralateral knee. So this I have taken an example. So this is a normal sign lateral compartment. There is a good lateral meniscus and good lateral tibial condyle. So very good cartilage, very smooth, nothing to worry. So we can't put him back to this normal level, but however, we can give him a better life by giving a better knee. So how to deal it? So arthroscopy in sports injuries, I have given a thesis to one of my PG, and we studied around 80 cases of osteoarthritis knee, and we treated the patients with arthroscopic debridement followed by PRP injections. So what I found is there are treatments given without even joint debridement, PRP injections, and that has brought a very bad name to the PRPs or any sort of adjuvant therapies to the osteoarthritis, because పాత్ర కడగకుండానే మనం పాలు కాచినంత మాత్రాన ఆ పాలు విరిగిపోతాయి కదా. అలాగే ఈ మోకాల్లో, నీ జాయింట్ లో ఆస్టియోఆర్థరైటిస్ ద్వారా ఉండే డిబ్రిమా అంటే వేస్ట్ పదార్థాలు, like cartilage pieces, osteochondral fragments, bone pieces, ఈ చెత్త చెదరం అంతా అక్కడే పెట్టేసి if you do a PRP injection there, I don't think this is going to save that knee, because until unless many people, what I have seen is, after studying around 79 patients, many people have got a meniscal tear. Many people have got a osteochondral fragments. Many people have got unstable fragments, which causes synovitis. That is the reason why these people will come with a knee pain. So we give NSAIDs and we send to physiotherapy. I wonder, these guys going for physiotherapy for 1 or 2 weeks, no physical therapy can produce any wonder until unless the guy goes for 6 weeks at least. సో ఒక వారం రోజులు ఫిజియోథెరపీ చేసినంత మాత్రాన ఉరిగేది ఏముండదు, తరిగేదే కానీ. సో అండ్ దే విల్ సే దట్ I have taken PRP, I have done physiotherapy, and nothing has happened. And he will move from me to another sir, and another sir, another sir. And that is the thing. So we need to definitely, even though American Association of Orthopedic Surgeons says evidence-based, they keep on changing every year. They release a new protocol. But the thing is, what I understood after studying 79 cases is, if you do arthroscopic debridement and treat all unstable fragments and clean the joint and then give you a PRP, and these guys are doing good. Actually, grade 3, grade 4 cases also doing good. It's almost 4-5 years. And if you can add on medial tibial osteotomy, high tibial osteotomy, that means if there is one compartment is maximum involved, if you can offload that compartment, so those guys will push on to another 5 to 10 years. Maybe if someone comes to at age 50 and is ready for not ready for TKR and unicompartment osteoarthritis, maybe we can do high tibial osteotomies and like cartilage procedures, something like that, and we can push them to age 60. At age 60, if you do a total knee replacement, yes, they can go up to 75, 80, fine, that's good. But if you do TKR at age 50, what are you going to do at age 60, 65? Are you going to revise it? Where is the bone? So that is a challenge, because 20 years back, now only here and there one guy used to go for TKR. Now TKR has become any ordinary procedure like a hysterectomy. So it is a time that we save our natural knee and protect, give them the mental stability and ability to use them normally. Whatever said and done, TKR may not give the same freedom of movement like a natural knee. So, and then moving on to the arthroscopy in shoulder. Yes, this is another interesting area, like frozen shoulder. And this is a common thing. And rotator cuff injury is also a common thing. This part of the country, or especially in India, rather than sports rotator cuff injuries, in tier 2 cities, tier 3 cities, we see a degenerative rotator cuff tears. So, especially calcific tendinitis. So, and recurrent shoulder dislocations. Arthroscopy has proved its mettle that is a good alternative than the open procedures, and patients will still same functional outcome, especially impingement syndromes. You need not cut it and everything. You can just debride the acromion and prevent further damage to the rotator cuff. So I will share one case here. RCCT is rotator cuff calcific tendinitis. Arthrolysis for the frozen shoulder. Arthroscopy is good. SAD is good. Cyst decompressions also we can do. See, this is a young lady, 36 years old lady, comes to me with a shoulder pain in July, acute pain, not able to lift since yesterday. It's from Trivandrum. And till then, she says she was okay. And there is a calcification just lateral to the acromion there. I don't know whether it's not that that clear. So this area, there is a shade there, big, more than 1.5 centimeter calcification. And this is an arthroscopy. You can see a pearly white area. And when I needle it, it is a tough one, like a calcified piece. So I have debrided it. I have 1 or 2 videos. I could not able to play it. So I have debrided. What happens is, till around 2 years back, I used to do barbotage for that cases. That means this calcification I will take to OT under CAM, that is image intensifier. I needle it, aspirate the cheesy material, and put a steroid. One case, one of my students' mom, she, after this procedure, she could not able to lift the shoulder. Probably I have produced a tear. So that's where I realize is, am I justified by routinely going and poking it and pulling the material there and producing a rent there? Already a calcification there indicates as a trauma. Probably it healed with another material. So I am going and producing a repeated trauma. A trauma by you or a butcher is a trauma. Maybe you have a plan to how to produce a trauma. They don't have a plan. That's the only difference. So all the cases with needling may not do well. Sometimes even you will produce a rotator cuff tear so that after that they won't raise and they may not be able to use it. So they came for pain. You have given a disability also, functional disability. So that's where I thought of this patient. Counseling and having the reasonable knowledge among the same community is also important for the patient outcomes. When I say this procedure, when she goes to another orthopedic surgeon or another clinician who don't have idea about this, so what this అలాంటిది ఏమి ఉండదు. దానికి మనం ఒక స్టెరాయిడ్ ఇంజెక్షన్ వేసుకోవచ్చు అంటే స్టోరీ ఓవర్. So, so that's why I thought of these things are there in the society. And even day for yesterday, I had a patient here. So maybe if you see like that, you will get those things. And I have debrided it and fixed it with a double row anchor fixation of rotator cuff. And now she's having around 120 degrees. And she's only 36. Imagine, very young lady. So rotator cuff calcific tendinitis, arthroscopic debridement and cuff repair is an excellent procedure. Selection of the patient is important. This is next level of evidence-based treatment. Sorry for the typing mistake. The calcific rotator cuff from traditional needling, that is barbotage and steroid administration. It do have a role. I have treated enough good number of patients with barbotage, indomethacin, and steroid injection. I am not saying that that procedure is not good. That is good. But always warn the patient, after this, you may have a problem of tear. If that is the case, you have to go for this thing. And if the lesion is very big, like 1.5 centimeter like that, definitely proactively, prophylactically, you tell that cheesy material, calcification has to be removed and it has to be repaired. If it is a small lesion, yes, we can give needling and steroid administration and everything. So impact on joint preservation and smart aging. In the era of 2025, where we are thinking about how to push our longevity to 80, 85, 90 like that. Because why I'm telling is, in Kerala, pushing the horizons is a normal thing. At 1 or 2 years, one gentleman comes to me with a fractured neck of femur, and because of his age, he was denied surgery. And I did a hemiarthroplasty, nothing very great surgery. And he goes up to 106, he breaks his bone again. I operated again, he goes to 107 and breaks his bone again. So what I feel is, death is not in our hands. Our job is basically to alleviate the suffering, and don't take the age as a criteria to say no to any treatment just because age is a criteria. Don't take age as a criteria. Pain is the only criteria. Suffering is the only criteria. Happiness should be the only hope and motive. So if that is the case, then we can offer and make this society more beautiful and happy. And arthroscopy has definitely helped many people in preserving the youthfulness of the joints. And if you can add on realignment osteotomies around the knee, it will play a crucial role in preserving the natural knee. And my only idea is how best you can be active on climbing at least 5 to 10 stairs, even at age 60. That's a great. And 70, that's a great. If you can have good memory, your knee and will definitely, you need your knee. It functional ability in mild to moderate osteoarthritis, delays or prevents joint replacement in young arthritic and injured joints, and maintains mobility, stability, and long-term function. So arthroscopy in sports injuries, again, is very important and it is time-tested. Timely intervention by arthroscopy will help the athlete to return to activity at the earliest. And why arthroscopy? It is getting better and is getting updated faster. That's why I'm telling. Rather than open procedures, minimal invasive procedures are getting updated very fast. Especially with the AI, I think we will be learning more with a bit of caution. Anatomical ligament reconstruction, yes, I think that part is has got clarity to everyone in the house also. And cartilage restoration techniques, this is a one area, is a new thing. And I have enough good number of caseload with microfracture, chondroplasty, I have done. And scaffold treatment also I have done. And there's one more patient waiting. And early mobilization. This scaffold treatment is not to the sports person. It is a beldar antar kada, mason. For that guy, he is back to his work. So, and early mobilization protocols for athlete to regain performance, modern arthroscopic innovations like 4K visualization. All laparoscopic surgeons may be knowing this. Enhanced precision and radio frequency has added edge to the arthroscopic procedure. Message: arthroscopy definitely, sorry for the spelling mistake, arthroscopy definitely has helped mobility and improved stability by preserving biology. That's the important thing which my boss, Professor Varghese Chako, has told me. Save biology and that will save you by saving the biomechanics. So just by going for mechanical alignment without saving the biology is no good. And at the end of the day, please remember, save biology and biomechanics. That's all. Thank you very much for your patient listening. Thank you, IMA. Thank you, all the organizers. Thank you to Medicover Hospitals. Thank you to everyone who bore for the last 20 minutes my boring talk, maybe post lunch. Thank you very much.
Any doubts, please?
Any questions? Sir.
Yes.
Sir, you have presented a paper on high tibial osteotomy, right?
Yeah.
Is there any scope for high tibial osteotomy even
Super.
nowadays?
There is a scope. The patient selection. See, what happens is, మనం మెక్కల్స్ డైవర్టికులమ్ గురించి చదువుకున్నాం కదా MBBS లో. That's that. See, there is a something called my tataya has practiced something. It doesn't mean that is bad. The technology has changed. But the only thing is, indications have to be very specific. Because I know high tibial osteotomy, I shouldn't be venturing on every knee. I know TKR, I should be venturing on every knee. So many times, like Elizaro, what happens is when you do procedures on unindicated cases, then it brings a bad name for that. My first bilateral high tibial osteotomy, who was advised TKR at age 49, I did a high tibial osteotomy in 2013. She went on to 11 years. Hood plate I have put at the time. And I did a bilateral TKR post-COVID 2 years back, both knees. So if I could able to give her natural knee for 11 years.
Because nowadays everybody is fond of TKRs, even in a room places.
That is you are true, because if I do a TKR, I am a great surgeon.
Yeah. It's like that.
And the pain tolerance of the people also has come down. Not like our grandfather, grandmother, our parents. That's what I think we need to, our aim should be, we need to save the natural knee wherever possible. That's the only thing. Not that it is a replacement to the TKR. TKR has got its own, it's like it's great. But if we can push another 5 to 10 years with a natural knee. See, I am 50 now. Imagine me undergoing for TKR. I can climb even now 15 floors and run for 24 kilometers. If I go for a TKR now, what can I do those things? That's where I think we have to see from our point of view to everyone. I think we can offer the best. Thank you.
Thank you, sir. Thank you very much.
Small moment of Dr. Venkal Reddy, sir. Our President Sudhakar, sir.
Come, Dr. Jagadishwar sir, Reddy sir, neurosurgeon Kadapa. Sir will give a small topic about management of trigeminal neuralgia. Now, chairperson will be Dr. Kirti sir. Sir will give small introduction about Jagadishwar Reddy sir.
Good afternoon, everyone. It's a privilege for me to introduce Dr. Jagdish Reddy, this surgeon speaker who is speaking about management of trigeminal neuralgia. He did his MBBS from Karnool Medical College and he's completed his MCH neurosurgery 5 years course in NIMS from 2006 to 2011. Later, he joined SWIMS as a senior resident and continued as assistant professor there for 2 years. And later, he established Jagdish Neurocare Hospital at Kadapa. Presently, he is working there. And over to Dr. Jagdish.
Start. Thank you, sir. Thank you very much for your kind words. Good evening, everyone. I'm going to talk about trigeminal neuralgia, brief talk. What is trigeminal neuralgia? Trigeminal neuralgia is a chronic neuropathic facial pain in the distribution of trigeminal nerve. The characteristic features of trigeminal neuralgia is it is a recurrent, unilateral, brief pain with electric shock-like sensation distributed to one of the trigeminal nerves. It is abrupt in onset and in termination. Sometimes it may produce psychosocial disability also. It is triggered by even small stimuli, innocent stimuli like innocuous stimuli, and pain is restricted to one or more the divisions of trigeminal nerve. It never crosses the midline. These are the three divisions of the trigeminal nerve. The first one is the ophthalmic division. The second one is maxillary division. The third is the mandibular division. This is the anatomy of the trigeminal nerve. It is important, as in the coming discussion, I will be mentioning these words. If we take the starting point in the brainstem, the trigeminal nucleus extends even to the upper part of the spinal cord. And then it comes as a cisternal portion. This is the cisternal portion. Then comes the trigeminal ganglion. This is the ganglion where it is enclosed in the Meckel's cave. Then it divides into three parts. That is the ophthalmic division. Ophthalmic division comes out through superior orbital fissure. And the second one is the maxillary division. The third one is the mandibular division, which comes out through the foramen ovale. This is the internal part through the skull base. This is the superior orbital fissure. This is the foramen rotundum. This is the foramen ovale. This is the foramen. Through this foramen ovale, the mandibular division comes out. These are the various. These are three sensory distributions of the ophthalmic division and the maxillary division and the mandibular division. The first one and the second one, that is ophthalmic and maxillary, doesn't have any motor contribution. The mandibular division has the motor component which supplies the muscles of mastication. The trigeminal neuralgia, when it comes to the epidemiology, it is more common in the females than the males. It is usually common after the age of 40 years. When it comes to the below, when we see the features of trigeminal neuralgia below the age of 30 years, we should suspect the other causes like multiple sclerosis and other secondary causes. As I mentioned, these are the characteristic features of the trigeminal neuralgia, usually restricted to unilateral side and one or more of the trigeminal branches, and the stabbing or shock-like sensation can occur without warning, last less than 2 minutes, and abrupt in onset and termination. When we come to the diagnosis and the classification of the trigeminal neuralgia, the diagnosis is mostly clinical diagnosis. There are three, usually it is classified into three types. That is the classical trigeminal neuralgia and idiopathic trigeminal neuralgia and the secondary trigeminal neuralgia. In the classical trigeminal neuralgia or the brainstem area, there will be compression of the superior cerebellar artery or the anterior-inferior cerebral artery or the root entry zone. That is called the classical trigeminal neuralgia. There will be neurovascular compression over the trigeminal nerve. The second one is the idiopathic. There will not be any compression, but still the patient feels the pain. The third one is the secondary causes, secondary trigeminal neuralgia, where there may be some intracranial lesions like epidermolysis or acoustic schwannoma will be there as a responsible causes for the trigeminal neuralgia. The triggers, the trigger factors, trigeminal neuralgia usually produced by even small innocuous stimuli. Even sometimes the patient will experience the pain while talking and while brushing the teeth and eating the food. So most of the times they may not be able to take the food properly. So so they will have some nutritional deficiencies also because of the decreased food intake. Pathophysiology, as I mentioned, the classical trigeminal neuralgia has the neurovascular compression, and the secondary trigeminal neuralgia has the causes like tumors, multiple sclerosis, and other things. And the idiopathic trigeminal, there will not be any obvious causes. The proposed causes are some channel block, channel abnormalities, and all these things. In the initial stages of trigeminal neuralgia, there are periods of remission and exacerbation. The exacerbation periods will be less and the remission period will be more. But as the disease progresses, the periods of remission will become less and it will become like chronic pain. As I mentioned, these three types in the initial period, it will become like paroxysmal pain, and as the disease progresses, it will become like continuous pain in some of the patients. Even though the trigeminal neuralgia diagnosis is morely clinical based, but the MRI is required for further management, because to exclude the secondary causes like acoustic schwannomas and trigeminal neuralgia, other tumors. Now, to know the causes, whether there is any vascular impingement. If I see this MRI picture, this is the trigeminal nerve course from the pons. It comes and in the cisterns it travels and it goes through towards the Meckel's cave, where it divides into three parts. Here, if we see in this part, there is a vascular compression, that is superior cerebellar artery compression over the trigeminal nerve. Here, this is the responsible for the patient for the pain in this patient. And to exclude other causes like multiple sclerosis and other reasons, we should do the MRI before going for further interventions. In the MRI, like routine, in addition to routine scan, there are separate sequences to know the cranial nerve. In addition to routine MRI sequences, the Fiesta and CIS sequences are required to know the vascular causes. Coming to the differential diagnosis, before going to the treatment, we should exclude other causes. The most common causes are the dental causes, like dental caries, dental infections, and other periodontitis, sinus causes, and salivary gland causes, and other neuropathic like glossopharyngeal neuralgia and other causes we should exclude. And other things are the trigeminal autonomic cephalgias we need to exclude before going for treatment of trigeminal neuralgia. These are the autonomic neuropathies, autonomic painful issues, which are manifested in the face. These are more common in the V1 distribution rather than V3, V2 distribution, where the trigeminal neuralgia is more common in V2 and V3 distribution. Coming to the management, the pharmacological, initially for all the patient, we should try the pharmacological treatment. The first line drug is the carbamazepine and the oxcarbamazepine. If the carbamazepine and these drugs are not effective, then we may need to increase the doses. Usually we start with 100 mg BD dose of carbamazepine, then we need to increase the dose. If the patient is not getting relief, then we may need to add on the second line drugs like lamotrigine, baclofen, and gabapentin. If still no further relief, then we may need to subject the investigation like MRI and CT scan to exclude this vascular compression and other secondary causes. The response to the carbamazepine is one of the characteristic diagnostic features of trigeminal neuralgia. If the patient is not getting any relief at the initial starting treatment, then we should rethink about the trigeminal neuralgia diagnosis. Sometimes the patient may present with acute severe exacerbation, then he may require local anesthetic injections and intravenous injections for the treatment of trigeminal neuralgia. Then coming to the interventional treatment, these are the surgical, that is the MVD, that is microvascular decompression, and then the percutaneous methods. This microvascular decompression is done when there is a vascular compression over the trigeminal nerve. Then other things are the percutaneous methods. This is surgical management. This is microvascular decompression, usually done under the microscope, where there is a compression of the trigeminal nerve with a vascular loop, usually the superior cerebral artery or the ICA. Here, this is the vascular loop, this is the trigeminal nerve. When the loop is getting compressing the trigeminal nerve, we should separate the nerve from the, we should compress the vascular loop from the nerve, and we should keep these Teflon patches to avoid the compression of the vessel on the nerve. This is the usual procedure. This is done under general anesthesia under microscope. This is the operative picture where the nerve and vessel are together. This is the after surgery, the Teflon patch is placed between the nerve and artery. And coming to the percutaneous interventional treatments, usually practiced treatments are this radiofrequency ablation, balloon compression, and the glycerol-based treatments. And now the radiosurgery is becoming more in practice. For all the basis of this percutaneous treatments, we used to introduce the needle through the face, through the foramen ovale, into the Gesserine ganglion, that is the trigeminal ganglion, into the Meckel's cave. The basic standard procedure for all the percutaneous procedures is the standard procedure is needle insertion. The needle insertion, we should have a good practice in needle insertion. Once if we know the needle insertion technique, then all the three techniques are more or less same. Usually in the radiofrequency ablation, the method is the thermal ablation, and the glycerol is the chemical ablation, and the balloon compression is the mechanical compression. This is for this. Usually these percutaneous procedures are, this is radiofrequency ablation is done under local anesthesia in the patient, when the patient should be conscious. First we need to, under the CM guidance, in the AP view or the submental view, we need to localize the foramen ovale through which the needle is passed. This is the foramen ovale where we are able to see here through which the needle is passed. After localizing in the submental view and the AP view, then we need to focus in the lateral view to entry into the foramen ovale. This is the clivus, and the needle should be in front of that temporomandibular joint. In the radiofrequency ablation, there will be a separate radiofrequency ablation machine will be there. There are 2-3 types of machine, conventional methods and the cool radiofrequency ablation method. In that, the standard practice is in the patient will be the local anesthesia. Initially, we used to stimulate the sensory division, then the motor stimulation, and those stimulations should be appreciated over the face. Then after that, then lesioning will be there with the thermal energy, 60 degrees centigrade and 70 degrees centigrade, the maximum 70 degrees centigrade. Then comes the next procedure is the balloon compression. This is the more little bit painful procedure. So usually we used to do under general anesthesia. In the same needle technique, we used to pass the Fogarty number 4 number Fogarty catheter, and we used to inflate the balloon at the Meckel's cave. After the passing the needle, the balloon will be inflated at the Meckel's cave with the compression. Because of that mechanical compression, these trigeminal painful nerve roots will get damaged, and there will be relief of the trigeminal neuralgia. And the pain relief will be almost instantaneous in this percutaneous procedure, almost instantaneous in the radiofrequency ablation and the balloon compression. And the glycerol injection we are not practicing. This is the brief video from the internet. This is how balloon compression is done. The needle will be passed and the balloon will get inflated and the trigeminal ganglion. Final summary is how to select for surgery. Classical trigeminal neuralgia, when there is a vascular loop, the microvascular decompression will be the better option. And the secondary trigeminal neuralgia, when there is a tumor and the venous malformation, the microvascular decompression will be better. Usually, if the patient is risk for anesthesia, we select for percutaneous procedure, that is radiofrequency ablation. If the patient is young and fit, we go for microvascular decompression if there is a vascular loop. And we should encourage them to take heat therapies and stress reduction techniques and these things. This is the summary. The trigeminal neuralgia is a highly treatable condition. Medications are the first line treatment, and surgical and intervention for refractory cases. Thank you.
Any question? Any questions? Hello.
This is the place where I practice.
Thank you. Hello. Okay. Thank you, Dr. Jagdish. Thank you for the nice presentation. What's the cost difference between the three procedures like radiofrequency ablation, surgery, and
Cost, sir. Microvascular decompression usually under general anesthesia, so it will be around more than 1 lakh, like 1 lakh to 1 lakh, because it requires a lot of antibiotics and hospital stay, craniotomy, and all those things. So 1.5 like that. And the radiofrequency ablation, it can be done around 50,000 like that. Balloon compression also the same cost.
if there are no questions, we will close the session.
Yes.
And
Thank you.
Thank you, Dr. Jagdish.
A small memento by Ayub sir to Dr. Kirti sir for chairperson.
Okay.
Cell station of Dr. Jagadish sir by Dr. Kirti sir.
Right.
15 minutes break for lunch.
Kantite Shila Rajani 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 Sravute Brahmara 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 Vipate Chaja Suravana Dirira Vyakapara Dinisha
Achyutrao is my classmate and he is now running Apple Orthopedics Hospital Center, Kurnool. And he previously worked at Agraseni Hospital, consultant, and also at Medicover Hospitals, consultant, and Ayushman Hospital, Kurnool. He has done his post-graduation in orthopedics from Postgraduate Institute of Socio Pratistan Meerut, graduation from Kurnool Medical College, and his skills are arthroplasty, arthroscopy, trauma, limb lengthening, and mobile app designing. He has got awards of distraction neoangiogenesis in TAO paper, polar screws in nailing of the proximal metaphyseal tibial fracture, LCP, its role at present in fracture management. And his project is digitization in medical practice. Now I invite Achyutrao to carry on the session.
Good afternoon, everyone. After your lunch, I'm going to give you some very valuable things which all of you encounter. Sunil called me and asked me to deliver a lecture in IMA. Generally, we are used to do lectures or talks in orthopedic specialty conferences. Then I thought, what should I deliver? I practice at Kurnool. Kurnool, as you know, is a tier 2 city. We are in touch with the public and the full spectrum of the society, from basic person to a top end person. So in this context, I felt, no, I will not talk something like revision knee replacement. అలాంటివి ఏం మాట్లాడను. I'll be touching a very common topic which everybody of you seniors and also everybody sees in their OPD, at least one patient, that would be arthritis knee. I'll tell you the context what I pick up, the topic what I pick up, and what is the context. ఈ సొసైటీలో ఇప్పుడు మనం ఉన్న టైంలో the practice that we are doing, what is the context you are living in. And I see many of the senior doctors going for knee replacement. అంటే వాళ్ళు సొంతంగా knee replacement చేయించుకుంటుంటారు. When you were a doctor, when you had practiced medicine, why you could not find a solution for arthritis knee? Why did you go for a knee replacement? That is a context. That is a question we have to ask to ourselves. It is not that non-orthopedic guys. Many orthopedic surgeons, in fact, my boss was also operated by Dr. Ranawat. When I was a second year postgraduate, my boss, where I learned my orthopedics, was operated by. So the context is totally replacement the only definitive solution for osteoarthritis knee? If it is so, how many of us in this hall, say for example, there are some 50 people in this hall, after 60s, should we all be ready for a total knee replacement? What are the actual realities? This is 20th year of my practice. I might have done at least 2,000 total knee replacements. I'm basically a high-end arthroplasty surgeon. I myself would have done some 2,000 knee replacements. I regularly do revision knee replacements. That is, replacements done outside, gone, failed, and I revise them. We do limb lengthening, all complicated surgeries. But the simple question that we keep on asking ourselves is total knee replacement the only solution for osteoarthritis knee? we arrived at a conclusion that no, progression of early osteoarthritis knee can be stopped. Only that we are lacking in a concerted multimodal approach to this simple common disease, but misunderstood and not properly taught in our medical colleges, in our medical curriculum. In fact, I keep on telling to my daughter, she entered MBBS just, I keep on telling, yeah, your curriculum of MBBS is not complete. There are many things which we have not been taught. Functional medicine we were not taught. Nutrition we were not taught. Exercise physiology is not there in medical curriculum. But these are the very important and foundational subjects which are needed for a positive health. All of us depend on, again, non-medical guys talking about functional medicine. So I'll tell you the context. What are the realistic outcomes of, from my 20 years of experience as an arthroplasty surgeon, what are the realistic outcomes of total knee replacement? The success rate of total knee replacement is 85 to 90% at 2 years. That is 15 to 10 to 15% of the patients, however good, however best you give, are still nagging with pain. They have some or other problem, and 10 to 15% in the best of the centers, in the best of the hands, 10 to 15% of knee replacement still have a problem. There will be 10% residual pain. They cannot kneel down comfortably. And 20-year survival across the entire best centers is 20-year survival rate is at the best 70 to 80%. That is, if you are in your 60s and getting operated for total knee replacement, or you are suggesting for your patient, be prepared for a revision knee replacement at the age of 75, 80. You just imagine at 80, a patient has to be prepared for a very complicated revision knee replacement. Revision knee replacement is a complex surgery. And there is a complication rate of infection, DVT, PE, pulmonary embolism, and chronic pain. It is in this context in which we do our practice. And as of today, after 20 years of my arthroplasty practice, surgery is the last resort and not the first option for arthritis knee. This is, I can say, this is a sort of a study that we have conducted, and surgery, that is total knee replacement, should be the last resort or the last option that you give to your patient. I will take you through case scenario. It would be very easy for you to understand rather than a theoretical discussion. This is a case of, I'm not taking out my original patients because I don't want to cross their privacy. This is a patient, Miss Lakshmi. She is a teacher, aged 52 years. She is non-diabetic, morning stiffness of 20 minutes, difficulty with stair climbing and temple visits, and her BMI is marginally elevated. On examination, she has got grade 2 arthritis as per the X-ray. So at the age of 52, she has got grade 2 arthritis. Her C-reactive protein is elevated. That is, she has got mild inflammatory changes in her body. Now, for this patient in my OPD, I have two options that I can. One, either I keep on treating her symptomatically, referring her to physiotherapy and postponing it, and ultimately one day declaring that you need a knee replacement. The most common scenario as of today is this pathway. 95 to 98% of us still practice a symptomatic pathway for osteoarthritis knee. That is, a patient at 52 years presents to us with grade 2 arthritis, and we just try to address their symptoms in the form of NSAIDs or joint injections or a physiotherapy, and we are just postponing the goalpost, and approximately at around 60 we announce that no, your joint is worn off in spite of our good efforts and it is time for you to go for knee replacement. But since last 1 decade, we have repeatedly studied and questioned and refined our modalities and protocols. And as of today, we practice for a grade 1, grade 2 osteoarthritis knee. We follow a pathway called disease modifying pathway. That is a grade 2 arthritis, that is Miss Lakshmi who presented to me with grade 2 arthritis. I would like her to avoid going to grade 3. That is the one which is stricken off. We want to stay there at grade 2 or come down to grade 1. What is this pathway? This is called disease modifying pathway. So, ఇప్పుడు మనం majority follow అవుతున్న pathway symptomatic pathway. That is, we are just treating their symptoms and waiting for the fine day to declare a knee replacement or suggesting a knee replacement. So, I would request all of you to please start thinking in these lines called disease modifying pathway. You might have heard in rheumatoid arthritis, these are called disease modifying anti-rheumatic drugs. Similarly, there is a disease modifying pathway for osteoarthritis knee. What is the problem? Why majority of the clinicians are not able to follow this disease modifying or stop the progress of arthritis? Arthritis classically has been taught wrongly to us. You ask anybody, average clinician, they will tell you it is a wear and tear disease. It is because of overweight. It is because of weaker bones. No, it is not. It is a complex, vicious circle. If you see the diagram over there, it is a vicious circle that is initiated by joint overuse or malalignment or obesity, and in some cases it runs in families like it is genetic driven. These initiating factors trigger an inflammation, that is synovitis and cytokine release. The cartilage, the inflammatory triggering leads to cartilage breakdown and its breakdown products, and this initiates a vicious perpetual cycle that keeps on triggering the initiating factor and ultimately damages the whole knee and transfers into a grade 3 or grade 4. So, a simple initiating factor, if not properly addressed, is leading to chronic progressive disease and advanced stage of. So, what is the crux? The crux is we have to break this inflammatory cycle in osteoarthritis. This is the key in stopping. Second, the second problem in osteoarthritis knee is it is a heterogeneous problem. Osteoarthritis is not one variety of disease. We have to see osteoarthritis. There are actually 6 phenotypes. Of them, 2 are the most common. The most common ones are inflammatory type of osteoarthritis, which is seen in almost 30% of the patients. Second most common that we see nowadays is metabolic driven. There is a metabolic syndrome on the background, and it is in 30% of the patients. In up to 20 to 25% of the patients, it is mechanical driven. That is, there is mechanical malalignment that is going on. In fourth variety is a chronic pain where the X-ray appears to be almost good and normal, but still the patient is complaining. It is called a chronic pain variety. There is an inherent problem in bone, say for example osteopenia or osteoporosis, and minimal disease osteoarthritis seen in youngsters like 20 to 25 years of age amounts to 10. So, osteoarthritis is not a simple single diagnosis. Whenever osteoarthritis X-ray is seen or a patient is seen, there are 4 to 5 differential diagnoses that you have to think. Is it an inflammatory type? Is it a metabolic type? Is it a mechanical malalignment problem, or is it a chronic pain problem? So osteoarthritis knee should be thought as further as a differential diagnosis into all these phenotypes. So if you type the patient perfectly, accurate phenotyping and targeting to that particular phenotype, to that particular cause, will lead to a better outcome. Almost your results will become into 3. So a healthy knee joint, which is seen on the left side, if not properly addressed, eventually lands up into a fully worn out cartilage, contracted ligaments, and the bone showing all the secondary changes like subchondral remodeling and osteophytes. So it is, dear clinicians, it is in our hands, and it is in fact in your hands, because when you guys see it for the first time in your clinic, kindly take a message that this disease can be modified. It has to be modified. Don't just treat it symptomatically. So what are we every time calling it as disease modifying protocol? We call it in short term as DMOD. What is this DMOD protocol? Our number one principle is offload the joint immediately. Decrease the mechanical stress on it. Our second pillar is decrease the inflammation. Our third pillar is do a neuromuscular retraining. One of the most important factors in developing osteoarthritis is your muscles have lost the balance. Your muscles, which have been working properly up to 20 years, after 20 years have started misbalancing, misfiring. If we see in this hall, 90% of us will be having gluteus maximus and medius weakness. That is, our buttock muscles will be weaker. Our gluteus maximus and medius would be weaker. Our foot muscles would be weaker. So this is neuromuscular retraining is needed. That is the fourth pillar. The third pillar, and the fourth pillar is give it a chance to repair itself. Give the cartilage as much as you can in the given solutions available, a environment for itself for the cartilage and the subchondral bone to regenerate, to repair itself. So these are the 4 pillars on which this disease modifying protocol works. There are additional pillars as well. Like, for example, some of them will need psychological pain management. Some of them need an important underestimated point called sleep optimization, which triggers an inflammatory response. And finally, they need a lot of education that this is what you have to deal with. It is not a thing to escape or postpone. You have to deal it by lifestyle modification. So I'm trying to take you deeper into the disease modifying protocol. The disease modifying protocol principle number 1, as I said, is breaking the inflammatory cycle. Most commonly, most of you would be suggesting a diclofenac or a acyclofenac or some analgesic like etirocoxib. You can do it, but take care of their cardiac status and take care of their gastrointestinal. If preferably, restrict all the diclofenac and aceclofenac to only topical application, and preferably go for an naproxen or celecoxib based on their cardiac status. We can also supplement with omega-3 fatty acids, curcumin, and boswellia. All these 3 drugs have been very well proved that they decrease inflammation at least by 15 to 20%. So number 1 point in our clinic that we can do immediately is give safer analgesics to break the inflammatory cycle. What is the next thing that we are not doing? We are just restricting them to only analogies. No, there are many lot more things that the modern orthopedics offers you. One of the most important thing at our center which we use is class 4 laser. Class 4 laser acts miraculously and it helps to it acts locally, whereas all your analgesic acts systemically. This class 4 laser acts locally, and within 5 to 15 days, the local inflammation comes down, which is what we want. Second, shift them immediately onto Mediterranean diet. Now, across the globe, now it has been proved beyond doubt that this particular diet decreases the inflammation by 30 to 40%. Because this diet contains many polyphenols, which are almost like a COX-2 inhibitors. Excuse me, the battery is low. So one more step or one more word about inflammation and nutrition connection. This is very underrated and very much to be concentrated on. So a Mediterranean diet, which consists of mostly 5 to 7 servings of vegetables, olive oil, nuts and grains with fatty fish, poultry, that is the chicken, etc. And what is to be avoided is all the processed foods, excess sugars. So the most of our content should be omega-3, polyphenols, fiber and curcumin. All these things are very important for nutrition, and nutrition is as strong or more better than your diclofenac and isoclofenac if properly delivered and if properly understood. Okay. Next, coming to the next principle that I was talking about in disease modifying principles. Second is biomechanical load reduction. Most important in it is weight loss. You pick up any Cochrane library, you become any randomized control trial. The first and the foremost thing is weight reduction. 1 kg weight loss will decrease the weight of almost 4 kgs on your knee joint. A simple 1 kg weight loss will lead to 4 kg decrease on your knee joint. So just estimate about 5 kgs of weight loss. You are almost decreasing almost 80% of the load on your joint. Second, as I was telling, gluteus maximus and the gluteus medius strengthening. Third is offloading braces. I will explain you what it is. And third is simple gait retraining. There are some minor modifications in gait that have to be done to prevent excessive load, which I eventually will explain what are those simple tricks of modifying the gait. This is the offloading knee brace. Now it is accepted that this is useful in almost decreasing the compartmental pressure by 30 to 40%. What is the difference between the regular braces? You might all be seeing many regular braces like companies like Visco, Tynor, all we have been, but there are some specific offloading braces which offload the pressure on the medial compartment of the knee. The third principle in the disease modifying protocol is enhancing the repair capacity. Give a chance for the cartilage and the subchondral bone to come back. One of the most important new generation modality that we use at our center is ESWT. It is called extracorporeal shock wave therapy. Any urologist here would know ESWL. ESW is extracorporeal shock wave lithotripsy. The same technology has been transformed, the pressure and the frequency has been decreased. It is a patented technology of Starge, Germany. And what it does is, it has been proved beyond doubt that it helps in subchondral bone strengthening, it helps in muscular retraining, it helps in contracture relief, and it helps in recruiting of more cartilage precursors. There is a class 3B laser also that we use, which helps in which works on a principle called photobiomodulation. These things are the first line of enhancing the repair capacity. One more second, and which is upcoming and almost proven, is platelet-rich plasma. This is a second line of treatment that we give to encourage the healing capacity, and that is platelet-rich plasma, which has to be delivered in a proper technique. That is, a double centrifuge has to be used. Almost 1.2 million per microliter of platelets have to be there, and it has to be given at least 3 times in a weekly duration. If delivered, it has been proved because of its action on multiple tissues in the knee joint. For example, it acts on synovium, it acts on the cartilage, it acts on the subchondral bone. So that is the second line of enhancing the repair capacity. What is the fourth principle of disease modifying in early osteoarthritis? As I said, neuromuscular reprogramming. To keep it very simple, our muscles have started misfiring. There is weakness in few muscles. There is contracture in few muscles in all of us. For example, almost 80% of the adults at the age of 50 have a anterior hip capsular contracture. This is proven. And 80% of them have got gluteus maximus and medius weakness. So, what is most important and very crucial in this protocol is glute isolation, that is gluteus isolation training, proprioceptive exercises, and milestone-based progression. I'll explain you what they are. So I was telling there is a muscle imbalance that we are all developing. It acts like a chain. If you go to any physiotherapy clinic or any standard sheet of exercise, if you take the pharma companies that give you, they will concentrate more on quadriceps. Actually, the problem is not there. The problem is in the hip. Knee arthritis develops because of imbalance that starts in the hip. There is a gluteus maximus and medius imbalance. There is a foot muscle weakness, which are above and below the knee joint, and they are compounding, and the end result is what we see in the knee joint. So what happens when there is a weakness? There is a contracture in the anterior part of the hip capsule. There is an internal rotation of the femur. There is a slight valgus of the knee joint and increased pressure on the medial part of the knee. So this important imbalance has to be understood, addressed with very simple exercises which have to start from quadriceps stretching. It is not your quadriceps strength that you have to start. You have to start stretching the quadriceps, your piriformis muscle, your plantar fascia, and the calf. Then you start strengthening with quadriceps, the gluteus muscles through glute bridges. These are simple exercises and clamshell exercises. And you start also strengthening your foot muscles. The foot muscles are very simple exercises which strengthen the foot muscles. Also, one more important thing that we are very much impressed and proved, and we implement it, is Pilates. Pilates is a German form of, you call it a German form of yoga. It is a mechanized yoga. Pilates was, Dr. Joseph Pilates was the actual inventor of this, and it works superbly in strengthening your core muscles. So what I want to tell is, starting from your core muscles, that is your abdominal muscles and back muscles, right up to foot, you have to strengthen them in a coordinated fashion. The Pilates is one particular modality of exercise that will strengthen your body as a whole. It will not isolate your knee joint, hip joint. This will strengthen that's how we function. We do not isolatedly function, isn't it? That is why we have to practice some exercises which are very well coordinated and wholesome. These are called compounded exercises. Always prefer to do compounded exercises, which are natural method of strengthening your body. So now I am trying to summarize the exercise protocol that we follow. We follow a phased wise program which is limited and very keenly observed. And these are the phases of exercises that we take the patient through. Phase 1, it takes 2 weeks. Phase 2, it takes 3 to 6 weeks. Phase 3, it takes 7 to 18 weeks. And phase 4, I said it's lifelong. You have to do some maintenance, trivial, small exercises which will maintain. And you have addressed almost 40 to 50% of your knee problem if you follow these phases. It has been proved that at 18 weeks, the outcome is almost 70% of the pain is gone. What is the problem? We did not understand which muscle was imbalanced, which muscle was weak. I told you in the first few minutes of my talk, we were never trained in exercise physiology. After anatomy, physiology, and biochemistry, directly we landed up in microbiology. Where did we read modulation of the physiology? Where did we read? How did we take control of the physiology? We did not. It is time we read it again. How to take control of our physiology? How to take control of our anatomy? So, this particular patient or this particular disease can be taken into a second pathway, that is the DMARD pathway. And in the DMARD pathway, the end result is your grade 2 joint will not progress and the joint is preserved. So, for this particular example patient, her phenotype was a mechanical type of phenotype of osteoarthritis. Our pillars of treatment for biomechanical correction, targeted exercises, and weight optimization, along with some supporting. And at 1.5 years, there is 83% reduction in her pain, 62% functional improvement, and the X-ray is in the same grade 2. It did not progress further. This is what we want. This is called disease modifying. This has been silently going on in our hospitals and clinics. Now we have started studying all our results, because many of the times orthopedic surgeons, you listen us, what is the next step in total knee replacement? We would be talking about robotic knee replacement. We would be talking about high flexion knee replacement. We very few times we talk about how to prevent knee replacement. So we thought we should take up this task, and we found that this is in fact very fruitful. And if you give us your grade 2 patient, in 80 to 85% of them, we can prevent, in fact, a lifelong chance for knee replacement. We can avoid a knee replacement. So our study had many mixed phenotypes, and our best results were seen in inflammatory type of phenotype. So what is the take-home message that I am trying to give you? Don't try to treat it symptomatically. Don't try to postpone and ultimately one day announce that you need a knee replacement. Try to address it. And addressing it doesn't mean giving analgesics or a simple physiotherapy. It needs a multimodal approach. That's what I discussed, and I would be summarizing for you. Before I close down in the next 5-6 slides, I would try to there is a outgrowing epidemic of metabolic syndrome in our society, and this is one of the most important reason why we are seeing more amount of osteoarthritis. So in India, osteoarthritis knee is going to rise because our daily habits are leading us to metabolic syndrome, and our sleep is also deprivation of sleep is also contributing to the inflammatory type of osteoarthritis. And so basically nowadays the psychology for chronic pain has, the threshold has come down. Now patient asks immediately, please get rid of this pain. So immediately we try to jump to total knee replacement. All these, I'm trying to tell you the trend where the society is going. The medical practice and the society is going towards the society is walking towards inflammatory, metabolic syndrome. All these things are complicating and getting more osteoarthritis knee. So as a surgeon, I would keep you very clear indications of when to refer these patients to us for our total knee replacement. The absolute surgical indications are only grade 4 osteoarthritis knee. There is bone-on-bone deformity with greater than 20 degrees to 25 degrees of varus or valgus. There is a failed comprehensive treatment. You have tried almost for 12 plus months, 1.5 years, and still you are not improving at least 30%. In 1.5 years, if you have improved by 30 to 40%, persist with it. He is a patient for saving the joint. And there is severe instability or mechanical symptoms. We have to always see medicine from society perspective also, economic perspective also. What is the cost that we are putting as medical fraternity in this particular simple disease called osteoarthritis? In a case which can be treated with 30 to 40,000 of rupees, we are incurring on them 4 to 5 lakhs of money in the long term. And if you take it and compound it to entire India, it would be some crores of rupees being spent on a disease which can be easily controlled. At least 85% of them joints can be preserved. So I would like to summarize my talk. Tomorrow, that is Monday, when you start practicing in your centers and start, please shift from your old paradigm. The old paradigm has been the first answer you give to your patient is osteoarthritis is wear and tear. No, it is not wear and tear. It is wear and tear is a wrong word. Wear and tear is a disease where it only tears. It doesn't recover again. Like wear and tear of an engine, wear and tear. It's not a wear and tear disease. The tear is not permanent. It can be again regenerated. Nothing can be done until surgery. Please stop thinking about it in that way and start addressing. Every physician should know that early osteoarthritis can be stopped, and it is if intervened properly with a multimodal approach. So I would request every one of you. This was a talk specially prepared for cross specialities. My dear doctors of other fraternities, kindly, this is the message loud and clear from orthopedic surgeons and orthopedic fraternity. Osteoarthritis, 85% of the joints can be preserved and the disease can be stopped. Thank you.
Dr. Achyut Rao has spoken very common disease, that is osteoarthritis. Even in the floor, I think at least 10 to 50% people will have this problem. He has clearly told surgery is not the final. So this is only almost conservative treatment is more than the surgery. He has clearly expressed it. And now I request the audience any questions. This is a commonest problem.
I encourage questions, please, because now we are in a limited numbers. Let us have a free talk.
Mic floor mic
Sir, what is the effect of walking long kilometers, so many kilometers per day, and then taking stairs frequently
Ma'am,
without walking? Just
you have
questions, so many questions.
right, ma'am.
And weight bearing exercises.
Weight
Bearing.
bearing
Weightlifting.
exercise.
Weightlifting
Okay, weightlifting.
exercise.
Okay,
What
okay,
are the effects on those?
okay.
On knee joints and ankle.
Right, ma'am.
I want to.
Okay, I will address. You have asked a very, 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 very important question. Just before, while I was taking lunch, I talked to Sudhakar uncle. Sir, the medicine as of today is YouTube driven and hype driven, and the scientific discussion and scientific forum. He thanked me that you came all the way from Kurnool for this talk. I said, no, academics drives me anywhere. You keep in a small village, I will come. The 10,000 steps per day hype is a maverick and a stupid thing that is going on in our society. It was given by some Japanese doctor for something else, and that has become a. See, what is assured? What did we talk in the 4 principles? Mechanical overloading tagginchali. When you walk, there is a ground reaction force. For every step you take, there is opposite force and that goes and hits your knee joint. There are many people from top-notch society. Just last month, I was seeing from a correspondent of he runs engineering college, educational institutions. That is a very well-read guy. Has damaged his knee joint because he has practiced 10,000 steps for the last 3 years. The solution for this is you can walk 10,000 steps, but you prepare your knee joint for it. Is your knee joint prepared? That is your cartilage hard enough, your subchondral bone hard enough, your muscle in balance. If not, you should not walk. What you have to do, what I would suggest, buy a air bike, buy a cycle, static cycle. So do exercise which doesn't put a ground reaction force on your knee joint. There are 2 things, 2 exercises which we commonly suggest. One is swimming. Swimming is very difficult. We have to find a pool. The easiest simple thing is 8,000 rupees. You buy from Amazon, you buy an air bike and you ride it for half an hour every day for the next 1.5 years. Your cartilage and the subchondral bone and the ligaments and the muscles will develop fully. And you go for walking and start with 1,000 steps. Then 2nd, 3rd year, you go for 2,000 steps. The cycling, if you do it at 110 per minute, at a heart rate of 110 per minute, will do 4 times more benefit to you than walking. How? It is called zone 2 exercises. While walking, your heart rate at the max will reach up to 95 to 100. It cannot cross. If you take a definition of a exercise by definition has to be done at a higher heart rate. That is at 110. It is called zone 2 training. If you ask any athlete, any military person, what do you do every day? They will tell zone 2 training. They do not sprint every day. They do zone 2 training. If you do zone 2 training, your cartilage will improve. Your subchondral bone will improve. Your muscle will develop. Your intestinal fat, that is the peritoneal fat, visceral fat will come down. So for the pertinent answer, you do zone 2 training, that is cycling, static cycling for 1.5 years. Develop your cartilage strength and then go for walking. Weightlifting is needed, but in how much you can tolerate, how much it is needed, because it addresses the muscles. Now, as many clinicians know, the myth that diabetes is not curable is a myth. It is wrong. It is being proved wrong. Diabetes is fully curable disease. And the reason is mitochondrial dysfunction was the problem. and insulin resistance was the problem. So if you do a resistance training, that is the weightlifting that you do a dumbbells of 1 kg dumbbells, you can lift it and do both for your, and one of the big hype going on in the youngsters is go to a gym. If you go to a gym and see all the surrounding, they will be practicing for the upper body. Actually, you have the bulk of the muscles in the lower body. Your gluteus maximus, quadriceps, hamstrings are at least 4 times larger than your deltoid, biceps, etc. So what do we need? We need more number of active mitochondria, which will address our metabolic disease. So you have to do cycling. Second, you have to do lifting, but lifting for your lower half of the body and up to a weight which doesn't put pressure on your joints. Hope I addressed your question.
Okay, thank you, sir. Sir, Vajrasanas, some asanas, they're bending the knee too much.
Ma'am, that is again, you are loading the joint. If you are in a stage 1, stage 2 arthritis knee, don't load the joint. Our first principle tells unload the joint. You can load the joint and do Vajrasana. I see people at 72 years doing Vajrasana. They can do it because they have been practicing since 40, 50 years. And their joints, if you take an X-ray, their joints would be pristine. They'll be in stage 0. So they can do Vajrasana. You can also do Vajrasana maybe after 5 to 6 years when your joints become so good and healthy. It is about the strength of cartilage and the subchondral bone.
Thank you, sir.
Yes.
Thank you very much, sir. Thank you very much, sir. You gave a very good lecture, especially in a common topic now. So we have been suffering by so many people, not only enlightened and the common people also. Everybody is nowadays now with joint pains, what to do, what not to do, what are the precipitating factors and all that. So you explained in a better way. But now I want to ask 2 questions. One is getting upstairs and downstairs. Now everybody thinks, shall I go upstairs or not? Shall I stop it? Shall I go for walking? What about my weight? What about sitting this thing over in front of the God? That is keeping the 2 legs together. And one more is running or jogging and all. And as for the age also, everybody thinks after 40, no, they are getting early compared to those previous years. So what are the common things to avoid or not to precipitate for a common man, not only for medical? So enlighten 1 or 2 or 4 steps. That's my just carrying message to a common man,
right,
not for a medical man.
Right.
So kindly enlighten.
Sir, for the question of sitting down, squatting, Vajrasana, climbing stairs, 10,000 steps, everything can be done. But make sure that your cartilage is good, your subchondral bone is good, and your muscles are good. If it is not there, just postpone your program. Postpone it for 2 years. Develop all these things with multimodal approach. All them will come back. Say, for example, you are in grade 2, the cartilage is soft, it is friable under inflammatory attack. If you give an advice to the patient that no, you don't do it, at 40 years, if he doesn't do it, when else does he do it? He has to do it. He will do it. But after he recovers from this inflammatory damage of the joint, from the soft cartilage, from the friable subchondral bone, it will take 2 years, and after that he can.
Thank you, sir.
You can do it. I always suggest my patients to play golf, to go for love trips at the age of 65, 70.
What about
it is the age to enjoy.
using of Western toilet and Indian method of toilet? So many doubts for so many people.
Sir, actually, the Indian toilet is actually a good toilet.
Our system is different than those.
No, actually it is a very hygienic, very well done, very good toilet, but it puts pressure on the joints. Again, the answer is if your joints are good and then do it. Because you pick up any health specialist now, they are asking you to squat at least for 5 minutes per day, which we were doing in the toilet already. Our elders designed it that way,
These
which
are
was
the
more
powers.
hygienic.
Okay, so thank you. Thank you very much, sir. You gave very good advice for everybody. So kind of you. Thank you very much.
Now I welcome. I welcome. Give the.
అదే సార్ అది అయిన తర్వాత మన వాళ్ళు
ఇది లాస్ట్ కదా సెషన్
అదే సింపుల్
2 minutes.
So only one session is remaining. Till now we heard all the presentations from different people from different areas. Now we are going to hear the session of local IMA branch doctor. I wanted to introduce him. Let me introduce Dr. Sunil. He passed out MBBS from Kurnool Medical College, Kurnool, 1995 batch. He finished general medicine from Amin Medical College, Bijapur, Karnataka. Worked as assistant professor in Narayana Medical College, Nellore. Worked as specialty registrar in cardiology, NIMS, Hyderabad. Worked as research assistant in ACCORD clinical trial under Dr. Vivian Pontuya and fellowship in diabetology at Midwestry in Apollo Hospital. Now he is going to give talk on hypertension. Now I request I request Dr. Subramaniam to come on to the dais to chair this session.
ఏం సార్ సడన్ గా రన్నింగ్ ఉంది ఏదైనా నైట్ నాదొక నాది
Today my talk is on the latest hypertension guidelines by the American Heart Association. Definition and classification of the blood pressure: normal less than 120, systolic blood pressure, diastolic less than 80, elevated 120 to 129 and less than 80 millimeters Hg. Stage 1 hypertension 130 to 139 and 80 to 89 mm Hg. Stage 2 hypertension greater than 140 and greater than 90 millimeters.
In adults, BP should be categorized as normal, elevated, or stage 1 or stage 2 hypertension to prevent and treat the blood pressure. Best practices for accurate in-office blood pressure measurement: avoid caffeine, exercise, smoking for at least 30 minutes before the test. Use a BP device that has been validated for accuracy. Use the correct cuff size on a bare arm. The patient's arm should be supported at the heart level. That is important. Patient should be relaxed sitting in a chair, feet flat, legs uncrossed, back supported for at least 5 minutes. Neither patient nor clinician should talk during the rest or measurement. No use of phones. Take 2 or more BP measurements at least 1 minute apart. The BP measurement should be done in a temperature controlled room. When diagnosing and managing high blood pressure in adults, standardized methods are recommended for the accurate management, measurement, and documentation of in-office blood pressure. When measuring in-office blood pressure in adults, it is reasonable to use the oscillometric method with an automated device over the oscillatory method. Essential laboratory tests and diagnostic procedures. When hypertension is suspected or confirmed, laboratory and diagnostic procedures are a standard part of the evaluation. This information will provide a baseline and will inform the management decisions, including the need for additional testing. The test should be repeated at least annually to monitor for potential adverse effects of therapies, including the kidney disease progression and changes in the predicted cardiovascular disease risk. Class of recommendations for the blood tests to be done are routine diagnostic tests such as complete blood count, serum sodium, potassium, calcium, serum creatinine with estimation of the GFR, lipid profile, fasting blood glucose and HbA1c, thyroid stimulating hormone, urine analysis, and urine albumin to the creatinine ratio, urine protein to the creatinine ratio, and an ECG. From clinic to home, blood pressure monitoring. This is class of recommendation 1. In adults with suspected hypertension, out of office BP measurements by either ambulatory blood pressure monitoring or home blood pressure monitoring are recommended to confirm the diagnosis of the hypertension. In adults who are taking the antihypertensive medication, home blood pressure monitoring is recommended for monitoring the titration of the BP lowering medication, along with the co-interventions such as patient education, telehealth counseling, and clinical interventions. Hypertension causes from lifestyle to the genetics, dietary intake factors. Higher sodium intake is the main root cause for the hypertension in the dietary factor. Lower potassium intake, lower calcium magnesium intake, and lower diet quality, lower intake of fruits, vegetables, plant proteins, fiber. These should be in the high diet. Alcohol intake, non-dietary factors such as genetics variants, overweight, obesity is the main important factor. Lower physical activity, fitness, sleep disturbances related to the duration, quality, regularity, and disordered breathing, psychosocial stressors, and air pollution. White coat and masked hypertension. White coat hypertension, BP is high in the office setting and normal or elevated outside of the office setting. Masked hypertension, BP is high outside of the office setting and normal or elevated in the office setting. Ambulatory blood pressure monitoring is preferred for excluding white coat and masked hypertension among individuals not taking hypertensives. Adults with in-office BP greater than 160 by 100 millimeter Hg should be promptly started on antihypertensives. In office, BP greater than 160 by 100 should be promptly started. Studies have shown that individuals with white coat and masked hypertension compared to those with sustained normotension are more likely to have sustained hypertension on follow-up. These are the class of recommendations of 2A with recommendations: white coat and masked hypertension with adults with untreated office systolic blood pressure greater than 130, diastolic greater than 80, and without office systolic blood pressure greater than 160 and diastolic greater than 100 millimeters Hg, it is reasonable to exclude white coat hypertension. In adults with white coat hypertension, out of the office BP monitoring is reasonable to exclude transition to a diagnosis of sustained hypertension. In adults with apparent treatment resistant hypertension on office BP, it's reasonable to exclude white coat effect. It's a form of pseudo resistance. In adults who are taking antihypertensive medication and have elevated office blood pressure greater than 130 or diastolic greater than 80, but do not have resistant hypertension, then the values are greater than 160, diastolic greater than 100, it is reasonable to exclude white coat effect. Secondary forms of hypertension. Does the patient has any of the following conditions you should rule out? Drug-resistant induced hypertension, abrupt onset of the hypertension, onset of hypertension at less than 30 years, exacerbation of previously controlled hypertension, disproportionate target organ damage for the degree of hypertension, and whether the patient has any accelerated or malignant hypertension. Onset of diastolic hypertension in older adults, age greater than 65 years, unprovoked or excessive hypokalemia, insomnia or daytime sleepiness, concomitant adrenal nodule, history of early onset stroke, family history of primary aldosteronism. If all these are present, then you should screen for primary aldosteronism, that is, and other secondary forms of hypertension. If positive, then you should refer to the clinician with specific secondary hypertension exercise. If not, screening not indicated. Class 1 weight loss goal is greater than, weight loss goal should be greater than 5%. Main diet with or without hypertension. There is a dietary approach to stop the hypertension. Mainly dietary approach is intake of sodium should be less and potassium should be more. Class 1, sodium intake should be less than 1.5 gram per day. Class 2A substitutes potassium based such as fruits. Class 1, moderate dietary potassium intake in bananas, it will be there. Alcohol. Class 1 is alcohol abstinence or less than 1 drink per day. Monitor potassium in those at risk for hyperkalemia. Exercise and stress with or without. Class 1 is structured exercise program. Follow the aerobics. Class 2B is stress reduction like meditation and yoga, doing meditation and yoga. Use of risk-based thresholds for initiation of the BP treatment. Does the patient have an average BP greater than 140 by 90 millimeters Hg? Initiate antihypertensive medications to lower the BP and reduce the cardiovascular risk for prevention of the cardiovascular disease risk. If not, that the patient has have existing clinical cardiovascular disease, coronary heart disease, stroke, heart failure. If yes, then initiate antihypertensive medications. Does the patient have, we should rule out whether the patient have any diabetes or chronic kidney disease, or is that the patient at increased short-term risk of cardiovascular disease. If yes, you should initiate antihypertensive medications. If no, if initiate antihypertensive medications, if average blood pressure is greater than 130, diastolic greater than 80 millimeters Hg. Initial medication selection for the treatment of the primary hypertension. Always start on a thiazide diuretic and calcium channel blockers and angiotensin converting enzyme inhibitors only after ruling out the initial I told the renal function test. That is, the serum creatinine should be checked before starting these medications. Stage 1 hypertension. This is the stage 1 hypertension. Only single first line agent is reasonable. That is, the single first line reagent is, as I told previously, thiazide diuretic calcium channel blocker, and angiotensin converting enzyme inhibitors. Stage 2 hypertension, that is greater than 140, greater than 90, then 2 first-line agents of different classes. Ideally speaking, in a single pill, combination of drugs is better to improve the adherence for the patient. Any stage hypertension, it's very harmful if you combine both AC inhibitor and ARBs. Anti-hypertension medication adherence strategies. Single pill combination is better, that is class 1 recommendation. These are class 2 interventions. Once daily dosing, class 1 recommendation. Blood pressure goals for patients with hypertension. 10-year atherosclerotic cardiovascular risk is greater than 7.5% using PREVENT. Preventing is the predicting the risk of the cardiovascular disease events. If no, blood pressure should be monitored, which should be controlled less than 130 and less than 80 millimeters Hg. Take home point, hypertension management with diabetes mellitus. BP goal should be antihypertensive medications if it is greater than 130 and greater than 80. Initial management, thiazide type diuretics, calcium channel blockers, ACE inhibitors, and angiotensin receptor blockers. Special considerations when it is chronic kidney disease, if EGFR is less than 60 ml per minute, when there is severe albuminuria, use of ACE inhibitors and angiotensin receptor blockers are recommended because these can delay the progression of diabetes mellitus related kidney disease. This is the recommendations class 2B and class 2B with hypertension, overweight and obesity and metabolic syndrome. These are the indications. Prevention of heart failure in adults with hypertension. This should be less than 130, less than 80 to prevent the progression of the heart failure. For patients with chronic kidney disease, SPP goal should be less than 130 millimeters Hg to decrease the mortality. Intracerebral hemorrhage, if blood pressure is 135 to 150 to 220 millimeters Hg, immediately lower the SBP to 130 to less than for at least 7 days after intracerebral hemorrhage. But stop medications if SBP is less than 130. Titration of the SBP blood pressure, smooth, non-labile, avoid peaks, range and variability. If the systolic blood pressure is greater than 220 millimeters Hg, it should not be lowered immediately. Why? Because it causes adverse events. Plan of care for adults with uncontrolled hypertension. This is the plan of the care. This is the plan of care for adults with uncontrolled hypertension. Hypertension and pregnancy. Individuals with hypertension who are planning a pregnancy or become pregnant, labetalol and extended release nifedipine are preferred to minimize the fetal risk and treat hypertension. And the patient should be counseled about the benefits of low dose aspirin to reduce the risk of preeclampsia and its sequelae. Should not be treated with, in pregnant, it should not be treated with atenolol, AC inhibitors, ARBs, direct renin inhibitors, nitroprusside and mineralocorticoid receptor antagonists to avoid the fetal harm. Pregnant individuals with SBP greater than 160, greater than 110, confirmed on repeat measurements within 15 minutes, lower BP less than to prevent the adverse events. Diagnostic criteria for preeclampsia, if systolic blood pressure greater than 140, diastolic greater than 90, on 2 occasions 4 hours apart, greater than 20 weeks gestation in a woman with previously normal blood pressure. Systolic blood pressure greater than 160, diastolic greater than 110 confirmed over 15 minutes. And blood pressure and proteinuria should be present. Other criteria are any of the platelet count reduced less than 100,000, reduced kidney functions, impaired liver function, pulmonary edema, new onset. These are the criteria for the pre-eclampsia. Management of the resistant hypertension, office BP greater than 130 by 80 on 3 antihypertensives, office BP less than 130 by 80 but requires greater than 4 antihypertensive, work up and address the potential causes. That is, first you should exclude the pseudo-resistance by these methods and review and remove the interfering medications and screen for the secondary causes such as primary aldosteronism, obstructive sleep apnea, renal parenchymal disease and renovascular disease. If any of these are present, these are the contraindications or intolerant of the MRA. You should add mineralocorticoid receptor antagonists like aldactone if patients with uncontrolled resistant hypertension despite optimal treatment with first-line antihypertensive therapy. It is reasonable to control, and if any patients are intolerant of MRA, that is aldactone, then you should add these things: amyloid beta blocker, alpha blocker, and central sympatholytic drug like clonidine, dual antithyrin receptor antagonists, direct vasodilators. These are the surgical methods such as renal denervation. It's a therapy, but be reasonable adjunct treatment to the meds and lifestyle medications to reduce BP in those with resistant hypertension. This is the orthostatic hypotension. In adults with hypertension, improved BP control is recommended to reduce the risk for orthostatic hypotension. In adults receiving intensive BP lowering therapy with asymptomatic ortho treatment with a goal of SBP less than 130 millimeters Hg is reasonable due to increased cardiovascular risks and mortality benefit. In adults with hypertension, initiating treatment or adding medication with a goal of SBP less than 130 millimeters Hg, assessment for symptomatic orthostatic hypotension is reasonable to detect other chronic conditions. In case of severe hypertension and hypertensive emergencies, any acute target organ damage is there, you should see. If there is any target organ damage, you should admit to the hypertensive emergency, admit to the ICU. This is the class 1 recommendation. If there is any aortic dissection and pheochromocytoma crisis, you should reduce the systolic blood pressure like this in this case. If not, reduce SBP by 25% in the first hour and to less than 160 by 100 over the next 6 hours. If not, severe hypertension, then evaluate inpatient versus OPT in the outpatient. Mainly avoid parenteral BP lowering medication therapy or intensified over therapy in the acute setting. It is very harmful. Identify in the outpatient setting, no need to refer to the emergency department. If you can follow up in the OPT setting in 4 weeks. Patients scheduled for surgical procedures. These are the patients who are planned for major surgery to minimize the perioperative complications. In patients on chronic beta blockers, continue beta blocker throughout the perioperative period. Abrupt discontinuation of the chronic beta blocker therapy is not recommended. Beta blocker therapy should not be started on the day of surgery in beta blocker naive patients. Abrupt discontinuation of chronic clonidine therapy is not recommended. Preoperative discontinuation may reduce the risk of perioperative hypertension. These are the evidence gaps and future directions. Research to improve screening and implementation strategies for BP control, BP targets and long-term benefits in the younger adults. These are the evidence gaps and the future directions for the blood pressure monitoring, optimal management of the pregnant patients, identify alternative and accurate methods to measure BP, understand genetic and epigenetic risk factors for the hypertension. Thank you. Thank you.
We had elaborative discussion of hypertension by Dr. Sunil now. Now, I would like to give memento to the
పిల్లలు ఏదైనా పిల్లలు
రాజు
I request సార్ ఫోటో అయిపోయింది కాదనా అన్న ఫోటో అయిపోయింది కూర్చుందామా ఫోటో అయిపోయింది కూర్చుందామా
చైర్లేం వద్దు చైర్ అప్పుడు తీసు ఇది అందరూ ఇట్లా రాదు మనము మండపంలో తీసిన ఫోటో ఉంది కదా అది చాలు అది పెట్టండి అట్లా కావాలి తీసుకోండి అందరూ లేడీస్ ఎంత ఒకటి తీసుకోండి వాళ్ళు తీసుకోండి ముందు సో వన్స్ అగైన్ థ్యాంక్స్ ఫర్ గివింగ్ మీ సపోర్ట్ ఫైనాన్షియల్లీ అండ్ ఫిజికల్లీ సో వెల్ ఆర్గనైజ్డ్ చైర్లు వద్దులే వాళ్ళని తీసే ఒకసారి సరే తీసుకుని
మీరు ఆర్గనైజ్ చేసి తీసుకోండి లేడీస్ అంతా ఒక ఫోటో అంట
నేను చెప్తున్నా మీకు స్పెషల్ గా మనకు కాదు ఇది ఐఎంఏ రాజంపేట ఫోటో ఉంటే అదే అందుకని తీసుకోండి
రాజంపేట రాజు ఎవరండి I thank all the IMA family for sir. Sir, I thank all the Rajampeta family and financial team. Sir, sir. Sir, sir. Financial team, scientific team, especially they took lot of pains sitting from yesterday, and registration committee, reception committee, audiovisual committee, all the cultural committee, and the outset, I would thank the AV team, Vamshi and his team, and food department, Mr. Shekhar, and all the members of IMA Rajampeta for extending their wholehearted support financially and morally. And I thank our organizing secretary and our co-chairmen for guiding us in right path.